Good morning, everyone. The formula race is over, however. The scientific pace is still ongoing here, so please stay tuned. Welcome to day 3 of the first KFMRC conference, where today's session will focus on neurosciences and chronic diseases. It is my great pleasure to introduce the moderators of our first session today. Dr. Faisal Al-Asani is an assistant professor at the Department of Medical Physiology, Faculty of Medicine. In 2014, he graduated from Maastricht University, working as a physician for 2 years in KSA. In 2018, Dr. Faisal was awarded a scholarship from King Abdulaziz University to pursue his doctorate degree at the neurosurgical department of Maastricht University. His dedication to learning, teaching, and research has shaped his journey. Please join me to welcome Dr. Faisal. I'm truly... Yeah.
Keynote and the
Yes. I'm honored to introduce also Professor Chaudhary, Professor of Human Molecular Biology at Medical Laboratory Technology Department. He held many positions throughout his career, including the first dean of Postgraduate Institute of Genomic Medicine Sciences at KAU. He is the director of the Center of Innovation in Personalized Medicine. He is a founding member of Diagnostic Genomic Unit. He published more than 180 journals, review articles, and original articles. He's a principal investigator and co-investigator on several projects. He played a key role in establishing the foundation of applied genomic research in Western Saudi Arabia. Please join me to welcome Professor.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. Dear audience, we would like to start our first session for today by inviting our honorable keynote speaker, Dr. Abdurrahman Sabbar. On behalf of the organizers, I would like to thank him for accepting this invitation. Dr. Sabbar is an associate professor of neurosurgery at the King Abdulaziz University. He is also Associate Executive Director of Training at the Saudi Commission for Health Specialties. He also served as a former head of Neurosurgery Scientific Council at the Saudi Commission for Health Specialties. He was Neurosurgery Program Director at 3 major institutions. He co-authored 5 international neurosurgery textbooks and was awarded the prestigious American Publishers Professional and Scholarly Excellence Prosser Award for Best Medical Textbook, and his other book on neurosurgery reached record sales on Amazon. He has contributed to over 80 publications with a substantial focus on medical education, surgical skill training, epilepsy surgery, and the use of artificial intelligence in neurosurgery training. Ladies and gentlemen, please welcome Dr. Abdurrahman Sabbar.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's a great honor to be among this amazing audience, and it's kind of intimidating to speak amongst the elites of knowledge in neurosciences and medical sciences in our institution. Bismillah ar-Rahman ar-Rahim, wa-salatu wa-salamu ala Al-Shek Musaleen. I really like to thank the organizing committee, the scientific committee, for inviting me for this prestigious conference. Here I'm going to talk about the future horizons of neurosurgical training, from the apprenticeship model to AI and simulation. I'd like to start with this hadith وهو من عبد الله بن عمرو رضي الله عنه أن الرسول صلى الله عليه وسلم قال: من تطبب ولا يعلم منه طب فهو ضامن. What does that mean? It means that we as physicians, we have to know what we're doing. We have to know from the explicit to the tacit knowledge to all of these things have to be really integrated in our behaviors, in our management of patients, in order to manage our patients in the most rightful way, and in the way that we as physicians or surgeons نقابل ربنا يوم القيامة إن إحنا عملنا الشيء اللي فعلا مطلوب مننا بما يرضيه. And if not just us as physicians, our teachers, or us as teaching physicians of the future generation, I think برضو جزء من اللود نقع علينا. What we're looking at today, I'm talking about surgical skill training, which is a really difficult task. You can teach someone a textbook of how to ride a bicycle, but there's no way that reading about riding a bicycle is really going to teach you how to ride a bicycle. Riding a bicycle is one of those basic knowledge that will be automatic in your brain without really knowing what you're doing. It's just it becomes your automatic skill. So how do we take our students and make them surgeons eventually? This is a learning curve. How do we make sure that we try to make the training period faster in order to have our surgeons become experts in a shorter time, in order for them to be able to cover or in their lifespan, or let's say their career span, will be able to serve as many patients as humanly possible. And let me go back in time, and this is one of my role models in life, Al-Qasim al-Zahrawi. Al-Qasim al-Zahrawi more than 1,000 years ago, and I encourage you to read his book if you can. He wrote the first actual treatise on surgery. It's the 30th treatise. It's called التأليف لمن عجز عن الطريقة. التأليف لمن عجز عن التصريف من عجز عن التأليف. Sorry for that. And he has it's a 30-volume book, and the final volume, which is the one on surgery, I started reading it in Arabic, and it was a big conundrum for me. So I had to find a translation. This is in 1973. Where I was able to, went through it, and it's really impressive. And it starts by the first word in the book. He says, Ya bani, in the plural form. He talks to his students as his sons. And he really goes, in detail about medical ethics and how we have to be knowledgeable about anatomy and knowledgeable about history of expertise in medicine and surgery. You have to know. And I'll give you, for example, he must be trained in anatomy, knowing your vessels, your bone, and structures. He explicitly says that. And he talks about the unskilled is bound to fail into error. He talks about learning through mentorship, not just imitation. Hands must be trained before the blade. Apprenticeship as a moral obligation. He explicitly says these things in his book. And he says operation without fear and danger is no good. And you have to, he says stuff like, if you fear, then leave it alone. And I always remember this as a surgeon. Just, a few days ago, I was, operating on a part of the tumor that was stuck to the, sinus. I was pulling it and pulling it. It starts bleeding. I want to, I give a complete resection, but then I remember, I don't want to hurt this patient. If I worry that I'm going to hurt this patient, then I stop. And to avoid procedures beyond your skill, don't treat mischievous maladies. That's what he talks about. And the patient's life is more important than the physician's pride. These are beautiful things that he talks about as a surgeon, talking about 1,000 years ago. And I have to, what did he invent? For the surgeons amongst us, catgut, or the absorbable stitches. Well, Al-Qasim al-Zahrawi. And I think every time that the absorbable stitch is being used, inshallah, في الكتاب a very important teacher of medicine, of the modern medicine that we know today, 100 years ago, or 150 years ago, William Halsted, he's the one that came about to say, see one, do one, teach one. Of course, it's not a surgical or a medical term. He took it from the educational literature. But it's essentially old mantra. It's is it enough for today? And I can tell you, Andre Olivier, Haytham would know him. He told me this is not. I was doing a reflexes for a patient. He says, this is not how you do it. And he says it, explained it. You raise your hand, put your arm. I couldn't understand what he was talking about. Then he told me, listen, you put the patient like this. You put his arms to the front, tap the hammer like that, and he taught me that. And he said, you have to. You don't know what just happened. So what do you mean? You just taught me how to do reflexes in your way. He said, no, I learned it from Thomas. Okay, and Thomas learned it from Coma, from France. I said, okay, I don't know who these people are. He said, no, and Coma learned it from Babinski. So now you carry the knowledge of Babinski, which all of medical school students will know that Babinski sign is for upper motor neuron. But this is it's a kind of mentorship. So can we train without patients? We don't want to. What we do now is, as I was doing yesterday, I was teaching a resident how to do with me. We're doing this 2 days ago, a meningioma at the Conference of Sinuses. It's very, very difficult. And I know if he puts a little more effort, he can cause bleeding. So I push him away and I do it. And it's kind of the teaching, surgery sometimes is critical. And you can ask any surgeon, did you have a complication because of a training? We'd like to say no, but it does happen at some point, and hopefully it doesn't. So we want to teach surgery in the most risk-free environment as possible. So is it man versus machine, or their partners? So here I'm talking about education through artificial intelligence. These are questions that I'm going to answer throughout my talk. Do you need a mentor, or do you need a machine to teach you how to do what you have to do? Is it a competition or collaboration? And I think it's both in all the questions. In the past, a master, and not just the past, the current situation, master and apprenticeship tradition, this is what we do. Currently, virtual reality simulators and AI tools are available. Maybe not in neurosurgery. We'll see it in general surgery, ophthalmology. We see it a lot in the anesthesia, emergency medicine. These are areas that use AI so much. We have to focus not just on skill, but also safety of both the patient as well as the operator or the surgeon. So, see one, do one, teach one. In the operating room on real patients, we have this, and eventually you need this because tacit knowledge will only be transferred through doing the procedure on the patient. And I mean tacit knowledge is the knowledge that is not explicit, it's implicit. It's the knowledge that you gain, for example, how you ride a bike. For example, if I tell all of you where is the S button on a computer, you'll probably have to think about it. But if you put your hands, your fingers will know where the S button is. This is tacit knowledge. So what are the strengths of apprenticeship? Real cases, real stakes. The hands-on tissue feedback, until today, we're not able to imitate it to simulate it in simulators as realistic as possible. The mentorship, it also gives the professional identity. It builds clinical judgment. But the problems of apprenticeship, especially as time goes by, limited operating time, the duty hour caps. We used to do calls, endless on calls, and I had some of our friends have car accidents because they were sleepy. We know that some people died just because they were too tired to when they're driving home. So we came up with duty hour restrictions and all this, and this affected how much exposure we have to the operating room for our trainees. Fewer cases, complex pathologies, and patient safety pressures are letting us try to shy away from letting the residents do more and more in the operating room. And there are no real objective metrics. You're not able to measure how good a trainee is in the operating room just by looking at them. So in simulation, now, as you know, until today, for example, neurosurgical simulation is there, but it's not as powerful enough to be used as a training tool. Still being used as a research tool. It's a risk-free environment. It's repeatable scenarios. You can do it unlimitedly, as limited as by your time, and you can train beyond the operating room constraints. This is me and Hassam Al-Jihani, the former and the current head of the Neurosurgical Scientific Council. We crashed this 777 on a simulator. But in reality, this is, on the top left, you can see the simulator. Just very close here at the Prince Sultan Aviation City. And it's extremely realistic. When we're flying, we flew above Jeddah, I can see my home. It's great. And we're landing the airplane, we crashed it. It's really scary. Unfortunately, we don't have the same realism in medicine simulation as we have in aviation simulation. And it's interesting how we're able to say that the world pays billions of dollars to develop these simulators, but they're not able to pay the same, not even a fraction of that in medicine simulation, because this costs money. But for some reason, we're not able to realize that human life also means money. So unfortunately, and I spent 1 year of my life as a visiting scientist at the National Research Council in Canada to try to develop simulation and talk about it. And it was very difficult to get anything done because there's not much money to be spent. And I remember when I was working on that, the movie Avatar came out. And all we're trying to do is very similar, using similar technology. The movie Avatar spent around $200 million. And all the work that we were doing between the collaboration of King Fahd Medical City as well as the National Research Council was about $2 million. And we're not able to achieve as much as we want. This is an example of a surgical error. This was a trainee being trained by the staff, and they were doing an epilepsy surgery. Haytham is here, and as you see, Haytham will realize that where's the pointer? Okay, I don't know if it's clear. You see this is the temporal lobe being dissected, and then he told them, you should take out the amygdala and hippocampus. So he took out what he thought was the amygdala and hippocampus. He took out a part of the brain. This child became paralyzed for life. And this is a North American institution, one of the world's top leading institutions. It's not some small institution. So this is why we have to develop simulators. We can't really rely on just apprenticeship model. And I don't want to scare you because we do train our trainees. It's almost never having complications just because of training, but it does happen. And that complication was caused by the surgeon being confused because the trainee had thought that this is the amygdala. So as a total, we have to have a better way to train, not just that. So the publications in VR, and I apologize because I did it on the Mac, brought it here, so some of the slides got confused. Anyway, so as you see, there's so much publications on VR simulation for neurosurgery. It was almost zero, and then it was climbed up to hundreds in 2024. And if you look at how much the impact, the Saudi versus world, we represent about 5% of the publications in simulation worldwide. So we do have an impact in Saudi Arabia. And not going to go through that, but again, the target population is mainly the surgeons and the training in simulation. So much is written, but mainly what we're looking at, the current applications and research that's going on for simulation is on these 5 simulators, and unfortunately, most of them are collecting dust internationally. Collecting dust, but they're just there for research. Trainees don't want to use them. We pull them, in Cambridge University, just because we have the 2 simulators. We pull our trainees, stand with them, they start working with them, and they just leave it because the level of realism is not as high, and the maintenance and all this is an issue. But NeuroVR, immersive touch, spinal simulator, search train, Upsurgeon, These are all the technologies that are available. I'm not going to change the difference. This is the one that we have at KFMRC University. This is the part that we helped develop with King Fahd Medical City as a joint project, and it's there. This is a preliminary model where here Fahd Atabi is doing a resection of a brain tumor. It's a simulated, a very simplistic kind of brain tumor. The simulator in his hand feels a little, haptic feedback. You can feel that there's some pressure on the brain. And you see, these are the tools in his hand. They're similar to the tools that we use under the microscope. Fahd is now the head of the Neuroscience Institute at KFMRC Medical City. And he developed what we call the Najd metrics. Basically, metrics to measure expertise. This is one of the very first papers to look at that. Jamal al-Zahrani had developed ways to benchmark people, how good people are, and how we as surgeons be able to train our trainees to reach the level of expertise. We tried also the group between us and McGill at that point, and to get surgeons to wear, heart rate monitors, ECG, and sweat monitors to try to look at levels of stress during these cases. Khalid al-Majnaid looked at the impact of stress on psychomotor bimanual performance during tumor resection tasks, and eventually we started using artificial intelligence to understand the electroencephalographic changes in the surgeons as they're doing these tasks. But at that point, we felt that simulation that we have is very simplistic. And here was my task. I spent 1 year at the National Research Council to try to develop more complex kind of simulations. This is me trying to convince Dr. Maestro that we should be able to use the existing technology to create more complex models. Here I'm trying to draw the temporal lobe in this finite model simulator to hopefully be able to simulate all the tasks of the temporal lobe resection, inspired by that major problem that you saw. So basically, we have to draw the model, see the time-lapse video, just to try to explain to the engineers what the simulation model should show, and basically how to make it look real in the static mode as well as the kinetic mode. Going through the developing, it took a lot of work, and about 6 months of work to try to get the real brain. And this was work on cow brains to try to see how much pressure you will feel when you're touching the cow brain at different parts of the brain to give the realistic haptic feedback, and eventually use real brains during surgeries. You take the temporal lobe, for example, and you do the tensometer to understand how much pressure to apply. And eventually that was transferred onto the simulator that we have. And this is just a brain tumor to compare an expert neurosurgeon on the top left with a medical student on the bottom right. The redness is how much pressure the students are applying compared to their expert surgeons. And as you see, blue is less pressure, red is high pressure. Because one of the projects, we got students to play with the simulators, and they were able to do a better job than the surgeons. But we used the wrong metrics because what we wanted, how much resection you're doing for the tumor. But realistically, when we looked at how much haptic feedback, how much pressure they're putting on their tools, we realized that students are putting a lot of pressure and hurting the surrounding brain compared to an expert neurosurgeon. Then we developed a roadmap to develop because no one has ever developed these complex scenarios and all that. There's no real cookbook, and I had to go to the NCA, basically the ones that developed the CAE. The CAE developed the simulators for airplanes. And we tried through the National Research Council of Canada to communicate with them, to give us some of their know-how. They said it's all trade secrets. You don't care about humanity. It's just go find your own way. So I developed the roadmap to developing complex virtual reality simulation, and this was well cited afterwards too. So this is the final simulator that we have now, and these are the haptic. So the haptic handles are better now. And this is a resection of a complex tumor at the motor strip. That's the Rolandic vein, and I will intentionally cause a little bit of a hemorrhage. You see on the two sides, these are measurements of how much pressure and how much feedback, how much suction I'm using. So it looks like realistic brain. It feels kind of realistic when you're holding the hands. How much time do I have? I don't have a time. Sorry? Great. So here, this paper was aimed at developing a virtual reality simulation tutor. So it's a coach that will coach the trainee during the surgery to tell him or her whether, and it's usually not realistic, not real time, and after the surgery has finished, it will tell the trainee where his do's and don'ts and where he should have been better. And we compared it to actually coaching. And actually, this should work. Can you run the videos, please? Can you run the video? Okay. So basically, here is the remember the model that I drew with hand and then the stop motion video. So this is the preliminary one. So we use a simplistic model, and then we use the actual model. It's not working. So it doesn't matter. Yeah, just go to play. Yeah. Press play, yes. It's not working. It doesn't matter. So basically, it gives the participant feedback according to what he's done in the surgery. This was a randomized controlled trial, and the result basically is very similar, but somehow there's a trend towards the artificial intelligence coach catches things that the coach will not get, the instructor will not get. These are some of the students that actually got a master's in simulation through the years. Actually, Cambridge University, there's the bottom three, the bottom two, and Khalid Rajneeb is Jamaat Jeddah, Jamaat al-Qura, al-Baghdadi, Fahad and Jama'an, Peter Medical City, and there are a few more. So it's a skill, it's a safe skills rehearsal. There's no patient harm. The objective performance metrics that we develop together are able to tell us how surgeons are performing, how the candidates are performing, and there's a possibility of feedback and coaching, and hopefully it will accelerate the learning curve. Let me go through. I don't want to invest so much time on this. We talked about the AI tutor, and it can give us real-time feedback, guidance. You can track the tool path, the forces, the timing, and flag errors for risky moves, and adapt to the personalizing our training. The problem is with our training system or schools, for example, is one size fits all. But what we want is to do a personalization of our training. And hopefully with AI, this will be the thing that we can. So AI and VR, what that shows that there's a reliability of to assist skill in terms of time, motion, and forces. It fills the gaps where human evaluations are limited. It addresses instruction shortage and cost, and hopefully will enhance the efficacy of our training. We talked about the training, this project. And here's something that we at King Abdulaziz University Hospital are addressing that was not addressed before, is looking at the surgeon safety. About 7 to 8% of all neurosurgeons will get a musculoskeletal injury or a disc herniation just because of the ways we stand in our cases. And let me show you, these are different. So musculoskeletal injuries, psychosocial stress, radiation exposure, communicable diseases, sharp injury, transmission of bloodborne pathologies. I decided to focus on the first one, and eventually also the second one. So the problem is long surgeries, awkward postures, and I don't know how many of you have been in the operating room looking at how the neurosurgeons work. We really work in very awkward positions, and I'm sure some of them reach social media, and I don't go there. But high rate of neck and back injury, the fatigue affects performance and career, and these are often ignored in training. So I'm one of those people that was, that likes to tell my trainee, when they stand in front of me, and you'll see some pictures, I will bang them on the head with my head. So don't do that, try to stand straight and take care of your neck. Look at that. What kind of pain he's gonna have if he's doing this, 10 times a day, removing stitches from patients, right? Look at the way, it's basically a right angle. Look at the way the surgeon on the left side compared to the surgeon on the right side. This is how we stand. Many of us stand. Most of us in the middle of the case and at the end of the case will have bad pain. Now, I know, 3 of my friends developed cervical disc herniation during the residency. Before he becomes a consultant surgeon, he already had surgery on his neck. So 80% of surgeons will have some kind of musculoskeletal pain during surgery because of after surgery. And in OB, it's even worse. So here we try to look at what we call operating room ergonomics. Ergonomics is not looked at in surgery, unfortunately, and this is something that's coming up. And we decided, why don't we develop a simulator for that? Hind al-Sharif was a PhD student with us and with Dr. Wadih Halabi, and basically published her work. And as you see, we developed this simulator. Basically, the surgeon or the candidate is doing the surgery, and we're not really looking at the surgery. We're looking at his position. She or he, they don't know that we're following their neck movement because the oculus and the joystick, you can infer the angles of the shoulder, the elbow, the posture of the neck, comparing the body to the goggles. And at the end, we're able to, look at differences between young and more junior and senior surgeons. This is the PhD that Hind had obtained. And basically, poor ergonomics means surgeon's failure and error. Early focus on ergonomics, hopefully fewer injuries, and hopefully mental, physical stamina improves and happier, longer careers, less burnout. I know a few of my colleagues that they're not as operating as often as they used to because of the fatigue or back pain or failed back syndrome. And we're hoping with the training ergonomics, using the tools that we have, this will hopefully solve these problems. I have 5 minutes left. So where do you want to go? They were doing another project with Bayan Bagasi. She's our PhD student, and we're developing an AI coach. She asked me not to show the results because now we have the results. We have an AI coach that would tell the trainee as they're doing the procedure what wrong they're doing. And we have very favorable results, and hopefully that will get published soon. Another issue that we're looking at is proposing digital twinning of training records. Currently, every procedure is being recorded, supposedly, through the Southern Commission on Specialties. And we have what we call the DOPS, the Direct Observational Procedural Skills. We have all of that being recorded. And hopefully, we're trying to twin the digital records in order to create personalized training for our trainees. But of course, it's not enough. We don't have the simulation records. Hopefully, as simulation gets better, we'll also get this done. And basically, what we're thinking is to have a digital twin of the virtual simulation. This will hopefully, there's a continuous buildup of the training record, and this will leverage by leveraging the Internet of Things, the IoT, with real-time monitoring. Hopefully, this will really create big data that we'll be able to use for the future. AI is effective, comprehensive, focused on dynamics, and personalized if we use it in terms of training. Big data analytics, we're not there yet, but hopefully that we be able to do that with our training records. So in reality, when we come back to the basics, synergy in action. Apprenticeship, it has to continue using that in addition to simulation that we can practice outside the OR to rehearse in order to do better in your operating room. And hopefully AI will understand where we stand to give you feedback and augment your learning process. And eventually, we interweave that with the ergonomic training in order to together create a better surgeon to be able to serve his community in the best way possible. I'll just touch upon that. There's so much in Saudi Arabia, and I think there's no country in the world is going as far as we're going with, in the vision that we have, and specifically that talking about Sadaq. I don't think there's any system in the world like Al-Shek. There's nothing in the world that I think we have the best, these tools that we have, they are the best tools of their kind in the world. So why can't we use that to improve our training ability and to use that to improve our? I'm in the Saudi Commission, and this is something that we're always talking about and trying to see where we can creating our own. Why are we using 145, for example, the ones who are trained? Why don't we create our own? Go through that. So, what's the next step? We should invest in simulation lab. We should invest in virtual reality. We should continue investing with AI training platforms. We should incorporate that in our curricula, and hopefully this will develop different ways to train our faculty to be able to train their performance. So I imagine in 2030, first thing in the morning, the VR rehearsal is being done for a difficult case with an AI monitor to tell you what you did right, what you did wrong. And then later you go for a live surgery with a mentor, with AI guidance overlay, artificial intelligence coach, and then post-op debrief, and eventually, you go home and have a good wellness session with the mental rest. And eventually, this is also something that we're coaching on is using metaverse, having multiple trainees, not just the surgeon, but the surgeon, the anesthetist, and the nurse, all in the same environment, being able to trade together. And this is because that's how things work. Let me just go to conclusions. So we want to embrace the future, tradition and innovation hand in hand. I think Saudi Arabia is posed to lead the transformation. Better trained surgeons, safer patients, and hopefully the future is now, and we should shape it. Thank you very much. And Jazakumullah khair, and sorry for taking so long.
Thank you so much. And we will have the Q&A at the end of the session 1. It's my pleasure and honor to introduce our distinguished speaker, Professor Haitham Tayyib. He's a professor of behavior neurology and clinical neurophysiology at the Department of Neurology, King Abdulaziz University, and adjunct professor at New York Medical College. Prophet Tayyib completed his neurology residence at McGill University and Montreal Neurological Institute, followed by a fellowship at Harvard Medical School in Boston. Prof. Tayyib is the Secretary General of King Abdulaziz University Scientific Council and Vice Dean. He's also president of Saudi chapter of Cognitive and Behavior Neurology. Please welcome Professor Haytham Tayyib.
Assalamu alaikum wa rahmatullah. Thank you for the invitation. Congratulations on already successful conference, mashallah. It's good to see some of the faces of mentors and friends and collaborators. And let's get to it. So in 15 minutes, hopefully, we'll discuss everything there is to know about research in Alzheimer's disease to the extent that you will not need to know or read anything else. And of course, that's completely wrong. I think of this talk as a point of to stimulate discussion and nothing more. And I say a clinician's perspective just to say it's the dumb person's perspective, because I really think that it's scientists who are supposed to really solve our problems. And by scientists, I mean the real scientists, not those that pretend they are, meaning us clinicians. So these are some of the disclosures. We think of Alzheimer's disease today in the same way that Alois Alzheimer thought of it more than a century ago. We define it pathologically as amyloid plaques and neurofibrillary tangles. We have come to recognize that in order for the brain on the left side of the screen, shown on the FDG PET, metabolizing glucose effectively to transform to the brain on the right side of the screen, where it's not. We see all the loss of all of the red areas because the brain is not metabolizing glucose effectively and is hypoactive. There are a bunch of neuropathological changes and neural network changes that need to happen for the brain to degenerate in the way that it does. And we have come to know that this process is actually, for the longest time, we were looking at it much too late. Say maybe 20 years ago, not much longer than that, we used to think about Alzheimer in its moderate and severe stages and not really a rush to diagnosis is what we used to say. And then about 10, 15 years ago, Ron Peterson coined the term mild cognitive impairment, which are people, referring to people who are experiencing cognitive difficulties, but are still able to go on with their lives. And at the moment, we are thinking about preclinical states, meaning people who have neuropathological changes with surrogates shown in the plasma or CSF or imaging, for example, and have not yet demonstrated or manifested any symptoms. So we have shifted ourselves to the left in this curve, recognizing that most of the neuropath changes occur decades before anything manifests. And that, in this 15 minutes, I will not present decades of research and trillions of dollars that were poured into trying to reverse moderate and severe stages of Alzheimer's disease when it's evidently been too late. So one of these fronts is transforming the diagnosis from a clinical phenotypic diagnosis to a pathophysiologic biomarker-based diagnosis. And we kind of have a staging for the Alzheimer pathophysiology on this ATN scheme, as you see, with A and T and N referring to the things that you expect them to refer to, and pinning all of those to imaging or fluid biomarkers. And this is really at the forefront of everything else, right? Because if you don't recruit the right patients, you are not you don't have the right candidates to try your treatments on. And something like plasma p-tau217 on the top right of the screen has revolutionized what I do in clinic. So this is basically a blood test that you order that will tell you whether, with great certainty, whether there is amyloid and tau in the brain to be shown with a gold standard of amyloid PET or CSF changes. And there are other biomarkers that are going to. There's a race somewhat similar to the Formula One that we had between these biomarkers and between not just scientists but also entrepreneurs to solve the problem of having a reliable biomarker. And we're working with the leadership here and to try to join this race. So these are the proposed diagnostic criteria for Alzheimer's disease, and you will not see reference to clinical symptoms. If you look at the right side of the screen, all you'll see is core 1 and core 2 biomarkers referring to neuropathological changes, just emphasizing the point that I've already belabored. And you can see also, we haven't mentioned imaging. You see those nice pictures. And this is, again, has revolutionized my practice in clinic, and it's right next door that we're able to do the amyloid PETs. There are tau PETs are going to become a mainstay also very soon on top of the FDG PET that measures neuronal dysfunction. All right, so which areas are we going to try to mention? We're going to talk about immunotherapies, some of the tau targeting approaches, metabolic dysfunction, cellular strategies, and the network therapeutics. I think this is a fair outline of the research areas, although definitely not inclusive. So what people have done and what has already breached research into clinical practice is demonstrate that amyloid targeting monoclonal antibodies that remove amyloid species from the brain in people who have mild Alzheimer's disease are beneficial. These are monoclonal antibodies that, depending on which one you're talking about, target different species of the amyloid along the cascade from its normal behavior in the brain to the parts where it forms plaques. And it's been demonstrated both in amyloid PET and also clinically that removing amyloid helps a little bit. Not a great deal, really. A little bit is even generous. If you look at the placebo and lecanemab is one of the 2 approved antibodies, you'll see that the difference is less than half a point on this scale, which translates when you do some statistics into 20 to 30% of improvement. And I think, aside from the clinical points that one can make, it begs the question of what the role of amyloid is, right? Because if you're removing amyloid effectively and only getting this much improvement, it means amyloid is only, if at all, just part of the story and potentially not even at the center of the story. However, it seems that there's a butterfly effect and that the longer amyloid stays off, and the earlier you intervene, the benefit seems to widen and potentially pointing to the idea, again, that the earlier we intervene and the more we keep the brain in a healthy milieu, the more likely you are to have cascading effects down the line. And these treatments are not without problems, and that's one of the things that we have been struggling with is the reaction that you get in the brain. You get edema, you get hemorrhages, so these treatments are certainly far from perfect. And there are treatments these treatments are being tried in other trials and other stages along the earlier and earlier in people with Down syndrome, in people who have autosomal dominant mutations. And so we'll know more about the role of amyloid in Alzheimer's disease. And there are second-generation antibodies that we'll hear about, including Returnatuk, for example. One of the things that have been troubling is that you give these antibodies, and less than 1% of it actually reaches the blood-brain barrier. So Returnatuk and Trontinemab are two ones that are going to be more available at the brain. One of the clever ways that scientists are doing this is by coupling the antibody to transferrin receptors, and there are other ideas to shuttle the antibody across the blood-brain barrier. And this has led to a more robust removal of amyloid from the brain, so we'll know more about what happens with that in the near future. We haven't been as successful removing tau, and there have been quite a few antibodies that have been tried and failed. BIB80 is an antisense oligonucleotide that seems to have reduced tau production, and this is one of the things that seem to be promising the field's focused on, BIB80. HMTM is a derivative of methylene blue. It's a tau anti-aggregant that was shown to reduce NFL levels in the CSF and reduce atrophy, but has not really led to significant cognitive changes, but additional trials are ongoing. That's something we may hear about. And the big story at the moment is GLP-1 agonists. So Ozempic, Mounjaro, blockbusters in weight loss, but they're potentially going to be blockbusters in Alzheimer as well, given the role of impaired glucose metabolism in Alzheimer's disease. And the EVOKE and EVOKE Plus are trials that clinical trials that we are following. It's not unlikely that we're going to find ourselves prescribing these medicines to folks with early stages of Alzheimer's disease at mid next year, not much longer. The trial is significant statistical power, so it's likely to lead to positive findings. And there are other metabolic interventions that are of interest too, and neuroinflammation remains a big story in relation to metabolic dysfunction. And microglial interventions are also of interest. TREM2, as a matter of fact, there was a recent, just a couple of days ago, a negative trial on TREM2 modulation to reduce neuroinflammation. But again, the role of microglia is interesting, and again, this is an area that you guys should focus on and solve these problems so I know what to do in the clinic. Stem cells have been tried, not just because of their potential neuroregenerative role, but also because of their secretome and its anti-amyloid and anti-inflammatory effects. Of most interest is Lomosal B by Longeveron, which is an off-the-shelf stem cell prescription that might end up being picked up and prescribed to patients, and was shown to have both positive cognitive effects as well as positive effects on biomarkers in the brains of Alzheimer's disease patients. However, trials are still ongoing, and there's additional, most of the trials that you see, these are ones mentioned in clinicaltrials.gov, and there's a little bit of we're still in the premature stage of stem cell trials in AD, aside from Lomosal B. Within senolytic therapies, Dastatinib and quercetin are on the front, and the STUMP AD trial is ongoing. These are clinical trials that I'm mentioning. Autophagy is something that's being discussed, and it's been shown that there are impairments in autophagy and cell repair in Alzheimer's disease, and things like metformin and mTOR inhibitors are being looked at the moment. Anti-seizure medications are being tried on the premise that altered neuronal networks lead to cytotoxicity, and cytotoxicity leads to neuronal injury, which leads to altered neuronal networks. So not just the chemistry, but also the dynamic interaction between cells seems to be important for AD, And levetiracetam as an anti-seizure medication was tried, showing some promise, and there are additional trials there, as well as some direct neurostimulatory approaches, again, showing promise, but nothing definitive. And the idea of brain network therapeutics, will it happen that one day I'll refer my patients to Abdurrahman to put DBSs in patients with Alzheimer's disease, just like we're doing in patients with Parkinson's disease, for example? It's something that's being looked at. The microbiome is hot wherever, whichever disease you want to discuss. There's evidence that, just mild evidence that probiotics help, that the fecal microbiota lead to unexpected cognitive changes, and that's being looked at. And the benefit of diet is something that is very well documented. So in conclusion, in this very rushed presentation, it is likely that in the next few years that we will be looking at multiple interventions targeting multiple mechanisms. And what you guys do in the lab is really now being ushered into the clinic in ways that are impacting patients and families in positive ways, hopefully. Thank you very much.
Thank you very much, Prof. Haytham, for an awesome talk. I'm sure there's a lot of information and knowledge, and 15 minutes were not sufficient. I would like to take this opportunity to welcome our next honorable speaker, Dr. Muna Al-Shek. Dr. Al-Shek is an associate professor of neurophysiology with more than 20 years of teaching experience. He was the first PhD holder at the King Faisal University, now known as Imam Abdurrahman bin Faisal University. She currently serves as the Vice President of the Saudi Society for Medical Research at the College of Medicine at AIU. Since 2012, Dr. Al-Shek has been a certified accreditation reviewer with the National Education and Training Evaluation Commission, ETAC. Some of Dr. Al-Shek's prominent achievements include establishing the Medical Education Department, the Faculty Development Program with the Interprofessional Essential Skills for Health Professionals, and the Examination Center at the College of Medicine. Apart from her PhD in neurophysiology, she also holds a Master's in Health Professions Education and a Diploma in Artificial Intelligence and Python programming. She has participated in several QAA and NCAA tours for quality assurance. Ladies and gentlemen, please welcome Dr. Muna Al-Shek.
Thank you, Dr. Chowdhury, for this introduction. I want to thank the organizers of the conference for inviting me. I feel proud to be at KFMRC presenting my humble work. And the reason for that is that I was involved in the reaccreditation of King Abdulaziz University, and your strong points were KFMRC and the Simulation Center, which is run by Dr. Abdulaziz Walker. I really want to thank the speakers before me, Dr. Sabbagh and Dr. Tayyib, for their excellent points. And one of the things that's very dear to my heart is Zahrawi. In my earlier student years, we were asked as a competition to present a historic report. And one of all the Muslim scientists, I picked Zahrawi because I was really fascinated by the details of the instruments, the surgical instruments, which are exactly what we are doing now. It's really fascinating if you go into the history, because we cannot succeed unless we give credit to those pioneers. And it happened that I got the first prize for the historic report, which was later published in Al-Faisali journal. I don't know if you were aware of that. It was a very good journal, very well published. I still have that copy with all the details of the instruments on the cover page. So it's a topic which is very dear to my heart. The other topic which is very dear to my heart is AI and involving it in education. And I give actually a lecture on some of the platforms that are used to excel and refine the surgical tools. And as it was mentioned, you can easily upload a video of your surgical tools and get it refined and get feedback by experts all over the world through this AI platform. So let me start my talk today. We have done some work on antioxidants and how they can prevent and ameliorate Alzheimer's disease. So my objectives will be about the statistics and prevalence. What is the health burden of Alzheimer's disease? Some of the pathogenesis, very likely I will mention it, the 3 hallmarks of the disease. I'll talk about our work, which is about the nano-emulsified quercetin and how does it interfere with it. It's an experimental work on albino rats. And then I will talk about the future. How is this study can be used as a prevention and treatment of Alzheimer's disease? So the statistics say, and this is why I changed my presentation this morning, because we found Saudi Arabia to be in the red zone, which means the highest level of dementia, early onset dementia, including Alzheimer's disease. Right, why? Why do you think that is so? Now, obesity was mentioned as could be a factor, but a very well-known factor is diabetes. Diabetes is directly related to the amyloid accumulation in the brain, and that could be reason because we know diabetes is prevalent in Saudi Arabia. I have published a paper in 2000, I think it was 17 or 18, about the early onset dementia in the Eastern Province and in Saudi Arabia in general and the region, and what are the factors and risk factors that are leading to that. If we look at the World Health Organization reports, the 2024 reports have nicely analyzed the top 10 causes of death globally. So we're not talking about a debilitating disease with a health burden, a tragic disease for the family, but actually we're talking about a lethal disease. So in the year 2000, the Alzheimer's disease was beyond the 10 top causes of death, while it jumped in 2024 to be the 7th cause of death. So we're talking about something that's really increasing, that's really lethal, that is a big health burden. The pathogenesis have been mentioned before, but the 3 main pathologic hypotheses that we have is the amyloid plaque deposition, intracellular and extracellular, and these depositions, they start an inflammatory process, which goes on from 15 to 25 years before the first symptom starts. Can you imagine? This is why the talk of Dr. Khuld Al-Ghamdi, which is after me, is talking about prediction. We don't want to wait till the symptoms start. We want to actually predict and prevent. These are the amyloid plaques. They are deposited intracellularly, extracellularly, and interfering with all the neurophysiological processes. Second hypothesis, as you all know, neurofibrillary tangles. What are the neurofibrillary tangles? We have microtubules inside the neuron that are there to transport nutrients, molecules, transmitters. Why? Because all the synthesis goes into the cell body, which has the ribosomes, and then they have to be transported through the axon to the axonal terminus where the site of action takes place. So these microtubules should be straight, just like a straw. What happens in Alzheimer? They turn into curves, just like straight hair and curly hair. So what does curly hair do? It tangles. And if you ask people with curly hair, they'll tell you that the main thing they have to do is to prevent tangling. So they tangle and they produce those tangles which no longer can transport any molecule. The third is the acetylcholine theory or hypothesis. We know that in Alzheimer's disease, there is degeneration of the nucleus basalis of millions in the basal forebrain area with reduction of acetylcholine presence and its interaction with the receptor. Now, the mechanisms are so many. So you know that the treatment of Alzheimer's disease is either preventing the amyloid plaque, and you have heard about the anti-amyloid vaccines and all the measures mentioned before me. And the second one is tackling the neurofibrillary tangles, which are an intracellular process that actually disrupts all the neurophysiology. And the third one is the anticholine esterase to reduce the breakdown of acetylcholine, increase its presence and its functionality. So pathology or pathogens of Alzheimer's disease has all these three factors. Now, it's also, we know that also the neurofibrillary tangles and amyloid plaque are related to each other. So one of them is actually leading to the other one. So the beta amyloid protein deposition actually leads to tangling of the tau protein, so they are related to each other. Quercetin is a naturally present product. It's present in fresh food, fresh vegetables, and it has this benzyl structure. So it's a small molecule actually, but it's not a chemical that we prepare. It's present in the food. Many foods actually. And its role as an anti-inflammatory, an antioxidant, anti-cancer, and anti-tumor is not new. It's been known for a while. But it has, the highest level is in onions. We know that quercetin, which is present in food, can protect the neurons. We know that it reduces the oxidative stress, reduces the inflammation, inhibits acetylcholine esterase, so it improves, it works on the three theories or three hypotheses of pathogenesis of Alzheimer's disease. So it reduces in amyloid deposition and neurofibrillary tangle formation. Why can't we use quercetin as a treatment? There are four main reasons. There are five, but actually I just put them into four. First of all, it has low solubility in water. Second, if given orally, the bioavailability in the blood is very low, 17% in rats and only 1% in humans. Third, it does not cross the blood-brain barrier where the action is needed. And fourth, it's rapidly degraded in the bloodstream. So what can we do? We use the nano-emulsified form of quercetin. This is a transmission electron microscope graph of our experiment, showing these nano-sized particles of quercetin after being emulsified by surfactant. We call it QCNE. Now, what does QCNE do? We found out that it actually does all of these actions. So it tackles all the three hypotheses of pathogenesis of Alzheimer's disease. And I'll show you the experimental work. We had 48 albino rats, and we divided them into 6 groups. The first group was a control, so just received the vehicle. Group 2 received only the quercetin intraperitoneally. Group 3 had the heavy metal or aluminum chloride, so they were the Alzheimer group. And then group 4, 5, and 6 received various treatments as shown. So all 4, 5, and 6 we induced neural degeneration similar to Alzheimer, and we have given only the vehicle in group 4. In group 5, we gave oral quercetin. In group 6, we gave intraperitoneal emulsified quercetin. So these are our findings. We found that the oxidative stress or the antioxidants, they were reduced in the Alzheimer group, and they almost came back to normal by the EIP-QCNE, or the emulsified quercetin. The same thing goes for glutathione. While the oxidative stress was markedly almost more than 3 times tripled by aluminum chloride in the Alzheimer group, AD group, and then it came much less when we gave the IP-QCNE. So we're trying to show that IP-QCNE have actually increased the antioxidant level and reduced the oxidative stress. The same goes for AOPP. When we talk about the inflammatory biomarkers, the same thing. So you can see that in the control group, the AD group had almost double the level, and they came much lower when we gave the IP-QCNE in the treated group 3. When we talk about TNF-alpha, the same thing, they were doubled with the aluminum chloride, and they almost came back to normal when we gave the IP-QCNE. Adiponectin, almost the same. When we talked about inflammatory mediators, and this was done by immunohistochemistry, so after the experiment, the brain of the rat was divided into two. One was homogenated for spectrophotometry, the other part was done sections to stain for COX-1 and COX-2. You can see that in this section of the normal rat, the control rat, you can see that we have a stain for the brown stain or patches is COX-1. So this was available in the normal rat. It disappeared in C, which is the Alzheimer rat. And then they came back when we gave the IP-QCNE in the F section. On the other hand, the COX-2, they were not present, the brown patches were not present in normal, and they appeared when we gave the heavy metal, and then they disappeared again with IP-QCNE. For the brain neurotransmitters, we found that there was a rise in the Alzheimer disease neurotransmitter level, dopamine, norepinephrine, and serotonin. Of course, acetylcholine was the opposite. And in the treated group, they almost came back to normal. So this is just to prove to you that IP intraperitoneal nanoemulsified quercetin was effective at the antioxidants, oxidant stress, reducing the oxidant stress, reducing the inflammatory biomarkers, and improving the neurotransmitter levels. So what are we saying? We are saying that in the future, if we have this intranasal injection of emulsified quercetin, could it be used for humans? You know, last year we had that innovation exhibition at my university, and Prince Saud bin Naif came and stood at my booth and he said, this is a great work because we have a lot of people suffering from Alzheimer, but how long does it take to be used for humans? I thought that was a great question, because yesterday is NIH, those of you who were in the webinar, we were talking about the gap between an innovation and its use. So I was really worried how long it takes. This has been published now, and how long does it take to commercialize it and being useful for humans? So nano-emulsified quercetin can be as simple as an intranasal injection. What are intranasal injections? They worked, or they reach the brain directly through the cribriform brain. So there is a short route and there's a long route through the blood circulation. Being emulsified means that it can cross the blood-brain barrier, unlike the natural quercetin. Intranasal nanoparticles is not a new idea. It is being used for so many diseases. It has not been yet introduced for Alzheimer's disease. And I hope soon I will see this product and we'll see people with Alzheimer's disease benefiting from this work. This was our publication in Antioxidants, and with my colleagues, Dr. Nawf Aqil and Prof. Mohammed Hariri. So I hope that this will see the light and it will be useful for Alzheimer's disease patients. Thank you for listening.
Thank you so much, Dr. Amana, for your talk. Next, it's my pleasure and honor to introduce an innovative speaker, Dr. Khulud Al-Ghamdi. She's a dedicated educator and a healthcare professional and lifelong learner passionate about the brain, innovation, and education. She holds a medical degree and a master in neuroscience from Imam Abdurrahman bin Faisal University and a PhD in neuroscience from University of Glasgow in the United Kingdom. She is a senior fellow of a higher education academy. Her research focused in artificial intelligence, application in neurocognitive disorder, and diagnosis of multiple sclerosis and factors affecting student engagement and mental health. She's the Dean of Institution of Innovation and Entrepreneurship at Imam Abdurrahman bin Faisal University. She holds a higher diploma in health executive leadership and certificate in strategic innovation from University of Illinois Urban Champion. Dr. Al-Ramidi educates future medical profession about neuroscience, focusing on creativity and innovative thinking. She will talk about artificial intelligence and the prediction of Alzheimer's disease. Please welcome Dr. Amal.
طيب السلام عليكم ورحمة الله وبركاته، أهلا وسهلا، بسم الله والحمد لله والصلاة والسلام على أشرف الأنبياء نبينا وحبيبنا محمد وعلى آله وصحبه وسلم. Thank you, organizing committee, for the invitation. I'm humbled to be part of this event, وأشكركم actually على اختيار topic of Alzheimer. احنا الحين ال RDIA مثل ما تعرفون فيها 4 innovative أو research توجه البلد هو في الهيومن هيلث، في السستينبل ديفلوبمنت، وفي الرينيوبل انرجي، في الفيوتشر ايكونومكس. من ضمن ال5 نقاط في الهيومن هيلث لونجيفيتي. طيب احنا وي وانت مش بس لونجيفيتي، احنا نبغى حياه طيبه، صح؟ من ضمن اللونجيفيتي اللي هي trying to tackle chronic مثلا neurological disorders، Parkinson's، Alzheimer هذا مرض كبار السن، فبالتالي اذا احنا عرفنا to predict Alzheimer and then hopefully to either treat it well early as possible. مثل my previous colleagues صراحة I'm humbled إني أنا شكرا لكم ساعدتوني أقول لكم أهمية الموضوع thank you very much. But it's very important to tackle Alzheimer as early as possible. وبالتالي كيف؟ عن طريق predicting people who are going to have Alzheimer in the future and then hopefully treat them as early as possible. مثل ما قال بروف طيب ومثل ما قالت الدكتورة منى it's an important topic وسعيدة أيضاً بالمحاضرة حق الدكتور صباغ thank you very much صراحة يعطيك العافية دكتور. وأنا كنت سابقاً I was the Vice Dean of College of Medicine of Research and Innovation and I've been رئيسة البروجرام director. فأشكرك، أعرف أن البروجرام directing is not an easy thing. Thank you actually for graduating future neurosurgeons. Thank you. شكرا لكم جميعاً مرة ثانية. على طاري الزهراوي بس قبل ما أدخل كذا، على طاري الزهراوي أنا في عمادة معهد الابتكار وريادة الأعمال كل سنة احنا في نسختنا الثانية تونا في رمضان اللي فات ندعوكم تجونا الشرقية. احنا سوينا ايفنت اسمه Islamic Inventions and Innovations and Islamic Civilizations. أعرف قرأتم كتاب 1001 Inventions في Islamic Civilization. I just wanted to tell you أن الانوفيشن والانفنشن في الحضارة الإسلامية الأساس فيها هي الحضارة الإسلامية. It's in our genes, But we really need to innovate for the sake of humanity, and this is not something new to us. شكرا لكم. So today I'll talk about artificial intelligence and prediction of Alzheimer's disease. أنا for the long day درست الطب وأخذت الماجستير في جامعة الملك عبد الرحمن فيصل اللي هي جامعة الملك فيصل سابقا. ثم I went to do a PhD in neurophysiology, basically في اسكتلندا في بريطانيا. ثم مسكت عمادة معهد الابتكار وريادة الأعمال. So today we are going to explore how artificial intelligence or AI is revolutionizing the prediction of neurocognitive decline disorders, including Alzheimer. Alzheimer is a neurocognitive decline disorder. في أكثر من disorders، في dementia، في Alzheimer. Alzheimer إيش مشكلته؟ Progressive neurological neurodegenerative disorder مثل ما حضراتكم قلتوا قبل. That affects millions worldwide. دكتورة منى لما وريتينا الخريطة اللي قبل شوية this is very alarming إن إحنا في red zone. We really need to do something about predicting and then hopefully treating or prevention deterioration.
طبعا تعرفون العلم ما بعد توصل الى يعني علاج كيور مثل ما قال بروف طيب، يعني ما بعد في شيء واضح، يعني بيساعدوني البيسك ساينتست we'll do our best ان شاء الله. Then it's a progressive neurodegenerative disorder affects millions worldwide. robbing، وكلمة robbing أنا حطيتها بالعنوان لأنه من جد يسرق individuals of their memories، يعني يسرق الإنسان ويسرق اللي هو أكثر شيء يأثر مش بس على الإنسان، يأثر على ال caregivers يعني والناس اللي حوله والعائلة. يعني tackling Alzheimer is preventing disasters مش بس للإنسان هذا، أيضاً لل-loved people اللي حوالينا. Their memories, their independence, their quality of life. Again احنا الحمد لله في محظوظين ان نعيش انه يبقى في يعني في عهد ان نريد من جد ان نطور the quality of life of people، والبلد متوجهه في هذا المجال والجرانتس متوجهه في هذا المجال. اذا it's heartbreaking condition not just for the patients زي ما قلت لكم بس كمان في العائله والcaregivers. طبعا 6 million people in the US alone live with Alzheimer، ومثل ما قالت الدكتوره منى it's a red zone البلد. طيب ايش challenges with Alzheimer is that often goes undetected symptoms يعني like memory loss becomes obvious by which time significant brain damage has already occurred. بمعنى أن لا تظهر الأعراض إلا بعد ما already في problem في البرين، يعني already في significant brain damage تظهر الأعراض متأخرة. وبالتالي هنا ليش نقول إن early detection is crucial و critical because it opens the door to earlier interventions مثل ما قلت لكم، أيضاً better management and potentially hopefully slowing the disease. إحنا ما عرفنا نعالجه إلى الآن. طب let's try to pick it up as early as possible to prevent لا سمح الله deterioration. إيش قصة الارتفيشال intelligence؟ أنا ماني خبيرة في AI، لكن كان البحث هذا بشراكة مع مجموعة من الكليات وهذا أيضاً يعرج عليه. Innovative research or research with impact is not a one-man show or a one-person show. It needs people who sit on the table from different backgrounds يجلسون مع بعض يتناقشون. بالذات كلية الحاسب إذا إحنا نبغى artificial intelligence we want people who are into artificial intelligence ما يقدرون يجوا في المتصفق، لازم يجلسون with people with medical background. إذا AI with its ability to analyze vast amounts of data، AI can analyze مرة data huge and uncover patterns للعين المجردة ما هي بواضحة. يعني ممكن ال AI يكتشف patterns معينة ما هي visible للhuman eye. طبعاً it won't replace physicians لا تخافون، we are there. يمكن الراديولوجيست ما أدري إذا هي راديولوجي ولا شيء، بس يعني we are there invisible to the human eye. AI is becoming a game changer. تكون كلمة game changer يعني مهم جدا. الحين اللي ما يعرف على المصطلحات كلهم، الحين اللي ما يعرف AI شوية يعتبر illiterate شوية، يعني حتى الحين في الجروك والأشياء يعني الأشياء اللي تساعد الإنسان. AI is becoming a game changer in predicting Alzheimer. So اليوم إن شاء الله I will discuss how AI is being used to predict Alzheimer, the promises that it holds, and طبعا ما في كذا حياة وردية the challenges we face and what the future might look like. شوي بس صوتي كويس تسمعون صح؟ طب how AI predicts Alzheimer؟ كيف ال AI يتنبأ بالألزهايمر؟ ال AI its core ال AI involves algorithms. طيب هذه simple كذا، احنا كلنا medical field بس بعطيكم شوية simple معلومات عن ال AI. Algorithms sets of instructions computers use to learn from the data and make decisions. طيب in the context of Alzheimer يعني حديثنا عن الألزهايمر AI is trained on massive databases. طبعا زي ال MRIs، ال brain scans مثل ما شفنا قبل شوية صور، ال PETs، ال genetic profiles، ال medical records، معلومات يعني تغذون المشين بمعلومات مختلفة تعطيكم prediction إن هل هذا الإنسان ممكن يحدث له ألزهايمر في المستقبل ولا لا. واللايف ستايل فاكتورز طبعا في لايف ستايلز مرة مهمة. تعرفون إن الألزهايمر it's not only يعني ال environment plays also a major role in Alzheimer. من ضمنها مثلا كيف الواحد ينام، sleep has a lot to do. في شيء اسمه الجلومفاتيك سيستم بتكلم عنه بسيط، إن النوم من جد سلطان وإن النوم من جد مهم يعني ل prevention of Alzheimer's disease to identify patterns associated with the disease. How AI predicts Alzheimer? One widely used algorithm الحين بس بتحدث لكم عن 2 algorithms في البيبر تبعنا. One widely used algorithm اسمه logistic regression. A simple يعني explanation is excels at binary classification. يعني determining whether someone is at risk يا أما أنت at risk of AI or not. إيش قصة logistic regression؟ Analyzes features زي brain scan, measurement or biomarkers. زي الدكتور طيب كان يقول في biomarker الحين مهم جدا في blood vessels that could predict الألزهايمر. assigning probabilities to predict disease risk. Researchers train logistic regression models on thousands of brain scans. Some from healthy individuals والother from Alzheimer عشان يقارن. Or mild طبعا ممكن تكون Alzheimer or mild cognitive impairment. A precursor to Alzheimer. mild cognitive impairment هذا أيضا زي ما ورانا بروف في الصورة أن MCI هذا ممكن يؤدي إلى الألزهايمر. The model identifies subtle differences. هذا اللي كنت أقول لكم إنه ما تختلف باختلاف يعني ما تبين في العين المجردة. الاختلافات البسيطة زي changes in brain volume to flag. إذا it tells you that there is a risk. طيب another widely إذا الأول كان logistic regression. هذا برضو it's an AI prediction model. الثاني اسمه logistic regression. الأول عفوا logistic regression. الثاني اسمه support vector machine. كان معنا في الدراسة دكتورة ما شاء الله بروفيسور في computer science. She is يعني into artificial intelligence. جلست معنا وقالت لنا إيش البست مودلز اللي ممكن تتنبأ بالألزهايمر بيست على المعلومات اللي الفيزيشنز نغذيها. So SVM works by finding the optimal boundaries or يسمونه hyperplane that best separates two groups. مثلا say healthy individuals from those with Alzheimer while maximizing the margins. يبين الفروقات between the closest data points يسمونها support vectors. So إيش يسوي هذا؟ This makes the SVM robust especially for complex or high dimensional data like brain scans. احنا في الدراسة ال SVM صراحة كان هو البايونير مقارنة بالlogistic regression. For data sets that aren't neatly يعني separable. مثلا لا تذكرون how could we predict Alzheimer? either نغذي المشين ب MRI, either نغذي المشين ب biomarkers, نغذي المشين يعني ب numbers. وكل ما كانت الداتا سيت ما هي neat ال SVM uses يعني tricks معينة to transform the data into higher dimensional space, enabling better separation. ما أدري في أحد من الحاسب معنا؟ كويس إني أقدر أقول اللي أقوله. طيب. لا. أوكي. ممكن إيه؟ أوكي. شكرا جزيلا. Thank you. No questions are answered. ها؟ أي of course طبعا دكتورة منى Artificial Intelligence دكتور. شكرا. طيب باختصار what is Artificial Intelligence؟ يعني ينقسم إلى أكثر من شيء. فيه الماشين ليرنينج اللي نتكلم عنه الحين using sample data to train computer programs to recognize patterns. في neuronal networks طبعا coming from a neuroscience background. أنا فخورة إن أصلا Artificial Intelligence has a lot to do with neurons. هو it tries to mimic the neurons. Computer systems designed to imitate the neurons in the brain. طبعا ال NLP سمعتوا عن ال NLP والروبوتكس. الحين الروبوتكس ترى جزء من ال Artificial Intelligence. استخدامات الروبوتكس في العمليات هذه يعتبر جزء من ال Artificial Intelligence. طيب اوكي بس بقول على 20 في study مثلا في 2023 from University of California San Francisco showed that an AI model could predict Alzheimer تقريبا with 85 accuracy. بمعنى احنا الحين ليش تختلف الدراسات؟ في دراسات كثيرة to predict مثلا using AI to prediction of diseases. تختلف في accuracy، تختلف في دقة هذه الدراسات. هذا اللي في University of California San Francisco 85%. Up to 5 years before the clinical diagnosis by analyzing the MRI scans. إذا هذه الدراسة بعد الدراسات they analyze MRI scans وممكن تتنبأ بحدوث الألزهايمر 5 سنوات قبل الحدوث. That's significant leap over traditional methods which often rely only on subjective cognitive tests يعني في العيادة. لكن إذا هنا هذه واحدة عن طريق ال MRI. وطبعا هنا تشوفون التاو والأميلود ما شاء الله يعني أول previous speakers they talked about it. هذا normal older هنا normal older adults، هنا normal older high عندها amyloid and tau، وهنا الألزهايمر disease patients. okay هذا tau وهذا الاميلويد. فبمعنى أن هذه الصور تغذى في الماشين ثم الماشين predicts ممكن هل هذا الإنسان يحدث له future Alzheimer or not. في لها طبعا ethical consideration زي ما قلت لكم ما في شيء يعني يجي as easy as possible. في لها ethical consideration. في لها أيضا لازم تكون الماشين مرة عالية. هذا النورمال، هذا المايس cognitive decline، هذا البيت neuroimaging، هنا الألزهايمر disease. طيب إذا كانت الأولى عن طريق الإيمجينج، الثانية عن طريق البايوماركرز. بايوماركرز ما إيش يعني بايوماركرز؟ biological indicators of the disease. مثلا ال AI model can examine blood tests for proteins زي الأميلويد والتاو which are linked to Alzheimer. هذه البروتينز can accumulate in the brain decades before the symptoms appears. وبالتالي كل ما احنا we predicted them we will hopefully prevent Alzheimer. دراسة أخرى ودي أشاركها معكم published in Nature Medicine found that an AI algorithm combining كل ما كانت الأشياء اللي نغطي فيها المشين أكثر combination مثلا blood biomarkers والdemographic data زي الage والsex. This is what we did actually. Could predict Alzheimer progression with 90% accuracy. This is exciting زي ما قلنا because blood test ليش أقل تكلفة وأقل invasive و more accessible than brain scans. إذا كانت هنا اللي هي البايوماركرز هنا المالتي موديل داتا زي مثلا الايمجينج والجينيتكس واللايف ستايل فاكتورز زي سليب باترنز والدايت كلها سوف تؤدي إلى prediction of Alzheimer. For instance مثلا ال wearable devices زي smart watches can track subtle changes in gait. Alzheimer يأثر على الجيت وعلى speech patterns which early Alzheimer affects. So AI models integrate this data to create a comprehensive risk profile. Sure. And imagine a future where your smartwatch مثلا flags a potential risk. طيب ايش promise of AI Alzheimer prediction? First and foremost early detection زي ما قلنا early intervention كمان could delay the disease onset. The promise of LSI. Second, AI makes the diagnosis more accessible, more cost effective أيضا for rural areas. برضو AI enables personalized medicine وأنا شفت وأنا داخلة ما شاء الله عندكم مبنى للpersonalized أو precision medicine for research. Well done, thank you. AI accelerating research إذن يؤدي إلى أبحاث مختلفة في الريسيرش. It's a lot of data. الchallenge سريعا ال AI is promising. It's not a magic bullet. أيضا one major challenge is data quality. ال AI also يعني if the data comes mostly from demographic مثلا older white adult يعني ما هي كل ما كانت الداتا specific لethnicity معينة كل ما كانت ما تقدر تطبقها على مجتمع أكبر. Researchers are working to diversify the data. اللي هي enter برضو يعني interpretation is not the same usually from جهة إلى أخرى. Another challenge is ethical dilemma for early prediction flags someone as has ممكن يعني هل أنتم ترون يجي واحد يقول ترى بعد 5 سنوات ممكن يجيك Alzheimer ترى فيها شوية هل نوتره ولا ما نوتره يعني برضو فيها شوية psychological dilemma. Finally بس بعطيكم a glimpse of our study. نشرت في Frontiers in Computation Neuroscience. We're proud. ليش أنا حطيت بوريكم multidisciplinary team. خالد he's a geriatrician family physician geriatrician عندنا في الجامعة. وأيضا دكتورة ناهد سلطان she's our guru في ال AI. أيضا نورا الملكم وعاصم نورا is a physiologist. عاصم is a family physician برضو geriatrician. نور الصفواني is a neuropathologist. مروة وخلود وأنهار وزينب medical students احنا برضو نفخر we include them. ودينا أبو 50 سمية ما شاء الله is برضو an artificial intelligence الحين هي في أرامكو. سلطان عمري من عندكم سلطان من عبد العزيز. احنا سعيدين we are open to collaborate in the future with يعني كينج عبد العزيز esteemed professors. يوسف القرشي is a sleep scientist. Sleep again is very important. So artificial intelligence approaches for early detection of neurocognitive disorders. Basically, this paper aims to apply various artificial intelligence approaches to detect patients with mild cognitive impairment, quantitative research, 343, association of the patient's cognitive function with various features, two models اللي قلت لكم عليهم بالlogistic with support SVM. بعدين ايش الريزلتس؟ تقريبا 64% of patients have normal cognitive function, 34 MCI, 12 dementia, وايضا the prediction accuracy. كانت البريدكشن في يعني accuracy for all كانت 71 لكن مين افضل موديل اللي هو الاس بي ام كان تقريبا 93 for all patients with a top 10 لاحظوا significant predictors based on SVM model اللي هم education. كل ما كان الانسان ماذا تعتقدون؟ ايش رايكم؟ ادري انه ما في وقت بس باخذ دقيقتين بعد ادركم. education كل ما كان الانسان highly educated كل ما كان ايش؟ أقل عرضة للألزهايمر. هذه أثبتتها الدراسات. وسبحان الله مش بس early childhood education وجدوا إن the more you are early يعني إحنا كل ما دخل أطفالنا في الروضة سبحان الله في المستقبل the prediction of Alzheimer يقل. education bedtime كل ما توجه الإنسان للبد أبدأ كل ما قلت فرص الألزهايمر. taking pills of طبعا الكرونيك diseases تناسب عكسي مع الألزهايمر مثل ما قالت الدكتورة منى مثلا vascular dementia لها علاقة مثلا في الدايابيتس. الفيميلز والميلز unfortunately ladies لأن الدراسة هذه أثبتت. طيب إنه we're more prone. الكرونيك بينز الكورونري ارتري ديزيز. الشيء اللي بس ودي اعرج عليه قبل ما اختم السليب. سبحان الله السليب تعرفون الجليمفاتيك سيستم اثبتت الدراسات ان الجليمفاتيك سيستم هذا ينظف البرين. فكل ما كان الانسان ينام تعرفون السليب في بوليسمنوغرافي في ريم ستيج ونون ريم اللي هي الديب سليب سايكل. الديب سليب سايكل كل ما كانت احسن كل ما كان المريض اقل عرضه للالزهايمر. هذه just make a note لها. وجدوا انها تؤثر. The results on this study emphasizes the higher accuracy and reliability of the proposed methods in cognitive decline prediction. بمعنى احنا ليش فخورين بهذه الدراسه؟ لان اخذنا 2 مودلز. اخذنا الموديل الافضل اللي هو 93% تقريبا واثبتنا ان الاكيرسي جدا عاليه to predict Alzheimer's disease. ما راح ادخل in details لكن موجوده هذه كلها الفاكتورز البيد تايم الويك السليب ات نايت الناب السكس الاديوكيشن هذه كلها depression anxiety stroke البين. الفيميلز ضربوا اكثر شويه. هذه more AI details اللوجيستيك ريجريشن versus الاس في ام ايش اثبتوا وين اللي accuracy اتبعوا اكثر. 95% فخورين بالاس بي ام في الفيميلز والميلز 94 لكن overall 93 which is actually a good percentage of prediction. هذه طبعا بعض المعلومات اللي تعطينا how accurate is هذه more into يعني AI how accurate is the method is. فأي again ال SBM كانت أكثر دقة. كل ما كانت الاريا under the curve أكبر كل ما كانت هذه يعني الميثود كل ما كانت أكثر أيضا دقة في تنبؤ بالألزهايمر. آخر شيء هذا اللي ودي أشوفه تشوفون هنا هذه البريدكتورز اللوجيستيك ريجريشن وهذا البريدكتور. الإديوكيشن كان ما أعرف البوينتر بس الإديوكيشن كان فوق. يمكن السلايد اللي بعدها آخر واحدة هنا اللوجيستيك ريجريشن والاس بي ام. الاديوكيشن كانت اكثر شيء لها علاقه بالالزهايمر البيد تايم الويك اب تايم الدبرشن الكرونيك ديزيزز. فالاديوكيشن باختصار كانت اكثر يعني عامل predicts Alzheimer. Finally, the study highlighted the utilization of AI in predicting cognitive decline among healthy participants من المنطقة الشرقية أو سعودي أرابيا. We're willing to expand it إن شاء الله بإذن الله تعالى عندكم which has rarely been studied. The artificial intelligence-based algorithm اللي هو ال SBM model was developed to predict cognitive decline in dementia in Saudi patients and compared the performance with widely used يعني other approaches. احنا فخورين بالنتائج وإن شاء الله نتمنى أنها تطبق. AI is opening new doors بإذن الله تعالى in the fight against Alzheimer's disease by predicting, by more accurate, not only predicting earlier and more accurate. Yes, there are challenges, لكن إن شاء الله بإذن الله تعالى together we can turn the tide against Alzheimer. أشكركم مرة ثانية صراحة على حضوركم واستماعكم. شكرا على فوز عليكم. شكرا جزيلا. Oh, okay. الله يقويكم إن شاء الله. We can discuss this further. شكرا جزيلا مرة ثانية. شكرا لكم.
شكرا وبارك الله فيك دكتورة خلود على البرزنتيشن الجميل رائع. الآن we would like to invite the honorary speakers please on the stage for moderation for the Q&A session. Please move.
So, anyone have a question for the speakers?
I think we have a question. Dr. Ali.
السلام عليكم.
Thank you all the speakers for the informative presentation. We are so honored for this, and even we are not in the same field, but we are interested in all combination between scientists and physician. I have actually two questions, mostly for maybe Dr. Sabah. I always wondering that the artificial intelligence, are you not worried about losing your hand skills training? And do you think that the new generation will be less skilled than your generation in surgery and so on? This is the first question. The second question is regarding using artificial intelligence for all speakers for a long period, and this will be, if there is a mistake related to the artificial intelligence or even in scientific prediction or anything else, who will be responsible in ethical point of view? Are the physician, are the scientist, is the manufacturer, the developer, who will be ethically responsible about mistake in this area or in this field of work? Thank you very much.
It's a question that needs two conferences. The first question, I was actually thinking of a conference called Will It Have Pieces? In a brief, just very short, and that's the same question that Dr. Haytham was asking me in the end. So that in brief, no, it's exactly when we started having calculators at school, and it was like, no, you should not use calculators because it make your brain go bad. It is in a way, yes. We lost human beings over the evolution of time. We lost a lot of skills because of the advancement of tools, but we gained different, fewer skills and better. We became. We used our glass of water instead of filling it up with stuff that we can replace. By the use of artificial intelligence, that we actually become more knowledgeable and more, able to do that AI will not be doing. Same thing. So we have self. So eventually, hopefully, we're hoping that we will, instead of we see movies that AI will kill us all, and which is probably going to happen eventually somehow. But I think we have to be very careful how to develop this and how to make it to our advantage instead of to our demise. Because to touch on the second question, because I don't know, many of us avid users of ChatGPT, DeepSeek, and Grok, and all of this, and they hallucinate, they make mistakes, and we have to be careful because we rely completely on what they tell us. We would be in trouble. And who's to fault? Is it the person who created the AI? Is it the person who's using it? It's again, these are very again, that's a conference by itself because we need to. There's a lot of growing. Interestingly, there is growing literature on the ethics of legal faults. Because now AI is being used in stock market. It's being used in education. It's being used in now the person that looks at I don't want to encourage too much on this. Medical insurance companies are replacing doctors who are the ones that are deciding, this test should be given or not by AI. So unfortunately, AI is already starting to hurt patients. So I'm hopefully not, but I think, and hopefully that they have these doctors that will actually review what AI tells them to do, and hopefully also us, because now we assert some of the physicians, we use AI to counteract the insurance companies. It's an AI versus AI. So yes, we have to have. There has to be a very serious look onto the ethical side. There's growing industry and the legal. Some of our friends, some of my friends in law, they're actually starting to look into this. It's a new frontier that eventually will also create trouble, and hopefully we'll be able to solve it. Sorry for taking too long.
I would like to just add over here. I think that's a huge challenge because AI integration is highly appreciated. Definitely, we are moving in the right direction and we are adopting it. But human brain is such a closed system, and it is so complex, and it is dynamic. You can do things on simulator, and you can see the end result right in front of you. But when you do a surgery, with AI and robotics, you will see the changes or the consequences later on, and that's where again it will be a very difficult outcome, unpredictable outcome. That brings me to a question for Prof. Haytham, that dementia and Alzheimer's, if I'm not wrong, it's not my field, but there are overlapping symptoms. So at what stage you begin to clinically or pathologically differentiate between the two? And what are the blood markers that can be picked up as predictory markers, if they are not genetic, any other markers, conventional markers, that can show us the direction of the disease, and its progress?
Thanks for the question. I think this is the crux of a lot of the efforts that are happening to find therapeutics. At the moment, I didn't have time to go into it, but plasma p-tau217 is actually has become routine clinical practice. It has very good predictive power when you compare it to the amyloid PET scan and CSF biomarkers. So what I do in clinic, for example, is if you have cognitive issues, regardless of what they are, essentially, you're going to get plasma p-tau217, and if it's positive, we're going to consider that you are at risk of having Alzheimer's disease, or at least Alzheimer, what we call Alzheimer's disease neuropathologic changes. And that will have consequences, clinical consequences, on what we decide to do. So that's in terms of diagnosis and early detection. And there's a bunch of other ones that are also potential targets for being biomarkers. CSF, we already have predictive biomarkers in the CSF. And I think the issue is harder with prognosis, predicting what happens down the line. And part of the difficulty is that we're not even sure what the role of these different pathologies are. So I tried to say that quickly. So, I can tell you whether you have amyloid or tau, but, we removed amyloid from the brains of these people, and the clinical change was only 20 to 30% at best. And then, dementia is, just to answer the other, I think the initial question was the difference between Alzheimer and dementia, and I think the main difference is in what parts of the brain are affected. So in Alzheimer, it's the memory network that gets affected.
So brain imaging is crucial for initial differential diagnosis also.
Yes, exactly.
For Dr. Muna, very nice talk. Thank you very much, Professor. Dr. Muna, you showed a map where you showed that Saudi Arabia is in the red, and also US is also in red. So what's going on over here? In terms of Alzheimer's, what's the prediction? Is it diet? Is it lifestyle? What's going on?
In my paper in the early onset dementia review, I analyzed all the risk factors for dementia in Saudi Arabia. And just to mention two of them, obesity and diabetes are prevalent in our country. They could be contributing, but is it genetic? Is it environmental? We cannot say for sure. But I just want to comment on prediction studies. And it's very tricky when you say I'm predicting Alzheimer, because unless it's a cohort study where you actually predict the disease and follow the patient and see that they have developed Alzheimer. They were not sure that we want it to be done very earlier on, 20 years before the disease starts. So who is capable of doing these long cohort studies to ensure that their prediction actually happened? That those who we thought they would have Alzheimer, they actually had Alzheimer. I think it's, we need big centers, we need multi-center studies in order to produce such data. I have worked on image processing on the lung, chest X-ray and CT scans, and we found with 98.9 accuracy how to differentiate the lung CT scans from normal, from pneumonia, and COVID-19. We started this during the COVID because we were not happy with the visual diagnosis of the ground glass appearance. So we thought we'd make it as a machine learning, and it worked, and it was published in Nature. Another one, I worked on the dental features and identification of persons, the identification of the personal identity. And this can be used in a Hajj season, for example. We have a lot of deaths without name or identity, so that's another study. And it was so developing the algorithms, following and making sure that the accuracy measured is actually accurate is very tricky in these studies. And I hope that I will see the time when we take this more seriously. So I'm very happy that Dr. Shader is asking that. We need to have efforts. We put our efforts together to produce really accurate data using AI for the prediction of Alzheimer, and then we can prevent it by antioxidants like the intranasal QCNE or others.
What you mentioned, nano-emulsified quercetin.
Yes.
It looks fantastic, but again, I think it requires clinical trials because coming towards personalized medicine, does our genetic spectrum will allow our patients to respond similarly? Experiments, for example, they're doing in the US on using these nasal spray or something.
That's a very important question because unless the innovation goes into that cycle where the clinical trials are done, we produce that it's effective in humans, it is tolerated by humans without side effects, we cannot commercialize it. And this was the question of Prince Saud bin Naif. He said, when can we have this? I said, it's a very difficult question. Ideally, it should take 12 to 18 months. But in our situation, the gap is very big. When we visited University of Miami, we had a center where the gap was only 2 months. They had the labs on one side, the clinics on one side. So they find in animals or in vitro, and they apply it to humans within 2 months. And when we reach that stage.
Can we take a question from Prof. Anwar?
I would like to thank all the speakers for the interesting talks. I have two questions, one on the AI side and one on the therapeutics side. What's preventing us from having a good system for all these technologies, simulation, digital twins, machine learning, AI? Is it only money? You mentioned money. Funding is a problem. But if there is funding, are we able to do it? Or we're still missing something? Because in my opinion, I think we're still missing, I don't see the clinical scientists who are equipped with all these capabilities. And for example, we don't have PhDs PhD programs, so people can do science, can do computer engineering, for example, or AI or whatever, and they continue their degrees in medical school, and then they do their PhDs and fellowship, and they understand everything. It's going to take longer time for them to be ready, but I think we're missing that a lot, and that's in my opinion, is a crucial link between science and medical practice. The other question is, where are we in the landscape of therapeutics today? I see a lot of clinical trials, modified antibodies, FcRNs to cross blood-brain barrier and other kind of, are we on the map, at least in clinical trial? Well, I mean, maybe in the use, actual use, or are we far? And also, what about clinical trials?
Two questions.
So in 2 words, it's lack of money and lack of interest. And the thing is, most people have resistance to change. I don't want to go into that, but when in our university, in our hospital, when we talk to surgeons, let's use the simulation lab, they will say, Toys R Us, you have to go to the patient, this is where you learn. This is just toys. So there's it's human nature. We don't like to change. بعد الله سبحانه وتعالى وفضله أنا تعرفت على بروف وديع حلبي. And that's how we work together. It's just a matter of connecting to people. We have a lot of people. حتى ما عندنا joint and it's all about me knowing him and working together, getting a PhD student here or a master student هناك. It's just about personal efforts and personal interest. But then trying to get funding, trying to get a lot of it is just personal funding, personal pocket funding. So money is important, interest is important. I'm a part of the Saudi Commission of Specialists. I've been singing this song for the past 10 years. And okay. So it is that. So now we are not, as physicians and clinicians, we're not trained in AI, we're not trained in education, we're trained to do certain clinical work, and anything else is not important. Even for med students, they don't care about it. And even now, my publications on AI, I don't know how much they will be granted, for my promotion, professorship. So they're disregarding the point. So I'm doing research because I care, because I want to do it. That's the problem. So it's money, but more importantly, interest. And if there is interest, there'll be money.
شكرا لك على هذا السؤال المهم. انت سالته وجاوبت اصلا لانك قلت حضرتك ان the more multidisciplinary fields they work together. So لما يكون في مثلا بروجرام اسمه biotechnology، لما يكون في بروجرام ما بعد البي اتش دي مثلا certificate in artificial intelligence and healthcare، لما يجلسون مثلا مجموعه انا لاحظتها لما تجلس مع الحاسب مع the more multidisciplinary research، لما كليه الطب تفتح اسوارها العاجيه وتجمع الناس، اتكلم عن كل الجامعات والميديكال doctors they are humble enough to sit with a computer scientist and talk together. هذه واحده ممكن ان شاء الله تنحل. لكن اتفق توتالي معك. ايش اللي منع؟ ليش ما في مثلا ابل الحين artificial intelligence to predict Alzheimer؟ لان الجرأه يبغى شويه مثل ما قلت، يبغى شويه جرأه، يبغى devotion، يبغى لها programs علميه. احنا في جامعه في منبر علمي، ليش ناويين نشجع فتح البرامج البيئيه ما بين الكليات؟ فهذه كلها اشياء to predict the future. عندنا في biomedical engineering، عندنا في biotechnology we try to open هذه programs. ما حد يقدر يسوي شيء لحاله، لكن لما نجي طبيب مع الذكاء الاصطناعي يمكن الولاد. الدكتور صباغ عرض على نقطه مره مهمه. What is in it for me for my promotion؟ مثلا انا شاركت مثلا في artificial intelligence كمبيوتر مثلا مجله health computer and healthcare، فيبغى لهم regulation changes كمان. هذه مهمه عن طريق الاداره العليا. ترى اي نشر multidisciplinary يشجع. وانا اشكركم شكرا.
Sorry. We have to close the session because there's really
So quite an interesting session for today. Dr. Faisal will thank all the speakers of this session. And finally, we would like to thank the moderators of this session, Prof. Ali Chaudhary and Dr. Faisal Al-Hussein. Now we have 5 minutes break as we are running out of time. Please come back 11:05.
research encompasses a range of topics, including the impact of oxidative stress on gastrointestinal function and the modulation of gene expression, neurodegenerative diseases. She has contributed to studies on DNA methylation patterns in autistic children, the effect of vitamin D on hepatic apoptosis, and the expression of profiles of apolipoprotein E in Alzheimer disease model. Please join me in welcoming Dr. Rasul.
Assalamu alaikum wa rahmatullah. Thank you very much. Good morning, everyone. I would like to thank you first, Dr. Nair, for this introduction. I'd like to thank Dr. Fatma, the organizers. I am pleasured to be here today. King Fahd Medical Research Center embraced me when I was just a master's student, and I'm very, very deeply honored. So today I'll be talking about H2O2, which is an oxidant, and its effect on colonic and jejunal mechanosensitivity. So with that, I'll be talking about the neurogastroenterology. That's what connects the brain with the GI. It's connected neurology and gastroenterology together. So in order to understand this mechanism and how do we feel when it is not all right down there. So the GI tract, as many knows, is a continuous tube, starts with the mouth and finish with the anus. It's responsible for all the good function and responsible also for what we call it the gut brain, when we have the gut feeling, when it is not quite all right. And why? Because it has its own innervation, that's the enteric part, enteric nervous system, that's my enteric plexus and mucosal plexus. I won't be talking about that. I will talk about all this innervation coming to the colon or the GI in general. It received an extensive innervation from the brain. So as you can see, the projections from central nervous system reach all parts, and it's here color-coded. So it goes to the serosa, mesenteric, to the myenteric plexus, to muscular plexus, and all the muscular layer, and then to the mucosa inside. What do they provide? As you know, provide signals from the GI all the way to the brain, so we can understand that there is something, and we don't feel quite all right. It causes something we call it hypersensitivity in many GI disorders. So what happens in case of oxidative stress? Many oxidants comes from bacterial radiation. Even some sort of food that we digest can affect the enteric cells to produce what we call it RUS. RUS is reactive oxygen species. These can leak out to the tissue, and boom, what's there? Just next, in a very close proximate to these cells and in the tissue, is the nerve endings. And it can stimulate the sensitivity of these endings, and we feel, again, something is not right over there. So also when we have infection, neutrophils will fight the infection. In the process, more and more oxidants are released and activating these nerve endings. So, what is the aim of this study? I'm going to show you, or the story that I'm going to tell you today, is that is there any different or regional differences in response to oxidant between small intestine and large intestine? The colon part. So we're investigating the effect of oxidative stress on the mechanosensitivity, on nerve signaling from both regions. Jejunum, which is the small intestine, and the colon, which is the large intestine. we hypothesized that there is a regional difference in the response. So in order to do that, we set up what we call an in vitro experiment, where we had the segment from the small intestine in an organ bath. Cribs comes in, cribs comes out. It is maintained at a certain temperature. So here, what you see, I hope I can point. I'll try, but you won't hear me. So, okay, I'll try my best here. And so, as you can see, the segment that we described lately, it has all the innervation. What you can do is cut there, just interrupt the signal from going to the brain. And on the right top, you can see the colon. That's the colon from mice. It's attached in an organ bath from both ends. I can diffuse cribs inside the tube, distend it, provoke it. So in the same picture down, you can see two numbers, 1 and 2. 1 is the mesenteric artery, and 2 is the lumbar colonic nerve. Here I can do the cut and then suck into a suction electrode from there to a neurolog instrument to pick up the signal, another instrument to filter it, and then display it in a computer, displaying a spike2 program. So we can do the analysis. So as you can see, the kidney here are just for sure. They are just the marker, so I know where to go from there. So that's the setup. Here I can manipulate the segment. I can do whatever I want, pharmacological manipulation. I used here in the data I'm going to show you is oxidant and mitochondrial inhibitor to provoke the oxidation. So next is the video. So this is the actual recording, what happened in real time. So in the first trace is the raw signal. You can see the spikes. Now the second one is just the rate. And down, I can close the tab from one end and distend the muscle. Distend it until it reaches 60 millimeter mercury. So that is a protocol established to study the mechanical sensitivity in the colon or the genome. So after that's finished, I will get this beautiful trace where I get the recording, the raw on the top, the raw signal. I can count them, not me, the spike2 program will count them and give me just a number. After that, you can see the interluminal pressure where I can decide where are the nerve is firing at what threshold. So after that, I can analyze the data using something really fun in spike2, which is a single unit analysis. It can scan the whole trace and then uses 60 different points to distinguish each signal and then give me just PCA, where I can just decide if the signals are overlapping together or not, or basically do the experiment again or not. I can also measure the motor complex, so that's the contraction, the normal contraction in the colon or in the genome. I can analyze that. So as any scientist here in the room or any researcher, the first answer of the first experiment, no, I got no, there's no effect. When I put oxidant, which is a pure oxidant, hydrogen peroxide, and I used a fairly high dose, because it's a powerful oxidant. When I used it in jejunum, the small intestine, it had no effect. That frustrated me for about 5 to 7 days. So when I jumped with the same concentration in colon, I got a star. So the colon responded. So the mechanical sensitivity did change, but in the colon, not in jejunum. I can do something where I can split the signals and use something we call it a single unit analysis to see which part, because it's a big nerve bundle. It has so many nerves inside. So I wanted to know which nerve actually responded. And when we analyzed that, we found that the change, oh, it's not here. Yeah, it's here. So the change is in mild dynamic and high threshold. These are the neurons that fire more, starting from about 40 millimeter mercury. So when the colon or jejunum is a little bit distended. Again, I increased the dose. I used 500. Again, jejunum was no, I'm not giving anything. But the colon, so many stars. So when I analyzed the single unit analysis again, I got 2 minutes, really. Like, okay, I got the significance. You got the story. That the response was in colon, but I didn't see it in jejunum. But that did not mean that the jejunum did not respond totally. There was a response, but not in distension. So not mechanosensitivity. It's just the spontaneous nerve firing increased. So the baseline, I will call it. So to further, I give like a more confirmation of this observation. I used something else, which is antimycin. Why did I use it? Because it's more stable than hydrogen peroxide. So I used it again. Jejunum, no effect. Colon, it has a significant effect, and it was in wide dynamic range. I wanted to know if this change is changing or will be the same during aging. So I used 22 old mice. The first observation was that the normal mechanosensitivity was reduced in aged mice, and that's established before. So what about the response to oxidant? Again, I used antimycin, so antimycin gave me an increase in mechanosensitivity in aged colon, but not in jejunum. Jejunum remains unchangeable even during aging. So to add a little bit to that story, we've done an oxidative marker between aged and young, and we saw an increase in the marker in aged mice. In aged colon, but not jejunum. We've done an MRI, the affirmatics, and again, the change was remarkable in aged mice, but in the colon, not in jejunum. So in jejunum, there was, of course, change by aging, but not as well we saw in colon. Okay, so in conclusion, I showed you that colon did respond to oxidative stress, and the response is actually less effectively than the jejunum. The most effect of aging was observed in the colon, but not in jejunum, and the difference response remain as conserved during aging in jejunum. Thank you very, very much.
So our next speaker is Dr. Hind Najashi. Dr. Hind Najashi is an associate professor and consultant in neurology and multiple sclerosis, chairperson of the neurology department at King Abdulaziz University, general secretary of the Saudi MS chapter. She finished the Saudi Board of Neurology in 2012 in fellowship in multiple sclerosis from Ottawa University, same university, right? In addition to a fellowship in medical education and stimulation in 2016. So she's going to talk today about what's new and the unmet treatments in MS. Welcome, Dr. Hind. It's a pleasure to meet you in person.
Bismillahirrahmanirrahim, and thank you for having me in this prestigious meeting.
Today in this talk, I'll try to talk to you not only as a clinician, but as someone who sees the suffer of patients with multiple sclerosis in daily basis. True, we made a huge improvement and development in MS treatment, but there are still critical gaps that remain and make the patient suffer. So I'll try in this talk to highlight some of these unmet needs with the aim to bridge the clinical reality from the bedside with the scientific innovation, with the hope to inspire new avenues for research and foster collaboration. So just before starting, okay. Just basically, what is MS? MS, or multiple sclerosis, is the most common neurological autoimmune disease. Basically, when we say MS or multiple sclerosis, we mean multiple scars that you can see in the histopathology, or what we can see them as white dot in MRI brain, and they result from the multiple attacks or the neuroimmunological inflammation that happen in the CNS, and it results in multiple symptoms, okay? Symptoms are variable, no patient is like the other. It's a wide spectrum, they have multiple symptoms, could be motor, sensory, cognitive, bladder and bowel, so it's really variable in the presentation and how it's affect the patient. Looking to the epidemiology for MS, it's not common as diabetes or hypertension, but still it's a common disease. So around the world, there's maybe 3 million people living with MS. Looking in particular to Saudi Arabia, stats are not very accurate, but there's an estimation that there are 62 patients per 100,000 Saudi national patients. Female are predominantly more than male, with a ratio of 2 to 1, and it's affect the young individuals, so at the ages between 20 to 40. So it affects the patient at their most productive age of their life. Looking to the map, okay, you can see Saudi Arabia is in the light orange, so it's in the moderate risk zone. It's not very high, but it's not low, and the prevalence is rising over the years, okay, and we still don't know exactly why. Just like a brief about the classification of MS, we used to say that we have relapsing remitting MS. The patient will have an attack, so they have like a blurred vision, they have a sensory symptom, motor, and then they recover. Either recover completely or recover with some deficit. And then after many years, the patient will transition from these relapsing remitting to be having more of a secondary progressive disease. So they don't have attacks, they don't have acute symptoms, okay, but they have a slow, steady progression over time. And there's a small percentage of the patient that we don't know why, but they don't have any attacks from the beginning. They start as a what we call primary progressive MS. Looking for these patients, the natural history, if we leave these patients untreated, around 85% of these patients who have relapsing remitting MS will be disabled, okay? And this is speaking about like spanning 25 years, okay? So if you have a patient who was diagnosed at 20, maybe by 45, you will need a walking aid or maybe even a wheelchair. This is like if we left the patient untreated. And as we understand MS more, we start to recognize it's not just a neuroinflammation and attacks, okay? We have degeneration and progression from day one of the disease, and even before we have clinical symptoms, we have some neurodegeneration. As the disease progresses, of course, we have more neurodegeneration and less inflammation. But why this neurodegeneration happens or start from the early onset of the disease, this is still not a clear answer, and this is maybe the reason that we don't have effective treatment for neurodegeneration. Still, we have made a huge success. So if you look like in the pre-treatment era, we just make the diagnosis and say bye-bye for the patient, and sometimes steroid physiotherapy, until 1993 when we start to have the first treatment for MS, which is interferon. Nowadays, we have more than 18 approved treatments. So this is a huge success, okay? We are glad to have all these treatments. It's a success story that we can have nothing, and then over the 30 years, we have multiple treatments and more coming, okay? So this is very good, right? But the problem that all of these approved treatments are anti-inflammatory. So they target the inflammation. Nothing so far is targeting degeneration. Yes, we make MS more milder. Now we don't see as much patient disabled as we used to see before the pre-era. So you can see in 1995, most of the patients are in the red, so they have high disability. 2017, most of the patients are doing well. They have a disability less than 3, so they don't need a walking aid or anything. So this is a huge success. But still, there is a lot of unmet need. So MS is a treatable now, but still we don't have cure. We don't have treatment for the progressive disease. We don't have treatment for many symptoms for MS. So as we said, progressive MS is a huge unmet need. We don't have anything for neuroprotection and myelin repair. Some symptoms like fatigue management and cognitive dysfunction are poorly understood. So we don't know what's the neurobiological basis of this dysfunction in MS patients, and then as a result, we don't have an effective treatment. Biomarkers are coming now. We have some biomarkers, but we still need more sensitive biomarkers to detect the disease before the onset. And also, if we can prevent MS, it would be a huge milestone. Saying that the most unmet need is progressive MS, okay. What we do in the clinics is that we follow the patient, we make sure that they don't have attacks, we look to their MRI to make sure that we don't have new lesions that indicate that there is an active inflammation. If this has happened, then the patient is in an inactive stage, and we tell the patient that your disease is stable and you have inactive disease. But sometimes, and a lot of patients, it's really heartbreaking, they say, okay, how come I have inactive disease, but I'm getting worse? My legs are getting weaker. And you see this obviously, like the patient was walking, after like 1 or 2 years, he started using a cane, and then maybe after a few years, he will need more support to do his daily activity. And this is the challenge that we face with progressive MS. And until now, we don't understand what is the driven mechanism exactly for this progressive MS and why patients differ in their developing of progressive MS. But we know that we have smoldering MS, and this is the real driven for disability. So there's no evidence of inflammation, but there's ongoing slowly degeneration and expanding lesion that is contributing to the disability for MS. So basically, when you have a patient who have an active inflammation, you'll have a myelin breakdown, microglial, macrophage aggregate, activated lymphocyte, and all the cytokines. And then this active lesion will either shut down, the blood-brain barrier will be closed, and we have chronic inactive lesion, the patient is stable. But some patients will not have this. They will have what we call slowly expanding lesion. So still the blood-brain barrier is closed, but there's a trapped CNS inflammation. So there's like a follicular aggregate of activated T and lymphocyte, T cell and lymphocyte, macroglial, macrophage with a lot of oxidative stress and iron deposition, and these get slowly large over time. And because they are trapped in the CNS, most of our available anti-inflammatory treatment cannot penetrate the CNS and cannot help this lesion. As a result of these slowly progressive lesions, the patient can have stable disease clinically and by MRI, by the traditional MRI that we do in the routine practice, but they still continue to progress and get disabled. And this is what happened in the progressive phase. Nowadays, we have more advanced technique in the MRI, so we can see them as a paramagnetic wave lesion. So we can see patients who have progressive disease, they may have more of these lesions that are surrounded by iron deposit, indicating that there is microglial activation and breakdown of the myelin, despite no acute inflammation. Saying that progressive MS is unmet need, we have another unmet need, which is the neuroprotection and myelin repair. We cannot give a patient anything to protect them from this damage, and until now we don't have a promising therapy for remyelination. A lot of trials going on, but until now there is nothing that really approved for remyelination. So thinking of something that could be effective in progressive MS, we need something that can penetrate the blood-brain barrier, that can antagonize the compartmentalized lymphocyte and microglial inflammation. We need to reduce oxidative stress. We hear a lot of oxidative stress in different diseases, so this is a huge need. And we need direct neuroprotection and demyelination. All of these some trials that have been completed on different agents, nothing like really made a clinical meaningful change. We have some ongoing trial on available agents like ketamine in high doses. Metformin is a promising treatment, but still in phase 1 and phase 2 trial as remyelination therapy. Finally, the reason, that we made a huge success in anti-inflammatory treatment, but we have nothing for the neurodegeneration, maybe, and you as scientists may know better than me, but I found this across this interesting paper that asks a question: do preclinical MS models allow us to measure neurodegeneration in clinical progression? So maybe the model that we use always the what we call the EAA, which is I think they call it the autoimmune encephalitis model in the mice, The problem with this model that it induces a severe autoimmune damage, So maybe this is very severe and it's not really resembling that what we see in the real clinical patients, So all the studies for trial and neurodegeneration is not working. The follow-up of these models is short and it's not enough to predict progression and atrophy. So maybe we need a new models to study the repair and remyelination therapy, like introducing the CAR T-cell based cell engineering or looking for any genetic modification for the cells. So by this, I conclude my talk, and I hope that this is just highlight some of the challenges that we see in daily practice and can inspire some new research ideas.
So our last speaker for this session is Dr. Shayma Yusuf. He's an associate professor of medical physiology at King Abdulaziz University, Arab branch, and Saudi Arabia, a member of the neuroscience, geoscience unit, King Fahd Research Center, the co-founder of the Neurobehavioral Lab, member of the Interpretive Monitoring Unit Physiology Department at the Suez Canal University in Egypt.
Assalamu alaikum. It's my honor to be here today for many reasons, and I'm lucky that all this presentation came before me from my respective colleagues, because it is a very good background for what I will talk about, inshallah. Today we are going to talk about the modulation of gut microbiome community, mitigation for multiple sclerosis in a mouse model, the promising role of Balmaria palmata algae as a prebiotic. ليش ما
بنفس
Okay, the definition. Why I mentioned this slide, because in Southern University, which is my home university, I began the research in algae at 2017, and I came here at 219, and again I worked in algae research, but at Egypt I worked in microalgae, and here I worked in macroalgae. We will talk about this, inshallah, the next slide. Here is the team of the research, and I am honored to be a part of them. From the right, Dr. Thamer, Dr. Zubair, Prof. Badra, Dr. Yanis, me, and Dr. Adnan, and Dr. Hamtash, but she wasn't here with us. And the team, each one do his work directly to publish this doctor degree. This is okay. It was published in Pharmaceutical And this research, by the way, was granted so we have to acknowledge the technical and financial support from the Ministry of Education and the KFMRC University. That's why I am happy to talk about this paper. Let's go in. Historical overview. There is a wide variability and the availability of the natural therapy in the Arab and ancient Egyptian history. The Muslim travelers provided a very rich account on the nature, location, and origin of various plants. For example, Ibn Sina in the 11th century listed more than 100 properties of herbal remedies, and in the 13th century, Ibn al-Bitar also discovered more than, or mentioned more than 3,000 remedies of plant origin, and in modern medicine, a lot of uses have been discovered. Now we are going to in our paper, the neurodegenerative disorders, including multiple sclerosis, are a class of pathologies distinguished by permanent declines, which result in a progressive and debilitating decline in nervous system function. It is more common in women than in men. However, the severity in men is more because they have primary progressive, while female have relapsing remitting multiple sclerosis. Why we use the Caprizone model? Because Caprizone is a carboxylated agent that causes demyelination, and also it can be used to assess the age and the sex influences in the progression. So it is a good model in multiple sclerosis. By the way, when we stop Caprizone, remyelination occurs spontaneously, so we can assess the demyelination phase and the remyelination phase. Degenerative illnesses caused by inadequate fatty acid intake are among the leading causes of death for 23% of people in wealthy developed countries. Western lifestyles promote peripheral inflammation and neuroinflammation with unhealthy diets. I mean here the abnormal distribution or abnormal ratio between omega-3 and omega-6 because in the Western diet it is about 1 to maybe to up to 25, and this is unhealthy, while it should be 1 to 1 to 1 to 4 maximum. The gut-brain axis controls the degenerative diseases response, so therefore, through regular probiotic and dietary fiber ingestion, this biotic rehabilitation decreases mental diseases. Synthetic neuroprotective drugs, as we knew in the previous session, are thought to have side effects, including fatigue, drowsiness, numbness in the upper and lower extremities, balance issues, nervousness, and so on. So the scientists have focused, therefore, on developing new neuroprotective agents. What are adaptogens? Adaptogens are plant-based medical and nutritional supplements that improve the living organism adaptation, resilience, and survival, and most important, without harming the body's homeostasis. In this regard, you are going to talk about the seaweeds. Here in this photo, we have many examples of seaweeds. There are thousands of seaweeds. So they can be regarded as neuroprotective adaptogens. Why we use the algae, and what are algae? Algae are two types, two main types, macroalgae, which are seaweeds, and microalgae. I worked by both. Fortunately, microalgae are seen only under microscope, not seen by the naked eye, and they are monocellular. While macroalgae are the larger algae that we can see in the sea. For example, the nori for sushi is one of the red algae species that I used one of them in this research. What are the advantages? They are available even in Saudi Arabia as raw, and also available as pharmaceutical forms. They have no or low toxicity or side effects. and they have abundant, they are abundant sources of bioactive compounds. Marine-derived natural substances have shown promise in exhibiting a range of pharmacological effects, such as anti-diabetic, anti-inflammatory, antioxidant, anti-cancer, and anti-obesity action. Okay, there is a lot of paper talking about that. Our paper was the first to use Palmaria palmata, which is a rhodophyta, and called also as dots. This family comprises about 7,000 of species. Seaweeds contain, as I said, diverse bioactive compounds like proteins, sulfated polysaccharides, polyunsaturated fatty acids, vitamins, minerals, phenolic compounds. All of these can be used for nutrition, for medicine, and industry. The valuable red macroalgae Palmaria was disregarded in the research, so this urged us to use it to try its efficacy. It contains polysaccharides, which represent nearly half its dry weight, and thicken and form gel that can be used in medicinal compounds and industries. So what provoked us? Debilitating course of multiple sclerosis, unavailability of complete cure, as we no availability of edible seaweeds in Saudi Arabia, safety of natural sources compared to synthetic drugs, intricate relationship between the brain and the gut, that was the core of our study, and the 6 differences in in multiple sclerosis incidence and the causes. We assessed this also. Study objectives to evaluate gender difference in structural, behavioral, and microbiome levels, and to explore the Palmaria palmata impact on multiple sclerosis and the gut microbiome. Rapidly, we did characterization of the Palmaria palmata. We assessed the fatty acid content and the antioxidant capacity. Then we let the animals to acclimate for 1 week. Our group of animals was 88, half female and half male, to assess the 6 differences. We we used Caprizone and Palmaria by oral gavage, and for the control group only with distilled water, and the control positive group for Palmaria, we added Palmaria to the distilled water and continued for 5 weeks, and stopped the Caprizone to allow the mice with Caprizone to remyelinate again, and we continued with Palmaria to assess the rapidity, of myelination in this group. And in both, at the end of the 5th week and the 7th week, we did behavioral assessment in the form of open field test and grip strength, and also did microbiome analysis and histopathology. This is the open field and fatty acid, we found omega-3 fatty acid, EPA and DHA, and omega-3, but nearly in equal percentages, which is good, and it has antioxidant capacity. Regarding the grip strength, Caprizone reduced the grip strength and it was recovered with better female effect. Open field test, we did central preference and mobility for movement, distance, travel, and velocity. Central preference and mobility for anxiety, distance, travel, and velocity for movement. And the finding was increased anxiety level and mitigated by Palmaria palmata. There is a lot of talk here, but this is the microbial community diversity, and I'm not going to talk about it for the limited time. Here we find that there is significant difference regarding the age and the sex. This is a lot of talks here. So, and regarding the histology, we found that the demyelination state, Palmaria palmata, Palmaria, just 1 minute, Palmaria palmata, and reserved the structure in the demyelination and led to lower cellular infiltration, so better results in demyelination and demyelination stage. The degenerative disease are linked to inadequate fatty acid, healthy fat, omega-3 and omega-6, reduced cognitive decline, and the lipids in Palmaria palmata are greatly absorbed and contribute beneficially to health. I have to escape all this. So the gut microbiota influences immune and brain function. Gut-brain interaction are multifunctional and bidirectional. Gut microbiota may help reduce stress and anxiety. I will jump to conclusion. Just limitations of these studies that we didn't establish a specific pathway linking gut microbiome, and it was the first study to examine the impact of beneficial impact on Palmaria palmata on male and female, and we solely assessed the preventive and the need to assess the therapeutic role of Palmaria palmata, and as a conclusion, Palmaria palmata shows potential as a prebiotic in mitigating multiple sclerosis effects through the neuroprotection and the microbiome modulation. It can be beneficial for at the risk group as preventive measure against multiple sclerosis. And I will be grateful if I have your feedback, and I'm sorry for not finishing all what I wanted. Thank you so much.
Thanks so much to all our speakers. For the interest of time, we'll skip the panel discussion, but we'll take questions. If there's any questions, one question for every speaker. All right. Well, me, my friends, I'll go to the other one. Hello.
Yeah. In terms of genomics,
في mic?
Yeah.
Question لمين؟
Thank you for all the speakers. So for Dr. Asma, in terms of genetics, what is the difference between a human and mice that could affect your results? I mean, there is differences that could affect, we with mice agree up to 90% in terms of genetics. So what would be this differences could affect your result or not? Thanks.
So his question about the difference, we have to accept that it is a model, and the translation into a man will take a little bit of time. Between the man and specifically, what do I know about the differences? I don't know. I have to count them. I have to know in the term. We know that more than 98% of the genes are expressed in human and in mice. But what is exactly the matching between the aged mice, for example, and aged human? I don't know.
Thank you so much. What I know is differences.
Just yes. Please.
Yeah. What I know there is differences in terms of dealing with antioxidants. So please just take it in your consideration for future your outcome. Thank you so much.
Thank you very much.
Allah يعطيكم العافية. Just like to have quick question for Dr. Hind regarding the MSCs available treatment. Is there any data or result regarding using the bone marrow transplantations for the MSC?
Yes, this is a good question. And actually, yeah, and it's already has been used for selected patients. They do the bone marrow transplant after giving an aggressive chemoablation therapy, and then they do the bone marrow transplant. But because it's a very aggressive procedure, it's reserved for like highly active patients who failed like 3 or more treatment, but it is available even in the Minectrans guideline for MS3. So we do it, okay? There's some mild form that they do mesenchymal cell or some cell transplant without chemoablation, but the results are not promising.
I would like to invite all the speakers to stay here just to give them their words.
Dr. Nice,
For me,
yes.
okay.
Thank you for creating this session.
Thank you.
يعطيكم العافيه جميعا. We two announcements. One is we have a stem cell domain, registry, and they're accepting donation. So everybody is welcome to register their name and maybe donate in the future or donate right away. That's one. And the second, we're gonna resume at 1. So please, يعني حتى the students, the post sessions, they all need to be back at 1. Thank you very much.
We would like to start our session number 3. Please let me introduce our moderator for this session. Dr. Fatma Basingab is an associate professor of tumor and immunology. She holds a PhD degree from Bristol University, UK. She worked as a postdoc in the molecular medicine school at Bristol University for a year with Dr. David Morgan, focusing on the co-inhibitory molecules, TIMT, from cancer patients. Our next moderator is Dr. Al-Khattabi, replacing Dr. because she has left already. Dr. Hiba is an associate professor of the Department of Medical Laboratory Science, Faculty of Applied Medical Science, Vice Dean for Postgraduate Studies and Scientific Research, Genomic IGMS.
Okay, we would like to welcome our first speaker for today, Dr. Naif Al-Muntashiri, who already has been a moderator for the last session, already has been introduced, but for those who did not know him, Dr. Naif Al-Muntashiri is an associate professor of medical genetics at Taiwan University. He received his PhD in cardiovascular genetics from University of Ottawa. He is the only double board certified in clinical molecular and biomedical genetics by the American Board of Medical Genetics and Genomics. He signed out more than 20K genetic tests. He is genetic consultant for major hospitals. Please welcome with me Dr. Naif.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizing committee for inviting me to join you here in this very nice conference. I really enjoyed it. It's one of the best conferences that I've ever been to. Actually, we're trying. I was hoping that I would present this talk before the lunch. No, I'm a bit heavy now and slow. So I was planning to take less than 20 minutes, but I guess I'll go to 30. I'll take my full time. So today I'm going to talk about our study. It was started back in 2019, just before the COVID time. Then with every conference, a local conference that I attended, a cohort grew. So it's all thanks to the local conferences for knowing local contributors and investigators. We were able to grow to what we are now, a big cohort. It's in the whole Gulf region. So today we'll be talking about the studies, the nuclear and mitochondrial genome of the mitochondrial disease in the Gulf countries. So I'm sure many of you here know the mitochondrial disorder. They're really very bad diseases. They can be multi-system, affecting multiple organs, especially the organs with high energy demands, like heart, muscle, brain, blood, and other organs. Or sometimes they become they can be isolated, like eye disease or muscle disease, so they're really heterogeneous group of disease. And the manifestation can be as early as congenital or even sometimes prenatal cases. Now we have some new genes where it's prenatally we can tell that there's mitochondrial disease, and it can be as a late onset or adult onset diseases that affect either the mitochondrial function or structure or the content of the DNA. We call it like DNA depletion syndromes. The global mortality rate associated with mitochondrial disease is, here I'm talking about global mortality rate in non-consanguineous populations, not like the Saudi population. So please keep this number in mind. 14% is the global mortality rate associated with mitochondrial disease. And here I'm also talking about Mendelian mitochondrial disease or monogenic form of mitochondrial disease at the age of 6 years. Okay, so this is like the median age of 6 years. They hit the death point. Mitochondria also, as you know, there's two types of DNA in our body or on our cells. There's the nuclear and there's the mitochondrial genome. This is my favorite MCQ question always in the exam for my students. What two organs, like nucleus and mitochondria? So, but you would be surprised, I'm sure, for those who are not in this field, that the majority of the disease is caused by something else. The mitochondrial disease, when we talk about caused by mitochondrial DNA mutations, we're talking about mutation inside the mitochondria as part of the mitochondrial genome, which is about 37 kb length of DNA. And it can be point mutation. When we talk about point mutation, single nucleotide changes, same like the one that cause MELAS syndromes, or single or large deletion or duplication in the mitochondrial genome, like the one that cause Pearson syndromes or some of the ophthalmological diseases because of a common 5 kb deletion. So this is type of mitochondria that are caused by mutation in the mitochondrial genome. Now, you would assume that from the name that most of the mitochondrial diseases are caused by mutation in the mitochondrial genome. But in fact, about 70 to 80% of the primary mitochondrial diseases are caused by mutation in a nuclear gene. But the protein encoded by those genes function inside the mitochondria. So the majority, especially the consanguineous population, they're caused by mutation, or we call them variants, and nuclearly encoded gene, but the protein function in the mitochondria, whether it's in Krebs cycle, or the respiratory chain complex 1 all the way to 5. So any mutation in the units can cause a severe mitochondrial disease. So it can be either in the structural subunits or in the assembly portions of the 5 oxidative phosphorylation. We have 1, complex 1, 2, 3, 4, and 5 is the ATPase, right? The mitochondria. So it doesn't have to be in the unit, but sometimes in the scaffolds or the ancillary, like the thing that assemble or signals for making the complexes. So what is the current status? Mitochondrial diseases are very hard to diagnose, especially if you do not have access to genetic testing. It's biochemically it's variable. Many of them, or most of them, they will present with lactic acidosis, sepsis-like picture of the patient. Like the patient maybe present with a sepsis-like pictures in the ICU. Also, the clinical feature are variable. For example, within the same family, with the same mutation, you will find a kid or a child or a newborn with a severe disease. But there will be another baby who's born and from the same family, it's a sibling, and he's mildly affected. So this is known for the mitochondria. There is a variability in the clinical feature and a biochemical. Every biochemical disease also is associated with a biochemical abnormality. Usually when we see a lactic acidosis, we suspect, especially if it's like persistent and high, we suspect a primary mitochondrial disorder, but not all mitochondrial disease presents with lactic acidosis. Or when you do urine organic acid for the patient, you will see fumarate, succinate, lactic acid elevation that will tell you that there is primary mitochondrial disorder. So now, it used to be the muscle biopsy invasive testing for enzyme and invasive study, biochemical invasive study, staining study. But now with the age of next generation sequencing, with the cheaper prices of the whole exome, whole genome, genetic testing becoming the first tier test. So if you do the genetic testing and you find the mutation pathogenic, then it's a mitochondrial disease. You get a biochemical diagnosis and clinical diagnosis of mitochondrial disease. Usually, sometime if we have mutation in a gene, but the mutation is of uncertain significance, we have to go and do some invasive study just to confirm that this is really, going with the variant to identify. But now, most of the labs or most of the hospitals, they always go to a genetic testing. But the thing is, we do not have really good genetic data for our population. So most of the known mutation or likely pathogenic mutation, the mitochondrial diseases or gene, they are coming from populations that are not relevant to us, and most of the mutation we identify are variant of uncertain significance, which is really nightmare when you counsel or when you try to make a diagnosis. So this is the reason why we thought about this study, is just to have a comprehensive clinical genomic database for mitochondrial disease. So just imagine how much this will save in terms of a saga of clinical testing and biochemical testing and invasive testing to diagnose. If you have a database where you go to find the mutation, if it matches your patient and you saw it in other patients, then it's a diagnosis, right? So that's the point of this study. So we designed a study where we reached out, it's retrospective, to all the major hospitals in Saudi Arabia. So we're talking about like the major metabolic hospitals. Then it was a success, actually. Then our colleagues from the other Gulf countries joined us. So in an aim to build a genetic database, make the diagnosis of mitochondrial better. So this is the general study design here. So as you can see, King Abdulaziz University also is part of this study, and there's a success story of finding a novel gene in collaboration with some of the investigators here. So this is not an updated slide. Now the numbers are more than 800. Now we are around 1,200, 1,200. So we have from all across the Gulf region, we collected or recruited families. So for the families. So families, so we have from Kuwait, from all centers in Saudi Arabia, from Bahrain, from UAE, Qatar is coming. So once we collected the family, we started analyzing, and the analysis was another legwork actually. It was hard actually because we had to reanalyze. Some of the reports were old as 2010. Some of them they are really, we do not have enough information, so we have to go back to the hospital and try to get more information. The baby was diagnosed in year 1 or day 1. Now we have to see what happened to the baby. So we recruited the family. We found patients with confirmed, so they're solved. So they have pathogenic or likely pathogenic mutation in a known mitochondrial disease. And there are some families, and they're not the majority, they are like 10%. They have a suspicion of mitochondria. Why we call them suspicion? Clinically and biochemically, they have a mitochondrial picture of disease, but the mutation were not conclusive. We found variant of uncertain significance in this family. So there is another a line of work we've done to this family. So in total, we had about 600 families with confirmed diagnosis. About 87 families, they have a suspicion. So there's still more work to be done on these patients. So we'll just talk about general characteristics. You know, the consanguinity rate in our population ranges from city to city and region to region. Can be as low, and it's not low, 60% to as high to 85% in some region of the country. So you will not be surprised that the consanguinity rate in our study is 90%. So most of the patients are consanguineous. And 10% are non-consanguineous, but we cannot exclude the tribal consanguinity because they are from the same tribe, but they're not relative. So now there is a new term called tribal consanguinity. So there's always, sometimes we find the mutation or we ask about the family, then we'll know what the mutation is. You know, a family in Medina, some tribe of Medina, or in Janub, or so. But these are, we cannot exclude, maybe it's as high as 95% consanguineous rate. Now, you remember I told you, remember the number of mortality rate in non-consanguineous population? It was 14%, right? So the mortality, we'll talk about it later, but the age of onset. So the age of onset in our study is 6 months. So that's a median, but it can be as early as a prenatal. And the median age as diagnosis is 2 years. So the median age is at diagnosis is 2 years. So just imagine how long it takes. It's about 18 months to diagnose the patient from the time of the appearance of the manifestation to diagnose the patient. It takes 18 months. That's a long time, right? And you cannot do anything. It's just a diagnosis and the saga, and it's a burden to the family, to the patient. And there are families with 2 or 3 affected, so they cannot even know the cause of their disease. So that's reason why we need genetic testing introduced early. So what is the confirmation rate in our study is, So what is the confirmation rate in our study? Confirmation rate means like the percentage of patients with a positive diagnosis. 89% and 11% have a value of uncertain significance, and they are again very interesting group. It is we call them the gold mine because there is a room for discovery. Some of them they are not what we thought are. So now we'll just zoom into the group with confirmed diagnosis. They're very interesting also. Again, there's no such study, a large study that studied our population and tells you what we expect and what type of disease that are most common to be targeted and to be prioritized when diagnosing or when approaching a genetic disease. So, for example, what type of assay you need to or test to order for mitochondrial? If you are a clinician and you are suspecting a mitochondrial disease, what is the right test based on a population relevant data? As you can see here, 99% of our patients, they can be tested and solved by just sequencing assay. You don't have to go through chromosomal assay arrays or other tests that are, just go to next generation sequencing. Only 7 cases, they were solved by deletion duplication assay. It means like we need an assay that can detect large deletion and duplication. And now with the NGS, the new ones that we have in the labs, you can even solve the 7 cases by the sequencing-based assay. So you face a patient with, reasonable and high confidence by mitochondrial disease, then you should start with the NGS. I'm talking about whole exome sequencing first as your first tier test. Genetic etiology. We said that the majority of the mitochondrial disease is caused by mutation in nuclear genes. But just imagine if you have this information and you have the fact that this is a consanguineous population, then the rate of recessive disease will go higher. So about 88% of our patients have recessive diseases due to mutation or due to variants in genes that are nuclear in nature. About 12% are due to mutation in the mitochondrial genome. And again, this goes with the fact that this is a consanguineous population. As you can see, 97% have recessive disease. Okay, so this goes with 95% or 90+% consanguinity rate. Only 4 cases there was autosomal dominant and 14 extinct. What are the top 10 nuclear genes? I mean, the top 10, or I would say I would start with the top 2 genes, SK2 and FBXL4. These are the top 2 genes that are associated with mitochondrial disease in our population. And there are stories behind this. These genes were discovered by Saudi groups in Saudi Arabia in 2012 and 2015. Just imagine if there is no research done on our population, this gene will be, but most of these patients, the majority of the mitochondrial patients will be not diagnosed until today. So these are diagnosed, first discovered, and now as part of the clinical genome by studying Saudi population. That's adds to the value of research in population-specific, context. So the top 10 mitochondrial diseases is, this is for or any tradition, you would say right away it's mitochondrial DNA depletion syndrome. It's a mutation in genes that are required for maintaining the DNA contents of the mitochondria, or sometimes the nucleotide that makes the DNA of the mitochondria. So the majorities are mitochondrial DNA depletion syndrome, then it becomes the mitochondrial dysfunction syndrome, and the combined oxidative. Combined oxidative means the patient has a mutation that causes a mutation or abnormality in the 5 complexes of the mitochondria. So it's completely production. The mitochondria is not functioning anymore. When you do Western blot, for example, or you will see that there's no assembly of complex 1 all the way to 5. But this is also important. What is the mitochondrial disease that are associated with high mortality rate? So these are the ones. So if you have mitochondrial disease, suspecting some mitochondrial disease with a high mortality rate in this family, and these are your top diseases that you should think about. This is also interesting because some of the genes, mutation, are not tolerated. So if you have a homozygous loss of function in any of these genes, for example, RRM2B and EGOG, these are lethal. So if you have a mutation, it's a matter of time, either die within the first few months or die later in life with mutation, because the mitochondria is completely gone. So this is what I was talking about, the median age of, or the average, or the global mortality rate. In the non-consanguineous population, the global mortality rate was 14%. Now look at the global mortality rate in our study. It's 43%. It's too much, right? Now this can be easily explained by the fact that the non-consanguineous population, like the European or other population, they are not consanguineous. So there is enrichment of mutation in mitochondrial gene. And mitochondrial gene is subjected to heteroplasmy, homoplasmy, the number of mitochondria or affected mitochondria in each tissue. But if you are consanguineous, then this consanguineous population, so going from 14% to 43% mortality rate, this is because germline, every germ cell, every cell in your body is affected, compared to some cells or other cells or tissue-specific affected cells. So that explains the high mortality rate associated with the mutation in nuclear recessive gene. So this is what, I mean, here we stop at the fact that these are all that we just talked about are solved cases. These are mitochondrial cases that are recruited, and we know that these are solved. The family or the clinician can start the care, and they can get BGD and other testing to prevent the disease. But the laborious one, and the one that is really associated with significant dilemma burden, even in the clinic or in the lab, is the cases with variant of uncertain significance. What should we do? We cannot act on them. We have to do some more work. So what was our approach to solve these cases? So usually we have patient with VOSIS. VOSIS is, again, it's variant of uncertain significance. So when we receive the data, we pulled all the data from all the centers. Okay. So then we have a bigger data and bigger power to really reclassify some of the variant with VOSIS, variant of uncertain significance. But when we put all the data together, we found that other patients, they have the same mutation from other cohorts. So now we classify them and they become positive and pathogenic. Some of them, they were diagnosed with mitochondrial disease due to mutation, but we found it's B or LB, benign or likely benign. So we excluded that gene, and we have to give the patient a new diagnosis or search for a new diagnosis. Some patients were still, like, even after reclassification, they were VOSIS, variant of us. We do not have enough data, so we have to go through the functional route, which is painful. And some of the patients, again, we classified them as benign, likely, pathogenic, likely pathogenic, and so. So we issued a new report to the family. Hey, we have a good news. You are diagnosed now with mitochondrial. It's a good news in a sense that they do not have to search for diagnosis anymore, and they can use this data to plan their reproductive options. So, but for the bosses, the one in the middle here, is there a pointer here? Doesn't work with the screen. Huh? Doesn't work with the screen. All right. Well, both in the middle here, uncertain, and sometime we hit this one here. That's all right. So sometimes we analyze and we end up with candidate genes. I mean, what I mean by candidate genes is mutations in a gene that is not known to be associated with human disease. This is the discovery gene. So we look at that gene. Usually, we find studies in animal where knockout, for example, deleting the gene in the animal causes mitochondrial disease, and the patient has a deletion homozygous. It makes sense, right? So we take it to functional study. But first, what we do is we go to other collaborators, other clinical collaborators, and we ask them, have you seen patients with a mutation in this novel gene? Then if we find another family, or third family, or fourth family, then we can proceed before investing in something based on one family. So I'll give you some examples now, and it's very interesting that in this study, I'm just giving two. Usually, these are the number of novel genes we discovered. About, it's more than this. Now it's 15 or 17 here, but now, till yesterday, we reached 25 genes, novel gene discovered, novel syndrome, this study. And these are genes that are affecting different parts of the mitochondria. Some of them in the respiratory chain, some of them they cause combined oxidative phosphorylation deficiency. Some of them they affect the ribosomal assembly and the function. Okay, almost there. Some of them they affect the mitophagy, the ability of the mitochondria to degrade and to control degradation. And some of them in the Krebs cycle. So we recently published Me2 as one of the Krebs cycle novel syndrome associated with the Krebs cycle. But today I'll give you two examples of two candidate genes that we discovered and we replicated in different families. Then we took them to the functional study based on patient cells, and we proved that they have a deficiency in their, mitochondria. So the first one, or the first gene that we talked about is a case. I mean, this is one of the cases. I don't know if Dr. Tabrid is here today, but it was a patient from Dr. Tabrid. She sent me this family. She said that they do not have a diagnosis and they're negative. So can you just look at, given that the mitochondrial cohort, can you just look at if there is any candidate gene? So they are. This is a 22-year-old boy admitted with a history of sepsis, like pictures, so it's lactic acidosis. There is a developmental delay, and there's some neurological abnormality with microcephaly. And also, they have a family history of another affected sibling, so a male sibling, who's affected with the same condition. So first, just before investing in anything, we took urine sample and we did urine organic acid analysis, and we found the elevation of lactic acid, succinic acid, and other Krebs cycle. So this is always when you have this combination of some metabolite like this is the suggestion of primary mitochondrial defects. Then we did whole exome sequencing, and we found a mutation in a gene called DMAP2. DMAP2 is a subunit of complex 1. It's required, it's just send signals to complex 1 to assemble. So if you do not have DMAP2 or loss of function, then you have complex 1 deficiency. So as you can see here, the two patients with the black boxes, they are mute means they are homozygous for the mutation. Second family, so now we have to look at our second family. Then I reached out to Dr. Mahazaki from Cairo. So she had another patient with DMAP2 mutation, different mutation, but in the same gene. And this is the mutation, and with the same phenotype. We have then a third family, but from where? From Al-Quds, from Palestine. There are two siblings also with the same mitochondrial disease, same phenotype, and they have different mutations. So now we're ready to go to functional study. We biopsy, second biopsy, skin biopsy, and we expanded the fibroblast to test them and look at the complex 1 deficiency. course, I mean, all the patients have this characteristic urine organic acid phenotype. Then we found that Mike Ryan in Australia is the one who worked with this gene and proved that this is complex 1 deficiency gene and it's required for mitochondrial function. Then I don't know how many minutes we have, but we looked at the mitochondrial complex 1 simply, and as you can see, these are all functional studies, but the one in the last one here, no, the one in the middle, contained the patient fibroblast. All of three. So see the second one after control 2, and maybe I use the mouse, I don't know. Oh, here? Okay, well, you're right. I'll use my hand here. This one here. Where is it here? Which one? This one? This one? Okay. Well, you see here, this is the patient's cells here. So this is DMAC2. This is the Saudi patient. This is the Palestinian patient. As you can see, this is complex 1. This is control. There is a complex 1. In the both patient, complex 1 is gone. It's not there. So they have complex 1 deficiency. Now we did CRISPR editing. Then we tried to put back the wild type. And as you can see here, here is the mutant. But when it was edited, complex 1 came back. So this is the mutant. The mutation caused the disease. When you correct it, you bring back the function of complex 1, right? So this is a novel complex 1 deficiency gene. And this is also a proteomic study we've done. We confirmed that, as you can see, I'm going back to this one. So as you can see, we did all sorts of studies, but as you can see here, there's complex 1 downregulation here, and all other complexes like 2 to 5, they are not affected. So it's really complex 1 deficiency. We took muscle biopsy also, the muscle, so they are also complex 1 deficient. So this is the last case, so 2 minutes I need. So this is the second case of another gene we discovered. Actually, it's 2 patients now. Okay, well, I'll go to this one quickly. Third case of mitochondrial discovery. This is the PBTC7 gene, a family with hypomyelinating leukodystrophy. So the myelin is not formed in these patients, 2 patients. And we could not find any mutation after we analyzed them. They used to have a mutation in the gene, but we found it's a benign. So we had to look for a new one. And we found both patients have mutation in this gene called PBTC7. PBTC7 is a master regulator of mitophagy, of the mitochondrial autophagy or degradation. So it regulates the mitophagy receptor. So if it's not there, mitophagy will be accelerated. So you will lose all the mitochondria. It will be increased mitochondrial degradation. If you don't have mitochondria, you have deficient energy production, right? So again, there's another group. I found another group worked on this gene. They have knockout mice, everything fine. And the patient exactly have the same phenotype of the mouse. And in fact, they have looked at this residue that has changed in mice, and it's also deleterious. All right, so we take the muscle biopsy, the skin biopsy, and we've done electron microscopy imaging. And again, you can see here there is enrichment, there's autophagic vacuoles, and there's some vacuoles here that has a mitochondria degraded inside it. But this is the control here. This is patient 1 and patient 2. They have autophagic vacuole fill of mitochondria or degraded mitochondria, and there is widening or vacuoles in the endoplasmic reticulum. Also, this is a phenotype that was seen in the knockout mice. And this is the patient fibroblast. We look at the immunofluorescence. So what we did here, we took the patient fibroblast compared to healthy controls. And as you can see here, confused going here and there. All right. So this is control fibroblast. This is the patient fibroblast, right? Here untreated. They are non-treated. NIX is a mitophagy marker. If it's elevated, that means there's increased degradation. Okay? So as you can see here, there is NIX is not nothing. This is a zoom in, okay, of this. So there is few cases of few mitophagy events. But look at the patients, look at the mitophagy. the mitochondria are almost degraded, all of them. And the patients are really severely affected and handicapped, and they are really regressing. I don't know if they will make it to the next month or not. But look, when we did a treatment, PFO is a chemical that induces mitophagy. So when you induce mitophagy in healthy cells, see they start developing this degraded form of mitochondria when you look at NICs. But in the patient fibroblast, there's no, the mitochondria is degraded. So it is the same with or without treatment. And also you can see here the level of the mitochondrial markers or the degradation marker NICs and BNF3. These are the mitophagy receptor. If you have a mutation in BBT7 and increased degradation, you will see elevation of this marker. And as you can see, in the patient cell, there is elevation. In the control, there is low level of mitophagy markers. So gene matching is ongoing. So if any of you have patients with mutation in this gene or normal gene, reach out. We may have a match. And for the sake of time, I'll skip the discussion, and I would like to thank the funding agency, the RDIA, and thank you so much for you and for our collaborators. And I'll take any questions if there is any time.
Thank you so much, Dr. Naif, for your insightful talk. Now, our second speaker, Dr. Faisal Al-Husseini, who was a moderator in the first session, which already introduced him. For those who missed the introduction, Dr. Faisal Al-Husseini is currently an assistant professor at the Department of Medical Physiology, Faculty of Medicine in Rabat campus. He graduated in 2014 from Maastricht University. He then worked as a physician for 2 years in the Kingdom of Saudi Arabia. Then he got his awarded a scholarship to pursue his doctorate degree at the neurosurgery department of Maastricht University. His dedication to learning, teaching, and research has shaped his journey. Welcome, Dr. Faisal.
Thank you. Thank you so much for this opportunity to present our recent work about long-term neurosurgical alteration of subchronic nucleus deep brain stimulation. This is a post-mortem human brain study. So, to begin with, Parkinson's disease is the second most common disease worldwide, affecting millions of people, and it's characterized by motor symptoms, including tremor, which is described as shaking, hand shaking at rest, muscle stiffness, rigidity, and bradykinesia, slow movement. In addition, non-motor symptoms, which can range from cognitive impairment to mood disorder and sleep disturbances. For several decades, the primary treatment for Parkinson's disease revolves around the concept of dopamine replacement therapy. Dopamine is a neurotransmitter which helps in controlling the movement, and its deficiency it's due to the degeneration of dopamine secreting brain region substantia nigra, and however dopamine therapy have its disadvantage. One major issue is the fluctuation response in some patients, that the patient have a period of improvement of the treatment and a period of worsening the symptoms. So this is led to discover and approach other treatment options such as deep brain stimulation. Deep brain stimulation is has become standard treatment in several movement disorders, such as Parkinson. However, it requires surgery and implementation of electrode in a specific brain area to induce an electrical stimulation, and this electrical stimulation reduce the neuronal reset the neuronal activity in that area and improve the motor symptoms. However, it has the surgery complications such as the post-operative complication, such as hemorrhage, infection, or discomfort, and it needs a routine battery change, and also sometime a replacement of the electrode lead. And in addition, it has a cognitive and mood side effect. In addition, because of this mood change in mood, we researched the literature about the histological changes in the STM caused by deep brain stimulation. In the literature, STM-DBS does not lead to a significant cell degeneration, neither a significant gliosis around the STM. Present in BD and Parkinson patient, and compared to Parkinson that not treated with DBS but treated with other medication treatment. In addition, DBS does not influence one of the major theory about the pathology of Parkinson. It does not influence the density of alpha-synuclein deposit in the affected area, mainly the substantial nigra. This suggests that the DBS is, in some instances, it's neuroprotective or neutral. Does not prevent the progress of the pathology. However, the long-term effect of DBS remain a topic of interest. So this sparked our interest to dig in long-term effect of DBS. So, as we said, the cellular change is not fully understood. So we hypothesize that DBS can induce cellular and neuroplastic changes in the long-term subthalamic STM stimulation caused by therapeutic and potential side effect of the deep brain stimulation. So our current plan is to assist this cellular alteration around the STM, combining deep brain stimulation treated group with BD, and we have investigating the following factor: the cell density and the inflammation. So we have collected from the Dutch brain bank 6 samples from BD patients and 6 samples from BD patients treated with DBS. It is post-mortem human tissue, and it includes the STM region and paraffin-embedded blocks. And we make sure that from the neuropathological report that they have been treated chronically with deep brain stimulation of the subthalamic nerves. So, in order to define our plots that we received from Dutch Brain Bank, we have used a human atlas, and then we define the SCN. And the SCN, we have defined the subdivision of SCN that is important for deep brain stimulation. The dorsolateral part, and the dorsolateral part is the subregion that is responsible for motor function, and the ventromedial part of the SCN is the region that is for non-motor stimulation, and DBS for the Parkinson's disease are usually implanted in the motor or the dorsolateral part of the SCN. So we did the following experiments: histology, HNE to localize STN electrode, NISL for the cell morphology, and also we did several immunohistochemistry. We finalized the first 3, the GFAP, IBA1, and also 8-hydroxy deoxyribonucleic for as a DNA marker for oxidative stress. So for hematoxylin azine, we have confirmed the electrode trajectory, and you can see here. Here is the dorsolateral part of the STN. The STN electrode has fibrotic tissue, which confirms that the electrode lead have been inserted in the target of the DBS in the dorsolateral, the motor region. Okay, so our result, we first quantified the cell count in the STM, and we found a significant cell loss in the dorsolateral part of the STM, and this was not shown in the non-motor, neither the DBS treated group. Next, we move to the GFAP cell count. GFAP cell count, we found an increase of GFAP in the entire STM, and this was significantly different when treated with DBS. So it was a significant reduction of GFAP cells in group that treated with DBS. IBA, we didn't find difference in IBA1, and this even we found a trend effect in DBS, but we thought that it is a physiological counterbalance of GFAP cells, so it's most likely the GFAP increasing in the BD is due to the dysfunction of glutamate system, and it's not part of inflammation. Oxidative stress was less inconsistent, but this inconsistency we think is because of the remarkable cell loss in dorsolateral that will prevent the expression of oxidative stress. So we will, in the next cohort, we will change the analysis to study the cell morphology rather quantifying the number of the cell density. Conclusion, there is a significant loss in the dorsolateral STN compared to the ventrolateral. So this changes was not observed in the DBS. The STN, the dorsolateral STN, the motor, was more affected, and it shows that it's part of STM pathology, because some theories say part of Parkinson, that the glutamate is overexcited. Glutamate neurotransmitter is overexcited, and it's part of BD pathology. IBA1 was not significant, and this could rule out the part of an inflammation process in this data. And the oxidative stress result was inconsistent. So we believe that this is inconsistent oxidative stress cell quantification might be due to the remarkable cell loss in the dorsolateral STM. So because of that, we will do follow-up and ongoing work. Next, we will study the vascular marker, alpha smooth muscle actin, to see if DBS had an effect on the diameter of blood vessels, because one of the theory that DBS therapeutic effect is increasing the blood flow in the brain. So we're gonna do this staining and other glutamate marker using vClot, and to confirm that the glutaminergic system was affected in the STM, and also the serotonergic fibers because from our previous work, we found that the STN causes really major depression and cognitive impairment. So we thought that might be also the projection of serotonin from other brain area to the STN might be also affected. So it's worth evaluating the serotonergic fibers projection to the STN, and also finally the neuronal integrity marker, as DBS and BD have neuroplastic changes in the cellular mechanism. So we believe that the synaptic integrity have been affected, and we will assess that in the next cohort. Exactly. Yeah, finish. Thank you so much.
Yes, sir. Thank you so much, Doctor, for your nice talk. Our third speaker for today, Dr. Muhammad Al-Khlafi, is an associate professor of pharmacology in Taiwan University. He received PharmD degree from King Abdulaziz University, awarded PhD in pharmacology and experimental neuroscience from the University of Nebraska Medical Center, United States. He published around 30 articles and one book chapter. He has a patent on device that measure gained in rodents with neurodegenerative disorder. He received 5 scientific awards, and we would like to welcome Dr.
Assalamu alaikum wa rahmatullahi wa barakatuh. After 15 years, it is nice to be standing here as King Abdulaziz allowing us. Once as a student, so today I'm privileged to be standing here as a speaker. So I truly appreciate King Fahad Medical Research Center and the organizers of this conference for this great opportunity. So today we'll be talking about a novel Parkinson's disease, rat model characterization and validation. As we know that animal models are an important tool to study neurological diseases, especially neurodegenerative disorders. So Parkinson's disease is considered as the second most common neurodegenerative disorder, and it is also the most common neurodegenerative motor disorder in aging brain. The disease was first described by James Parkinson in 1817, and around 70 years to 80 years later, the degeneration in dopaminergic neuron and the substantia nigra and the involvement of dopamine has been described. So after almost 2 centuries of Parkinson's research, now we know that Parkinson's disease is characterized by the loss of dopaminergic neurons in the substantia nigra. And pathologically, it is also characterized by the presence of eosinophilic inclusions known as blue-body, containing alpha-synuclein and ubiquitin. The neurosurgical pathway is made up of dopaminergic neurons, whose cell body is located in the substantia nigra, and their projecting axons and terminal are located in the striatum. Once Parkinson's disease patient loses 50 to 80% of dopaminergic neuron, then Parkinson's symptoms will start to appear, including tremor, rigidity, echinacea, and postural changes. There are multiple risk factors that might contribute to Parkinson's disease, including age, gender, ethnicity, and environmental toxins. Talking about environmental toxins, Dr. William Langston, who is a neurologist in the state of California, in the 1980s, he discovered that a young drug addict have been coming to the ER with a Parkinson-like symptoms. further discovery, he found that those addicts were taking contaminated heroin. The heroin was actually contaminated with a chemical substance called MPTP, or methylphenol tetrahydropyridine. Injecting MPTP into mice, those mice started to show behavioral abnormality as well as degeneration of the dopaminergic neuron in the substantia nigra, as well as losing the projection of the neurons in the striatum. Further exploration and studies on the mechanism of action of MPTP has been found that MPTP, once it crosses the blood-brain barrier, it gets uptaken by glial cells and then get metabolized into MPP. MPP then block complex 1, leading to the neuronal degeneration we see in those mice. And this actually highlighted the importance of the mitochondria in Parkinson's disease. So there are, as Dr. Al-Shek was talking about the importance of the mitochondria in several neurodegenerative disorders, we were very interested about two mitochondrial proteins, the PINK1 and Parkin. Those two genes are linked to the early onset form of Parkinson's disease, meaning that the patient will start to develop Parkinson's disease symptoms before the age of 40. So just to understand what is mitophagy, that Dr. Al-Shek, I'm referring to Dr. Al-Shek because he spoke a lot of things I'm talking about right now. What is mitophagy? Mitophagy is a kind of a macro-autophagy. So it's not on the cellular level, no, it's on the mitochondrial level. So once a damage occurs to the mitochondria, Parkin will get accumulated to the outer mitochondrial membrane. This will recruit Parkin, mediating an epiquination of several outer mitochondrial membrane protein. This will facilitate the formation of autophagosome and then leading to the mitophagy. To understand more the impact of PINK1 and Parkin on Parkinson's disease, we need an animal model. So a PINK1 knockout rats and a Parkin knockout rats were generated. PINK1 showed actually a degeneration of the dopaminergic neuron in the substantia nigra, while Parkin didn't show any changes. Also, when we speak about a behavioral study, Parkin showed some motor deficit, while Parkin didn't show any motor changes. In addition, in rats, neither PINK1 and nor Parkin knockout mice showed any neurological changes or degeneration of the dopaminergic neuron in the substantia nigra, nor a motor deficit. And this is why actually we said, okay, if PINK1 were showing some neurodegeneration, while Parkin didn't, and both actually are playing key role in mitochondrial mitophagy. So what if we generated a PINK1 Parkin double knockout? And we did. And in the beginning, when we looked at the hind limb strength by performing a cylinder test, where we placed an animal in a beaker, and we count how many times does the animal rear or stand on its hind limb. And we found a significant reduction. And so we found a significant reduction at the age of 6 months, 9 months, and 12 months. So the animal were not able actually to rear. And then also we looked at the use of the formalin just to support the rear, and we found a significant reduction at 6 and 12 months. While using only one limb, we saw also a reduction at 6 and 12 months, as well as the use of the right forelimb at 6 and 12 months. So why are we looking at system, right? Because sometimes when we generate Parkinson's disease in rat, sometimes we use a hydroxy dopamine, where we do a stereotaxic injection in one side of the brain, and this is actually induce a difference between the use of the left and the right limb. So we wanted just to make sure that in those mice, on those rats, that there is a degeneration in both sides of the brain. Just so to confirm those results, we took a 12-month-old rat and we put them in an open field, and we just wanted to count the number of rear, the total. We saw a significant reduction in the total rear, as well as a reduction in the unsupported, so without touching the walls. Okay, so to confirm that this is, or those changes is due to a reduction in dopamine, we injected the rat with L-DOPA, and we saw an increase in the number of unsupported rear and a reduction of the supported rear. So next we wanted to, as we all know that Parkinson patients, they show motor abnormality, especially in their gait. So they show that patient takes small steps. And this is why actually we wanted to assist the animal gait. So at 3-month-old animal, we saw a reduction in 8 months, yes, a reduction in the hind limb step length, as well as the step angle and the step pressure. What do we mean by step pressure? Looking at the heat map, we saw that those animals were walking like if they were tiptoeing, walking on their toes, despite that those animals at 8 months, they were weighing around 600 grams. Next, we looked at the agility of those animals by performing a pull test. So we placed the rat facing upward, and we measured the time it takes the rat to turn, and that's the time to turn, and the time it takes the rat to walk downward, and that's the time to descend. And we saw that those animals at 6 and 9 months, they lose their agility, and they show signs of bradykinesia. Then we wanted to count and to make sure that those motor abnormalities are due to a degeneration of the dopaminergic neuron in the substantia nigra. So we counted the number of dopaminergic neurons, and we saw a significant reduction at 6 and 8 month old animals. And these changes in the number of neurons were accompanied by the increase in the level of neurofilament in the plasma at 3, 6, 9, and 12 month old animals. Also, we saw a significant change in the number of neurons in the ventral tegmental area at 8 month old animals. Looking at the one of the hallmark in Parkinson, the alpha-synuclein, we saw traces of alpha-synuclein in the striata, but not in the substantia nigra. And that was actually surprising to us. Also, looking at the CSF, we saw a significant reduction in the number of alpha-synuclein in the CSF of 12-month animals, which was actually consistent with data published from Parkinson's disease patients. In the plasma, it was a completely different since we saw a significant increase in the alpha-synuclein. Finally, we wanted to see if the mitochondria is working fine. And this is why actually we did a seahorse. So this test is done by administrating multiple mitochondrial complex blocker. So at 3 months, we saw a significant reduction in the maximum respiration and in the spare respiratory capacity. What does it mean? Meaning that when there is an increase in the demand of ATP, mitochondria from those tracts cannot keep up with that increase in the demand. However, at 6 months and 8 months, we didn't see any significant changes. Also looking at if the mitochondria in those rats was using glycolysis to produce ATP, but that wasn't the case since glycolysis was similar in the wild type and in the double knockout rats. Then we looked at the mitochondria function from the PBMC isolated from 12-month-old animals. And it was actually similar to what we saw at 3 months old, that there was a significant reduction in the maximum respiration. And with this, thank you.
يعطيك العافية.
Thank you for the very nice lecture. It's my pleasure today to introduce our next speaker, Professor Mohammed Amin Bey. Prof. Bey has been working as a professor at King Fahd Medical Research Center, King Abdulaziz University for the last 13 years. He has a PhD in reproductive biology from India. After finishing his PhD, he moved to the United States for the postdoctoral training at the University of Wisconsin Madison in 1999. Thereafter, he continued as a research faculty at the same university and remained there until 2013, working on endocrine mechanism regulating ovarian function. In 2013, he moved to Saudi Arabia as a professor at King Fahd Medical Research Center. Prof. Bey's current research interests are aging, functional genomic, and fertility in men. Please, everyone, welcome Professor Bey.
Assalamu alaikum. Thank you, Dr. Hiba, for this introduction. And I thank King Fahd Medical Research Center and our advisors for organizing this conference. And I thank also all the presenters for their excellent presentations. And I'm going to talk about aging and metabolomics and fertility decline in men. I see not many men in the audience, and this has been always the case. Whenever there is talk of fertility in men, they are unhappy. So let's move forward. Okay, I'm going to talk on two. You'll hear these two words, fertility and aging, most of the times in my talk. And at the outset, I'm defining them. Fertility is the ability to conceive a child naturally within 12 months of marriage. And aging is a complex process, complex natural process of time-related deterioration of physiological functions associated with health and survival. So when we talk of fertility, fertility is always, it is not a singularity, it is always of a couple. So, and when there are issues in a couple, fertility issues in couple, most of the times it is either male or female, that means 30% in male, 30% in female, and sometimes it is in the both man and woman, and that is 20 to 25%, and in 15% of the cases, it is not known what the problem is. So it is kind of 50-50, male 50-50, female 50-50. And whenever you do treatments and anything, still 5% of the couples remain infertile, so permanently infertile. Now aging is, I'll go back, aging is a very critical factor in fertility in men. Okay, and aging associated reproductive effects are lot of things happen with age. Semen volume goes down, sperm cell concentration goes down, lot of things you can see from there. And one of the most important factors which is not taken into consideration is that even if aged men have children, so those children are having neuropsychiatric diseases and other diseases. So this is an important aspect of aging. And this is a data set from United States on birth on newborns, on 200 million newborns. And I want to tell two things in this. Number one, aging, the most common age groups for men are 20 to 29, 30 to 39, and 40. These are the most common age groups when they have children. There are children present in those fathers who are more than 40 years age, 50, 60, but those are minuscule. Those are not major things. Second thing is that aging has been a shift. There's a shift in aging. You can see from the data set in 1988, more than 50% newborns were born in those young men, 20 to 29 years of age. But now in 2020, you can see that more than 50% are born from those who are more than 30 years of age. So this is an appreciable shift in aging, and this has long-term effects in population. Now this is another, this is from Austria, this is Europe, Austria. This is on the basis of 75,000 newborns. And you can see this is a doomsday scenario. Most of the 60% or 75% of the children are born from fathers who are 30 years of age, or more than 30 years of age. So these are the things that we are going to talk about today, what is going on with these. And why the shift in the aging is there? The shift in aging of fathers is because there is more improvement in health and longevity of population. And more people, they delay their marriages, they delay having children, and they delay that for the sake of financial security, for the sake of career, for the sake of enjoying life, industrialization, higher education, entering into public and private services. So this all what is going on in the world, and shifting the age population also shifts the father's age for having children. So that is having the issues. Now in Saudi Arabia, I don't have the data for newborns, but what I have gathered information from the census to 2022 is that it is projected that by year 2050, 25% of the Saudi population will be 60 years or older. And median age of population is projected to increase from 29 years in 2020 to 40 years in 2050. Then in 35 to 49 years of age group are projected to be majority reproductive age groups of male population in Saudi Arabia. So you can appreciate where we are going, what we need to do for this kind of population change. Our objective was to study age-associated metabolic changes in human spermatozoids. And this research was expected to improve the fundamental understanding of metabolomic role in fertility decline. And due to delayed marriages, a steady number of, this is the negative point of delayed marriage, because due to delayed marriages, a steady increasing number of advanced age couples are seeking fertility treatment. And we need to, our research was to help in discovery of age-related sperm metabolic clinical diagnostics and potential therapies to preserve metabolic status and help in fertility rescue and enhance fertility outcomes in older couples. Now, our methodology first, I want to tell you what is metabolome. Many of the people are not associated with this kind of research. So what is metabolome? Metabolome is the global metabolite pool of total complement of metabolites in a cell to look at global shifts in cellular function under different growth conditions. Metabolomists can help in identifying key metabolome biomarkers responsible for dysregulated biological mechanisms. And this was our experimental methodology. We had 3 groups of men. A young group, which is the reference group, they have the highest fertility, and late adult group, which is the medium 30 to 40 years of age, and we had an advanced age group that is 41 to 50 years of age. For reproductively, 40 to 50 years of age group is known as an advanced group, because most of the changes in fertility start to occur at 25 years of age and onwards, and 40 years of age, there is characteristic decline. and we collected semen samples. We processed them for metabolomics, and we did metabolomics by LCMS, and then we analyzed that by metaboloanalysis, and then sites by informatical analysis and network analysis and PCA and others. And this is going to be, I'm going to present the data, but if anybody has not, because there are some people who may not have seen the spermatozoa, this is spermatozoa, and this is the left side is the scanning electron micrograph, and right side is light microscope. The down on the below is photomeostatation of sperm. Sperm is basically a specialized cell. It doesn't have any. It has minuscule of cytoplasm, and many of the organelles are like Golgi apparatus absent in sperm. They have a head that is mostly DNA. Then they have a midpiece which has mitochondria, and they have a tail which is used for their motility, and that's all the sperm has. And previously it was thought that the sperms are just for transferring DNA to the ovum. That was in their genetic transfers. But more recently it has been known that spermatozoa have some proteins, they have some metabolites. When they get transferred into the ovum, when fertilization occurs, those proteins epigenetically they have some effects on the ovum and effects on the development of the children. So it is more now complex, it's becoming more complex now, and the old theory has old thinking is getting changed. Now this is the semen analysis on our men. I want to emphasize it here. These are normal men. These are not any patients. These are normal fertile men. Each of the men in our study had a child. They had children. So okay, age, because by definition we are having young adult group, late adult group, advanced age group. The mean age was 27 years, 24 years, and 47 years. And we had differences in concentration of spermatozoa. So that was the only difference. In other things, other parameters, we didn't have any difference. When we did the metabolic analysis, we had 469 peak intensities, out of which 380 metabolites were identified by human metabolome database, and 89 peak intensities would not be annotated by this. Okay, this is the list of the metabolites, and when we analyzed these metabolites and classified these metabolites, most of the metabolites are lipids and lipid-like molecules. Then there were nucleosides, organic acids, oxygen compounds, and other things. When we push these metabolome data into the PCA analysis, you see that you can see that all the three of our groups got clustered into three groups. Okay, the pink ones are advanced stage, and the blue ones are the young age. So you can see there are two separate clusters. That means there is difference between the two groups. Whereas the late advanced to the middle age, 20 years age, it was kind of in the both. It was a schedule in both the groups. Right side you have that is the metadata of metadata of our analysis, and it shows that when you have 80% of the variance is in principal first three principal components, that means your model is working well. Okay, and this is the heat map. It shows the same thing, that your differences were between young adult and advanced age group, while late age group was kind of in the middle, associated with both the groups. And this is the conclusion matrix of the for and fast regression. It tells you there was no misclassification. Advanced age was different than young adult group, and none of the men in the advanced age was misclassified into young adult, and none of the young men was misclassified into advanced age. So we did a lot of modeling. I mean, there are so many modeling I can show, but I don't have time. We wanted to, now I'm going to present only two groups, which are the main groups, young adult and advanced age group. Again, you see those two groups, one is young adult group, one is advanced age group. They are completely separate, and that means there are differences in them. And we did the volcano plot to see the differences between metabolites. We had 153 metabolites which were significantly different by statistical analysis point P, probability of 0.05, and fold change of 2 are greater than 2. And the red ones are these are upregulated metabolites, and blue ones are downregulated metabolites. And these are the total metabolites. I mean, some metabolites, because the list cannot be shown in full. And this is you can see clearly what the differences are. The blue indicates that they are downregulated, and red metabolites indicate they are upregulated. So advanced stage has downregulated and upregulated metabolites. And this we did further modeling, and we did partially step discriminate analysis. We did SPLFA, we did SAM plot, we did Hunter analysis, and all sorts of analysis, and we saw that there were differences between young adult younger advanced stage. And then we did numeric biomarker analysis. We found that 137 metabolites in advanced age were they were biomarkers, and they had an ROC AUC of 1. ROC AUC of 0.5 means this is random chance. ROC AUC 0.5 to 8 means there is small indicative value. ROC 0.9 means there is some potential biomarker value. And ROC of 1 means it is perfect performance. So these are perfect performance, 137 metabolites. You can see what the difference is. 137 metabolites are different from advanced stage young age. And this is the ROC curves and box plots of 8 biomarkers. Out of these 37, these are top 8 biomarkers. You can see from the left side is the advanced stage, and right side of the box is the young age. You can see the difference. I mean, how much difference between the two groups are here. And we did also quantitative and different analysis, and these are 98 key metabolite processes were different. And processes, the top part processes were citric acid cycle and fatty acid metabolism, glycolysis, glycolysis, metabolism, phospholipid biosynthesis. And this is, I'm telling you for example of the glutathione metabolism. See, glutathione is an antioxidant, it's a potent antioxidant metabolite, and it causes antioxidation, it protects sperms. When there is less of glutathione, in this case, in our case, glutathione comes from homocysteine. Homocysteine turns into cysteine, and then it becomes glutathione. And when there is less of glutathione, so antioxidation is not there. So that causes DNA fermentation. So what I want to say is that this is the glutathione is one of the processes with one of the metabolites which get down-regulated and it may be responsible for the age-associated effects. And likewise, when you have this data, you can do all sort of analysis, like this network analysis, global metabolic network analysis, gene network analysis, metabolic disease network analysis. You can do any sort of analysis, and there are lots of data which will keep you busy for a couple of years. So this is kind of these functional metabolic data analysis. And I'm telling you the example of a couple of these metabolites which are aging is associated with deregulation of sperm metabolome with 153 of 380 metabolites in study. So phosphatidylcholine, which protects sperm from cold shock, got down-regulated. Homocysteine, which prevents oxidative stress, got down-regulated. These are some of the examples of these metabolites. And okay, L-cysteine, fructose, NADP, uracil. These all were somewhere down-regulated, somewhere up-regulated. And this is the list of upregulated metabolites and down-regulated, some of them. I'm not presenting all of them. So this is aging sperm biomarker metabolites. And conclusions are aging is associated with deregulated metabolic stresses of potentially impacting their development and function, resulting in fertility decline. Deregulated metabolites are involved in crucial sperm developmental processes and physiological functions, including allergy metabolism, mitochondrial integrity, antioxidation, motility, fertilization, etc. These aging effects, the aging impact of these processes and functions, and that's how aging in men affects the fertility decline. And I acknowledge the contributions for this work from my students, Shaukat and Abrar, and my associates, Ishfaq, Dr. Taha, Dr. Ishfaq, Dr. Yuswafa, and the technician, Umar, Dr. Priyanka, Kinaz, Rinard, Dr. Imran Khan, Mahmoud, Dr. Mahmoud, Professor Ali Rubuzanada, who helped in the administrative parts of this. And particularly, I thank the Ministry of Education in the Saudi Arabia for funding this research through audio project number 1132. I thank Kimfad Medical Research Center for providing all the facilities, Center for Innovation and Personalized Medicine, Department of Neurology, and Department of Biochemistry. Thank you.
Thank you very much, Professor Beg, for this nice presentation. Our next and last speaker for this session is Professor Muhammad Amran. Professor Mohammed Imran Nasser completed his PhD and postdoc from prestigious Jinsang National University, South Korea in 2011 and joined the Center of Excellence in Genomic Medicine Research. He has 15 years of teaching and research experience. His expertise are human genetics, gene therapy, gene editing, cellular developmental neuroscience. Currently, he involved in neurogenetic research program at Institute of Genomic Medicine Science, working on ultra area, and common neurological disorders, including epilepsy, autism, mental retardation, microcephaly in Saudi Arabia. He has published more than 180 international peer-reviewed research articles with almost 4,000 citations and 4 international patents. Dr. Mohammed Imran, welcome, and the floor is yours.
Thank you, Dr. Hiba, for the nice introduction. I would like to thank the administration and the conference organizer, KFMRC, to give me the chance, and it's really honor for me here to present today. This side, no, the slide, next slide. Right. Yes. So genetic disorder is an illness caused by one or more mutations in the genome, especially a condition that presents from the birth, congenital. I'm sorry. So most of the genetic disorders are rare and affect one person in several thousands and hundreds and millions. Genetic disorder may or may not be heritable, passed from down from the parent gene. It may be heritable or non-heritable. If it is non-heritable, this is due to the new mutations in the DNA. Genes are the building block that contain all the information to make the protein. If there is any change in the protein, so it may lead to the disease. So we can classify the genetic disorders in single gene, chromosomal, and multifactorial genetic disorders. So the transmission pattern is autosomal dominant, autosomal recessive, and X-linked. Autosomal dominant disorder is manifested mainly due to a heterozygous state. One parent is usually affected, male and female are equal, both can transmit the disease, and there is a 50% chance of having the disease in the next generation. So in autosomal recessive disorder, there are mainly Mendelian disorders. Thank you. So these are the major Mendelian disorders affected when the homozygous state, both the parents may be the carrier, and there is a 1 chance in 4 to having the disease. And this is due to mainly the consanguineous marriages. As in the first presentation, Dr. Ahmed mentioned, the consanguinity rate in Saudi Arabia is very high. So X-linked dominant we can divide in 2 different: X-linked recessive, X-linked dominant. If the female is carrier, it can produce male and female, male affected and female as a carrier. And if male is affected, father, it can produce 2 female as a carrier. And if in the case of the X-linked dominant, the female is affected, it can produce 2 affected male and female. So why we do the genetic testing? This is important for the carrier testing, for the testing for genetic disease in adults before cause the symptoms, newborn screenings to find out the disease pattern. So rare genetic conditions affected a small percentage of the population, but can have a significant health impact. So rare genetic disorders are individually rare but collectively very common. In Saudi Arabia, is 10 times higher in incidence of this disorder as compared to USA and 4 times higher as compared to the Europe. 350 million people worldwide suffer from these rare diseases. Rare diseases are more widely expected. They kill more people globally than cancer and the HIV combined. The genetic diversity of the Saudi population due to the historical context of the migration pattern and the unique genetic markers. Researcher has identified several unique genetic markers in the Saudi population which reflect the adaptation to the local environment and highlight the historical connection with the neighboring population. Even the population genetic side, the consanguinity rate is high, which impact the genetic diversity, health outcome, and prevalence of genetic disorder within the families and communities. Genetic drift is another reason. Genetic drift is isolated. A small population of the Saudi Arabia can lead to the significant changes in the allele frequency. So, autosomal, according to the study published by the Infectious Specialist Hospital, the mode of inheritance of the KSA, 61% is autosomal recessive and 22% is autosomal dominant, and rest are the other X-linked and unknown reasons. And they put the congenital dysmorphism and chromosomal abnormalities in the top, and second, metabolic disease, third, the nervous system disorders. Genomic sequencing techniques help us to enhance the genomic research and personalized medicine, and whole exome sequencing help us to understand the genetic complex disorder. So we have the different steps. I will not go into details. So I will discuss about the few cases that we have sorted out. This study was done with the collaboration in the Tokyo University in the Professor Robotaka Hayakawa lab. This study was published in Journal of Cell Biology. We identified a P4A regulator neuron morphology cells separately via PAR1 signaling pathway. We received a family having the epilepsy, microcephaly, intellectual disability, and patient was unable to walk and sit. We did the whole exome sequencing and we find a novel mutation identified in P4A. After the validation using the Sanger sequencing and different silico pathways and the different software used to identify the mutation in disease causing. So, segregation analysis was done during with the help of Sanger sequencing because Sanger sequencing is the gold standard. We identified that there is apparent changes in neurons, and even the binding of the path is increased significantly. And when the mutant mice shows the P4 expression is increased as compared to the normal. The genomic background of the patient and the P4 mutant mice exhibit high embryonic mortality rate and development delay, as we find with the phenotype of the patients. You can see at the embryonic day 6.5, the development is significantly decreased as compared to the normal. The suppression of the PRK activity driven by the mutant if affected the expression of the PRKB ACC2 epilepsy-related pathway. So we checked using the Western blot analysis the upstream and downstream pathways, and we identified that the point mutation we identified in P4A is very important, leading to neurological disorders. P4 is involved in the poly A signaling pathway, and through the combination of the P4A coil domain. The P4A mutant causes aberrant morphology in dendrite and spines of hippocampal pyramidal neurons, and if it is engaged in the fundamental mechanism regulating the seizure susceptibility and could be a potential target for the epilepsy treatment. And the case 32, normally we found the compound heterozygous mutation, but in this case we identified a unique 3-site compound heterozygous mutation in LAMA3 gene. We received a family with the rare, ultra-rare genetic disorders. Here the patient has the skin disorder, nail deformities, facial deformities, hair loss, and hydrosis. They cannot sweat. So we identified a gene that is leading to autosomal recessive disorder known as laryngomicrocutaneous syndrome (LOC). Again, we did the segregation analysis. We identified a mutation in LAMA3, 30, 30, 71, and 65. And a couple of months back, the family contacted us again because they had another baby born with the same symptoms, having the same disease. So we have to go back to see because they want to go for the IVF study, IVF for their next baby planning. So we will see how this mutation can help us to eradicate this disease in the family. In the case study 33, family with the spectrum of anti-vertigo spectrum defect was received and whole exome sequencing was done, and we identified a novel mutation in BIZEP gene encoding the protein that abundantly expressed in the cardiac tissue. So this is a disease related to the left ventricle involvement and sometimes shown the biventricular diseases. So loss of function mutation due to stop gain mutation in the BIZEP gene. These were the twin. And this study, again, we did the same sequencing for the validation study, and we find the father was the heterozygous carrier and the twins having the homozygous leading to the disease. This study was done with the collaboration of Professor Abdul, he's sitting here. So with his colleagues from the University Hospital, and we are planning to do the function study for this family as well, inshallah. And the case study 4, whole exome sequencing, study the two novel homozygous variant in TRAPC, traffic protein signaling complex 9, and PLOD3 gene, leading to intellectual disability and bone fragility with contraction. We identify the family having a consanguine family with twins. One was died during the birth, and the second baby have the disease. The patient having the intellectual disability, development delay, microcephaly, spectral contraction. And this is again the first study reporting the patient with the TRAPC and plot-related disorder from the Saudi Arabia. In case study 5, the neurological neurocardiogenic syncope, also called reflex syndrome. This is a rare study. We have the 6 affected cases in this family. This is a normal guy enjoying his meal. During his, they cannot eat. Once they start eating, they get faint. So they are normally on the liquid diet. The fainting reason is because the brain gives the signal to the brain, to the heart, and there is a oxygen deficiency. You see, it's a normal guy. It's ultra rare disorder. We find this in Saudi Arabia. They have the 6 affected. So the reason again that comes again. So it takes some time and he will get normal, and again he can start eating. So we did the whole exome sequencing. Again, we find the TTN gene. We did the again compound heterozygous mutation. The same sequencing was done for the validation study, and we identified this. And one of the variant was proved, and the other is still under process. The clinician was not satisfied with this outcome, and we went for the whole genome sequencing. And another gene was reported, that is NEP, nemaline myopathy 2, muscular weakness in the upper region of face and neck region. And even the clinician is not satisfied for this, and we are studying deeply what is the reason. This study was done in the collaboration of Dr. Badr Shirak in Plastic Specialist Hospital and Dr. Yasir Al-Adin National Government Hospital. Last case, the case study 6, congenital insensitivity to pain and fibrosis. We see the family with 2 affected members with a disorder called hereditary sensory autoimmune neuropathy. Type 4, this is called pain syndrome. Patient don't feel any pain. This is 1 in 25,000 people. We identify the rare novel mutation in NTRK1 gene mutation. It is predicted that deletion in exon site has pathogenic damaging influence of the NTRK protein function. These are the patients, they don't feel pain, they don't have the pain, they don't sweat, even they have the fracture, they don't feel the pain, even you put their hand on fire, they don't feel the pain. It's a really critical condition, and we identify 3 base pair deletion in the NTRK1 gene. Recommendation and future study, as Saudi Arabia is continuously investing in the genetic research and healthcare infrastructure, these advances could significantly improve the public health and provide the new opportunity for disease prevention and treatment. By combining the cutting edge gene therapy and gene editing, we can lead the application of genetic medicine in the region. Thank you so much.
Okay, now the session is open for questions. Do you have any questions? I can start with a question with Unmet, please. You mentioned that clinical Parkinson BPO rat model shows progressive motor deficit with alpha synuclein, which are hallmarks of Parkinson's disease. How closely do these findings in DKO in rats mirror the clinical progression and pathology observed in PD patients?
Thank you for the question. First of all, we have to understand that this is in products, either mice or rat. Of course, we see some similarities between what we saw in those mutant rats to what we see in patients. For example, the motor deficit from gait dysfunction, loss of agility, and the early neurodegeneration we saw. This is why actually we think that this genetic model is for sure for me is better than the neurotoxin model, because we saw well, we see usually a slow progression of the disease, similar to what we see in patients. Talking about neurotoxin model, where we induce Parkinson's disease in a matter of days. So it's a rapid way to induce Parkinson's disease. So yes, we saw a lot of motor deficits similar to what we see in patients. We saw a neurodegeneration. It was the loss was gradual. Also, we saw hallmark of Parkinson's disease similar to what we see in patients in the term of alpha-synuclein. Of course, in patients we see it in the cutaneous and also in the substantia nigra, but in those rats we didn't see it in the substantia nigra, but we saw it in the striatum and also in the plasma. So I think there is a lot of similarities between what we saw in the macaque and what we see usually.
Thank you so much. I have a question for the keynote speaker, Dr. Naifal Tishri. It was a very impressive presentation, quite remarkable insights in your field. One of the slides that you showed, the top 10 genes, I think, the mitochondrial causative disorder. Have you ever encountered RMND1, the combined oxidative phosphorylation deficiency disorder? As we have encountered like a couple of families in KAUH hospital. They are Yemeni in origin, however, they're consanguineous, showing normal mutation in this gene associated with epilepsy and spectrum of phenotype, chronic kidney disease. And from our findings, using bioinformatic tools, again, bioinformatics always give you a prediction that this might have been associated with cinnamide level elevation and necrotic tissue that caused the glomerular membrane of the kidney to be damaged. So have you encountered also in this gene, although it's rare, one of the rare mitochondrial disorders? This is one question. The other question, where do you see the AI tools like Gami Fabric and all these fascinating AI techniques in electronic health records and in genotyping as well for genetic disorder in early infancy to transform the healthcare? Thank you so much.
Yes, عندنا
I remember that I have at least 3 families with mutation in this gene. But we'll have to go back, and if you're interested in getting knowing them or recruiting them, we're happy, because the point of the study is to build a database, but not just electronic database. Because something that I didn't tell you, at least 50% of these, we have fibroblasts from them. We have plasma, we have urine, we have. Now, I'd like to divert, so just going to what Dr. Mohammed was talking about, the model. Now we're genetic, we're shifting to another model, which is the human model of disease. Now we have the loss of function mutation, we have something called human knockouts. What is better than human cells, right? So, and for example, the PBTC7 and DMAC2, we've went way further in terms of function study. We've taken the fibroblasts, differentiated them to iPSCs for the patient to model the disease. So then we, for PBTC7, was hypomyelinating leukodystrophy. So we're differentiating them to oligodendrocytes and seeing what's happening, why they are not myelinating, right? So that's one of the points where we have confidence that we can model the disease through brain organoids. We have immune deficiency genes where we go back and see what's happening at the bone marrow level or the progenitor cells. But we have cells. We have these patients. We can, even if we don't have them, we can go back, if they're still alive, we can get material from them. But the short answer to your question is we do have them. Now, AI is, we've been using AI in genetics since 2007, but now it's just becoming trendy and everywhere, but I can't tell you all the data analysis, big data. You know, genetic data are all big data analysis. Big data without AI.
Complexity.
Right? Yes, so we do use them. It's improving, it's helping us to deal with the complexity of the human genome, finding the mutation, but it always comes down to the genetics to find the mutation. Now, in terms of the phenotyping, now we're taking, with the AI, we're taking a really good approach, which is called reverse phenotyping. For example, we find, for several genes that we find the gene in one family, then we ask other collaborators from across the globe, can you please check this mutation? And then check what the patient has, right? So this is the reverse. You're starting with the genotype before the phenotype. But they have a database of thousands of patients, so they have to put the keywords, like for the phenotype, matching our phenotype. Then they come, and then one gene that we're working now, we started with one family, and I consulted a group here in Saudi, and another group, and within 1 hour, I went from one family to 17 families matching in a normal gene. That's a big thing, right? It's just by AI, right? They found the mutation, it matches the phenotype. So that's one of the applications, but I mean, it's evolving and we're evolving with it.
Thank you so much, Dr.
Hi, Dr. Naim. I just a follow up for her question. If you have like all of these families with this mutation, did you consider collecting single cell data set for these families? Single cell RNA-seq?
We do have the fibroblast, so we can do the single cell, right?
Yeah.
So we have fibroblasts for some of them. We do have some tissues. Sometimes some of the patients have interesting phenotype like chronic diarrhea or cholestasis. So we have liver biopsy or intestinal biopsies, and we can always, we will do something also more of that. In that line, we do spatial genomics.
Yeah, spatial
transcriptomics, proteomics. Yeah, but we try to always prioritize for that one. I know that I get this question very often, like, why don't you do single cell? It's a very expensive one, and always we are hypothesis driven. We cannot go, wild hunting. It costs us a lot. Every assay costs us like $5,000-6,000 US dollar or something.
So we always try to build the evidence, and then we do it only when we have reason to do it. But we do have the cells, we do have all the materials. 5 minutes for me? Okay.
Questions?
I just would like to ask Dr. Muhammad Nasir regarding the 6 cases, studies that you mentioned. How often are these cases? Do you have any statistic about them here in Saudi Arabia? The 6 studies, that you presented. Yeah, but do you have any statistic how often they are occur here in Saudi Arabia? The diseases. Yeah, so it is a rare disease. Yeah.
You can find this maybe the other patients, the other doctors, they have the similar type of mutations.
Are they considered as a rare disease? Diseases? Yeah.
I have a follow-up question on the case because they're interesting, especially the case with the reflex. So sometimes these patients have a collar syndrome where they have a problem with the baroreceptor, right? They it's excluded. Yeah. So there is the NEB nebulin mutation. Usually nebulin mutation. I'm afraid that nebulin mutations they do not explain this reflex. So, and you have to keep in mind one thing. Usually in this consanguineous population, there is always 2 to 5% of the patient will have 2 or more molecular diseases. So you're maybe dealing with dual or maybe 3 molecular diagnoses. So maybe if the patient has a phenotype, muscular phenotype, then that can be easily explained by the NEB mutation, right? I think that one will be like channel sodium potassium channel mutation that can explain this type of disease.
Thank you for the nice question. We had a long discussion, around 2 hours. The clinician will sit together, we discussed all the details, and he is not satisfied with the results. I have mentioned in my presentation as well. Actually, time is short, that's why we cannot explain the detail. Yes, we are thinking something more. He is thinking that this may be the rare genetic, and we will report this for the first time in Saudi Arabia, inshallah. We have all the data. We will go back and have the VCF files. Yes, we have the whole, because first we did the whole exam sequencing, we find the mutation KDN gene, but we are not satisfied with this. It's normal that can be issued on the slide. I think there's 1 or more, 2 or more. Yes, they reported as the MEP gene, but we are not satisfied with this outcome. So definitely we have to have more details. We'll see inshallah in the future.
Well, thank you very, very much, everyone, for the great talks. Very insightful, very, very interesting. I think I'm not going to focus on it. I'm going to talk collaboration. I see a lot of collaboration that could be established from big to the end and to the audience. So please discuss potential collaboration. I think there is huge potential. Maybe finding these mutations with the data sets that he has. Maybe looking at the mitochondrial sperms with NAIB. Looking at other mutations, joining forces. I think that's the main message that we want to come up with from this conference. So please do so. Thank you very much.
Abdulaziz University. She is the founder and former head of Immunology Unit at King Fahd Medical Research Center. Prof. Alia earned her PhD in Infection and Immunity from King's College London. She served at Saudi Arabia Consultative Shura Council from 2016 till 2024 as a member and a vice chair of the Health Committee. She is also a consultant to the Vice President for Graduate Studies and Scientific Research at King Abdulaziz University. Prof. Dahlawi's research interests focused on the antigen presentation of immune cells, especially dendritic cells, as a powerful tool to manipulate immune responses. This has implications for several areas of immunological research. Her scientific contribution include over 50 publications and 2 patents. She has participated in numerous national and international conferences and is an active member of several leading scientific societies. Prof. Dahlawi has presented Saudi Arabia in international academic and parliamentary forums. She is widely recognized for her commitment to scientific excellence, higher education reform, and advancement of women in research, policy, and innovation. Please join me to welcome Prof. Adnan. Also, we have Prof. Faisal Zahrani. Prof. Faisal Zahrani is a faculty member in Biochemistry Department at King Abdulaziz University and a principal investigator at the Stem Cell Research Unit. He earned his PhD from the Northwest Cancer Research Institute at Bangor University in the UK. His research interests include stem cell biology, particularly exosomes, and their application in disease management with a focus on cancer, infectious diseases, and overall well-being. With numerous publications to his name, Professor Zahrani actively engages in national research initiatives centered on health, sustainability, and livestock, contributing to advancement in these critical areas. Welcome, Prof.
Okay, thank you, Dr. Fatma, and thank you for all the audience who attended the last and final session of today and survived to be here. Today, I'm honored to introduce the speakers of the last session of this, and finally to the immune response in inflammatory disease. So the first speaker is Dr. Mohammed Nashawi. Dr. Mohammed Nashawi, I'm pleased to introduce you. Dr. Mohammed Nashawi is assistant professor at the Faculty of Medicine at King Abdulaziz University. Dr. Nashawi earned his medical degree from King Abdulaziz University in 2011. He completed his residency in general pediatric at Hillbridge University in 2018, followed by fellowships in pediatric rheumatology in 2021 and autoinflammatory diseases 2022. His research interests focused on immune dysregulation and disease mechanism, contributing to advancing pediatric immunology and rheumatology. Please join me to welcome Dr. Nashawi.
Thank you, Prof. Ali, for the introduction and the organizing committee for the kind invitation. It's my honor to stand here in front of you. Almost all of the attendees are non-physician. I'm a physician, but I will try to make it interesting also for you and also for the physician who will attend this last session today. I talked to Dr. Ali before. The inflammation could be actually at the morning level. بعدين الانفلاميشن بيجي مع الوقت بس بنخلينه كده the end of the session. So I will have like 3 objectives, but actually the main objective is to show you how the collaboration between physician and non-physician can change patients' life, not only like mouse or kids or something in the lab. So we'll start with the autoinflammation or autoinflammatory and autoimmunity. Are they the same or not? Maybe a lot of you or the people working in the immunology unit know more than me that there's like innate immunity and adaptive immunity, and both are different. there is some cytokines and some like risk factors or role in the innate immunity and the adaptive immunity when it's come to antibodies or cytokines. However, in the real life, it's really difficult to differentiate between autoinflammation and autoimmune diseases. Although there's some diseases we think, like here some diseases with pure autoinflammation, or we think this is really pure autoinflammation, but you guys, after like 2-3 years, usually you discover something, the pathogenicity of this disease, and then we rethink again, and we thought maybe it's like adaptive and innate immunity, and it's usually there's like a gray zone between autoinflammation and autoimmunity. When it comes to immune deficiency, also some of physicians, they think that immune deficiency is either the immune cells are not working, and the patient will have like recurrent inflammation or recurrent infection without autoimmunity. But in the real life, there's a lot of immune deficiency patients. They have like immune dysregulation. So the best toxicology is to use the immune dysregulation rather than autoinflammation or autoimmunity. What are the types of autoinflammatory disease? There are a lot of classification of autoinflammatory disease. I like to classify the disease according to the pathway. We know some diseases, they are really connected to interleukin-1 beta family diseases, or NF-κB, or JAK diseases, interleukin-36. There's a lot of classification. Usually, if the student or the residents use any classification you want, the most important thing that you understand what's going on. The pathophysiology is really very important in these diseases. So in real life, when to consider these diseases, the immune dysregulation disease, usually the early in onset, and this is like when the patient have like 3 months, 2 months, less than 1 year, usually, but not always. Recurrent flares of chronic inflammation, elevation of acute phase reactant, clinical findings such as serositis, rash, arthritis, and this means like multi-system involvement. Usually they will have like skin and heart, skin and muscle, skin and MSK. So if you have like more than one system, think of chronic disease which is related to autoinflammation or immune dysregulation. So why we need to think about this? So maybe we will have a diagnosis after 3-4 years, or sometimes when Dr. Naif also presented before, some patients, they have a diagnosis after 2 years with mitochondrial disease. And autoinflammation or immune dysregulation, it could be fatal. So early diagnosis, early treatment could change the patient's life. And maybe we will see also some examples at the end. This I usually put for the students and residents. They like this kind of slide. So if you think flashback, L for fever, L for lymphadenopathy, hearing disorders, belly pain. When we see this slide, we know it's multi-system involvement. I think this is enough for the people to think of immune dysregulation disease. Let's come to the interesting part, the case presentations. I presented 2 cases. One case, or the first case, I saw during my fellowship, and this maybe will reflect what Dr. Naik before said about the consanguinity, and maybe some patients, they will have more than one disease or more than one mutation. This 5 years old came at that time to the hospital with generalized pustular psoriasis with fever, starting at the age of 7 months. So early onset, more than one symptoms, fever and skin changes. That time they thought at the beginning it's early onset psoriasis, probable infection, treated him with steroid and antibiotic, and he improved. After 4 years, he came back again with fever and psoriasis, so flare of the disease, and at this time they think it's maybe immune dysregulation, we need biologic treatment, and they sent for whole exome sequencing. You know, we have whole exome sequencing, each body or each doctor, they think, sent for it. It's a good investigation, but I think it's good investigation if you know what to do with it. So interestingly came the results back with homozygous mutation, or a variant or homozygous mutation in a gene, which usually causing familial HLH. Familial HLH, usually the patient will come with pancytopenia, hepatosplenomegaly, they don't have like skin change. After we found this result, we thought that it's case report, interesting. We have like homozygous pathogenic mutation
with a new clinical phenotype. But at that time, we thought, like Dr. Nice said before, maybe it's not like this gene, maybe the patient has another gene, and we reanalyze the data. And before reanalyzing the data, this comes to the research lab. So we sent for in-case cell dysfunction. We know that familial hemolytic or HLH is the in-case cell dysfunction, and we can do the in-case cell function testing. And at that time, we did it, and we found it's normal. So this is not causing the disease. So maybe it's only physiological changes at that patient, and when we reanalyze the data, the patient had like mutation in interleukin 36 receptor, and he has like tetra diagnosis, which is known to make skin changes and fever also in that age, and the patient received the right treatment, and he improved, of course, after that. So the take home message here, or the point to learn from this case, is that the functional testing can change the thinking pathway of the physicians. So without the people in the lab, they did the in-case cell function, we could not reach the diagnosis, or maybe we would struggle with the diagnosis 2 to 3 years until we really classify the with data, and that was like really quick in-case function, and then we have it. The second case that we treated here at King Abdulaziz University with the collaboration with the neurology unit in King Fahd Research Center. This is an interesting case, and I'm really proud that we could diagnose her. She's like, the symptoms started when she was 4 years old. She had like fever, upper respiratory tract infection, skin abscess, which had multiple infections. She went to multiple hospitals at the beginning. She had also eczema, failure to fly, lymphadenitis. Also hepatosplenomegaly. Not sure if you can see the spleen. This is like a huge spleen. Usually the normal spleen will be until here, and she has like really huge splenomegaly. So multiple admissions, as I said, like with pneumonia, with infection in the PICU, not in our hospital. They did a lot of investigation. He has also interstitial lung disease, clubbing, pancytopenia, hypogammaglobulinemia, high inflammatory markers. They did all investigation you can imagine. Even the West came also negative. Went to another hospital, they did West again. Went to another hospital, they did West again. So she had like 4 polyclonal sequencing, all were negative in different places. So at the end, they thought maybe this is immune deficiency, and we don't know the cause. Let's treat her with the immune deficiency phenotype. She received IVIG and supportive treatment, but unfortunately, the disease was also progressive. So at the age of 11 years, she came to our hospital. She lost 6 years from her life. She could not go to the school one day because she had almost always fever and infection. She was in different hospitals. And at the 11 years, she had COVID and came to our hospital. And I think she was lucky that she came to our hospital. So we summarized the case quick because of the time. So at that time, in 11 years, she came to our hospital and the PICU ward due to COVID infection. And like we say, from 2017 until 2022, she had like 4 times on sequencing. Usually, as a physicians, the maximum we can do horizontal sequencing, and then we don't know exactly. What we tried in our hospital to do like multidisciplinary and to rethink again with the other subspecialties, immunology, genetics, and our lab, we immune phenotyping the patient, not really the clinical phenotype. So we thought what she has like from immune cells, what is going on. We think it's a granulomatous lymphocytic interstitial lung disease, or we thought it's like GLID, immune dysregulation disease, and most likely the T cell is the problem. And these candidate or potential genes should be looked for. And then we asked our genetics to look for these genes if there's any potential variants and not significant. And we found that she has like a homozygous uncertain significant in CTLA-14. So we think it's CTLA deficiency. This is not the point. The interesting part that the gene is usually, the mutations usually should be in the coding region. And this gene is in the non-coding region. So because of that,
the genes or the genetics, the lab there, they did not mention this mutation because they think it's not causing the disease. So we thought, but maybe it can cause a disease because it's homozygous, and this is patient with consanguinity with other siblings who have like autoimmunity. So what we did, the functional testing. The collaboration with our lab, and prior to the lab, we did the functional testing, the lymphocyte subset and the CTLA4 expression, and it was low in this patient. Also, we did the exact functional testing of CTLA4, which is transendocytosis with flow cytometry, and it was low. So we could confirm the diagnosis that this patient has CTLA4. And we started there on the treatment, which is abatacept. The main point that after this treatment, she had like 1 year with a very good quality of life. She could visit her school. The family now, they know that she had this diagnosis. And unfortunately, after that, he died because of infection. So sometimes we do something good, but could be helpful for the patient. I think she has like progressive disease after 6 years, 7 years. We just now started the diagnosis. The exact treatment is bone marrow transplantation, but because of the progressive disease and the recurrent infection, she could not make it. But the good point of this is we could diagnose 16 other patients in Saudi Arabia with the same mutation. And they went for bone marrow transplant, and they are living now. Because of one patient, because of functional testing, we could declassify a mutation which was not reported before to a pathogenic variant, and other 16 patients can benefit from this patient. So what is the take-home message from here? It's also the functional testing. So functional testing that we cannot do it as a physicians. Usually we need a collaboration with other labs. So my take-home message is genetic is an excellent investigation if it's done appropriately, and like we do in this whole exome sequencing, and we don't know the clinical phenotype of the patient. So you need to have a target before you do the whole exome sequencing. Functional testing is a must case, mandatory to confirm or exclude any disease. Like in the 2 cases, biomarkers are really important. Like in our field, we need more research about biomarkers and the translation research or the involving clinicians and basic science researchers are very important to understand this disease and better diagnostic, better management plan for our patients. Thank you very much. I would like to acknowledge for immunology from Alzheimer and the
Thank you, Dr. Nashawi, for your informative presentation. Okay, our next speaker is Dr. Peter. We are delighted to have Dr. Peter Natsen-Buschenberg. I've been trying to repeat the name many times until I can pronounce it right. Dr. Peter, he's an associate professor at the Institute of Genomic Medicine Sciences at King Abdulaziz University. He earned his PhD in biochemistry from the National University of Singapore and completed postdoctoral training at the University of Glasgow, focusing on signal transduction and system immunology. He authored over 180 publications, and he has his work is cited in 122 patents and holds an impressive high index paper publishing. His research on cytokine drug discovery and inflammation model has been supported by a major grant. I will not say the amount of money, but it's a huge grant. Please join me to welcome Dr. Peter.
Good afternoon, everybody. Thank you, Prof. Alia, for the nice perspective. So now I'm going to introduce about some basic research. Then I'm going to connect with the clinical aspect. So today I'm going to talk about investigating acute and chronic inflammatory responses in human cortical-derived mast cells and the application of Luminex multiple array profiling approach. So basically, I'm going to introduce inflammation and also mast cell. Then I'm going to introduce the technology, which is the Luminex technology, which is used to measure the biomarkers from the serum or plasma or from the cell. So, this is the overview of my presentation. So, understanding inflammation, then introduction to mast cells, then how we derive the human cardiac-derived mast cells, then I'm going to introduce about the Luminex multi-carbonate profiling technology and its application in studying the inflammatory responses in human cardiac-derived mast cells. Then the conclusion and the future direction, how it is going to be applied, basic translation and clinical research. So understanding inflammation. So inflammation is a natural response to injury or infection, which is leading to symptoms like redness, heat, swelling, and pain. And the cause of inflammation is mainly if it is due to infection, allergens, or can be due to autoimmune disorders, which can trigger immune response. I think Dr. Mohammed Ashawi actually introduced about different types of inflammation, autoinflammation, autoimmune response, etc. Usually, we classify inflammation into two types. One is the acute inflammation, which is very fast, which occurs within minutes to days, and it is due to the migration of neutrophils inside of inflammation and the resolution. Then chronic inflammation is for longer time, actually weeks to years, and it is characterized by the influx of lymphocytes and macrophages, which can lead to tissue destruction. It also causes the angiogenesis, fibrosis, which can lead to various chronic diseases. So this is one of the slides I got from one of my professor, Ian McLeish from University of Glasgow. You can see that about 10 to 15% of the population are affected by the inflammatory disease, whether it is autoimmune disease or autoinflammation diseases, or allergies, or asthma, etc., etc. And this cover page from Time magazine, which is 20 years before, it is in 2004, saying that the secret killer is the inflammation. So inflammation is the basis for most of the diseases, like heart attacks, cancer, Alzheimer's, etc., and etc. So this is the basic information about the role of immune cells in inflammatory response. You can see the neutrophils respond to the infection, and macrophages can lead to the, can orchestrate the inflammatory response, which is mostly the adaptive response, and then the lymphocytes and T cells and B cells play a role in sustaining the adaptive immunity, leading to the long-term response to the inflammation. The mast cells, which is I'm going to introduce today, which can contribute to both phases of inflammatory response, both innate and adaptive. So the mast cells are like tissue residing immune cells, which can be in mucosal tissue as well as connective tissue. And it expresses the FGF1R1 receptor, which is the receptor for IgE, and it can also express other receptors like toll-like receptor, which can recognize the LPS, can recognize the infection. Then also it expresses CD117, which is the receptor for the stem cell factor, and ST2, which is the receptor for interleukin 33, which I am also going to introduce to you in this presentation. And it releases various cytokines, prostaglandins, proteases, more importantly, histamine from the granules. So this is one of my publications from the University of Glasgow, which is actually the cover page article in Nature Medicine, which we tested one glycoprotein from nematode, which inhibits mast cell function. So as you see from here, the mast cell has a relatively like a oval nucleus, and the cell structure is also about oval in structure, and it varies a little bit based on the granules present inside the cytoplasm. The cytoplasm is densely packed with granules, and these granules have histamine and proteases and proteoglycans, heparin and some enzymes like beta-X, there. But when it's triggered by the antigen or pathogens or cytokines or neuropeptides, it can release cytokines, chemokines, and growth factors. So cytokines, chemokines, and growth factors, they are all smaller proteins. These smaller proteins ranges from about 10 to 30 kilodaltons. which can actually trigger other cells in the immune system. So the rationale for study here, which I'm going to introduce quickly, is that we are going to create the master model, which is derived from the human cortical cells. Basically, it is from CD34 phosphorylated. These are the hematopoietic precursors. Then we are going to differentiate the CD34 cells into complete mast cells, and we are going to test the interleukin 33, which is acting through the SP2 receptor. So SP2 is the receptor present in the mast cell, which can recognize interleukin 33, and it can trigger inflammatory response. And we are going to assess the inflammatory response using the Unmet technology. Interleukin 33 is a type 1 cytokine. It actually binds to the SP2 receptor, and it is actually triggering the inflammatory response by activating the mast cells and other immune cells. And you can cause COPD, dermatitis, multiple sclerosis, asthma, allergy is actually decreased. That's why it's called as alarming. So it's a danger signal, by the way. So how to create the carbon-derived mast cells? So here we are taking the carbon, which is from the healthy individuals who deliver. We take the carbon, take the carbon, then do the pica, then we do the isolated bopicol, then we do the max based on the CD34 microbes, the positive selection. Then we take the CD34 cell and use a media called N5 media, which is a serum-free media, and we use human recombinant allergics 50 nanograms and 100 nanograms of ACF. ACF is the factor actually which triggers the mast cell differentiation. Because ACF binds to CD117 on the mast cells and it triggers the differentiation. This is going to be a 8 to 10 weeks process. We need to actually monitor using the facts. So initially, I'll just quickly go through. We get the few CD34 cells. Then we actually expand these cells and differentiate these cells into complete mast cells. So complete mast cells express CD117 and they lose the CD34, CD45, and this is CD34 progenitor, and it differentiates into mast cell. And actually, you see after 8 weeks to 10 weeks, CD34, CD45, CD23, CD23 is the FP epsilon R2, which is very less, are completely absent after 8 weeks. And the differentiated cells express FP epsilon R1 alpha, usually it is more, sometimes in thin, and CD117. Then you can see the complete, it is completely differentiated into mast cells, express the CD117, and to some extent the FP epsilon R1. Usually, the percentage purity is about 80 to 90%. If you culture longer time, it will be around 90%, 95, 99%. So this is like a steady process. We do gene stain, toluidine blue, which is very specific for the mast cells. You can see the nucleus and the granules, and we can do some imaging with the CD117 staining operator system. We can also see the expression of this receptor. So again, the same process. We take the carbon, differentiate the mast cells, do the RNA isolation. We did the microarray. Then we did the characterization actually using some of the in silico techniques, which is called the pre-rank GISA, which is introduced in the year 2005 by Arvind Subramanian, published in PNS. It's a very good technique actually, because in fact you are not going to test for more than 4 or 5 markers, But here you can test 50 specific genes. So we can assess the enrichment of these genes from the gene expression signature. If you do the microarray, get the gene differentiates the gene, then you can use the pre-rank GISA. Then you can see about 50 genes are enriched in our mast cells. So it's like a completely differentiated mast cells based on the gene expression signature. So this is one of the good techniques to differentiate. When you compare the CD34 population with the completely differentiated mast cells, these genes are actually. So once we are sure, we did actually 2 different kind of same experiment, but we did 2 publications on that. We have the same concept. We triggered the mast cells with IL-33 for 6 hours, 12 hours, 24 hours using 10 nanograms, 6 hours, 24 hours for 20 nanograms, 2 different doses. One is 6 hours considered as a acute response. 24 is like a little prolonged response. You can't say it's a chronic response. Chronic means longer. because mast cells respond very fast. So that, we use 6 at 24 hours. Of course, we can keep more, 48, 72. It's not a problem. One aspect, we did the microRNA profiling with the microarray. And in the second aspect, actually, we did the Luminex assay. The Luminex XMAP technology is the basic technology. We use the matrix machine, which is a small machine, which you can analyze 50 analytes, up to 50, smaller proteins like cytokine, chemokine, growth factor. You can analyze. Here we use magnetic beads. They are smaller beads which are linked with the antigen. Then you can actually use this bead to test up to 50 cytokines, chemokines, and growth factors. So this is the machine. It has it's a very small machine. And this is the principle. If the magnet is there, these beads are color coded. There are 50 different beads. You can go and bind with the magnet. And these magnets are actually have specific coating with a dye inside so that it goes to 50 different bead regions. So each region has a marker for each individual cytokine, chemokine, and growth factor. Then it has a CCD camera. And these, the microspheres are actually illuminated with green as well as red, LEDs. Then it is actually captured. The signal is captured with the CCD camera. So one of the publication actually we did in the immunology letters only with the cytokine expression. You can see when you trigger with IL-33. IL-1 beta, IL-6, IL-13, IL-5, TNF, IL-10 are all increased. So these are all Th1 cytokines, and IL-10 is anti-inflammatory cytokine. And IL-13 and IL-5, which are expressed in the later stages, which are all Th2 cytokines. So IL-33 actually induces Th2 response. That's why it's very important in allergy and asthma. Because Th2 cytokines, IL-5, IL-13, IL-4 play a key role in allergy and asthma. Then also we tested chemokines. Chemokines are responsible for attracting the immune cells to the site of inflammation. So as you see here, CXCL8, which is IL8, CXCL9, and Nepone alpha and beta are all increased, but they are increased based on the acute and chronic stages in a differentially expressed. Some are expressed in 6 hours, some are expressed in 24 hours. Then the growth factors, the GMCs, which plays a role in the differentiation of myeloid progenitors. So the conclusion and future direction is that, interleukin-33 is one of the triggers we test. Of course, we can test a lot of other cytokines which are unexplored. So IL-33-SC2 actually it is very key for inducing the inflammatory response, which is play a key role in allergy, asthma, and atopic dermatitis, for many inflammatory conditions. So we need to target IL-33 either using any drugs or using SC2, which can also function as a decoy receptor. We can use to block it. And the XMAP technology can also be applied to test these biomarkers. Whatever model we use, we can use the XMAP technology to test for these markers. And the future possibility is actually using high-end machines. There are many new machines that are coming up. One is the intelligent system, which you can test up to 500 biomarkers. And you can see from this, that the link is there, kit finder, where you can go and find the kits for various other disease models. You can get the kits for testing cancer, diabetes, neurological diseases. There are many panels are available. You can go and get the panel and you can do the assay. And if you want to see the degranulation of mast cells, there's the link down actually. It's called David Barlow archive. Because there are categories, microscopy, where you can go and when you click the link, you can see the video for the mast cell degranulation, which is amazing actually, which I can't show it here because it's copyrighted material, should not be displayed in public. So when you go there, it's not only mast cells are there, but there are many videos are available, other cells, even human development is there. So you can actually, go and look into that. Very amazing actually. This is IntelliFlex system, which advanced system, which has a dual reporter. You can test two different phenomena in one field engine, and it is like a flow based, so it's very advanced engine, which is you can easily design the assay. And we are going to get it later. It depends on the funding. And these some of the publications, in the last 3-4 years, we got about 10 publications with our collaborators. And most of them are in fuel category. And now I would like to acknowledge, because this work is not possible without our team members at the sharing professor, Farid, and the graduate students, Dalia, then other PhD students. One of the PhD students is going to work in the new cytokine. I don't want to name it actually, it's in the master model. Then I would like to acknowledge our management profile, Dr. Talal, Dr. Shilo, and our collaborators from the University of Jeddah, Dr. Kim, Ala, Reem, Roa, Laila, and Prof. Mohammed is from King's College, is going to collaborate with us. Then other collaborators who are also doing the math technique in our lab. And funding bodies, TAC, the major funder, then RGO, previous funder. And we got a grant from Saudi Allergy, Asthma, Immunology Society in the last year. The only one grant in the kingdom, Dr. Sherin and Farid and Imran, about 100,000. It is to test one of the novel cytokines in master model. Recently got Saudi Arabia grant with the University of Jeddah collaborators. And some grants are from DSR and the institutional bodies from KU. And I would like to thank the KFMRC conference organizing committee, Dr. Prof. Anwar, and others for giving me this opportunity to present this work so that I will get more collaborators in the future. Thank you so much.
Good afternoon, everyone. It is a pleasure to introduce Dr. Khalid Madani, consultant in clinical nutrition and a leading voice in public health and nutrition education. He has published 38 scientific papers in international peer-reviewed journal and co-authored over 60 Arabic books in the food, nutrition, and public health. Dr. Al-Madani also served as a vice president of the Saudi Society for Food and Nutrition and Saudi Society for Environmental Sciences. Please join me in welcoming Dr. Khalid Madani.
بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. First of all, I would like to thank the organizing committee for giving me this opportunity and the شكر مبذول للمودريتور عند الحضور الكريم. This is the outline of my presentation. And about the sugar to be controlled in the body, in the blood, actually there is two important hormones to control the blood level within about 70 milligram deciliter to about 110 deciliter. These two hormones are insulin and glucagon. Both are secreted from the same area, but working actually opposite to each other. One increases the production of sugar, and the other one tries to make it enter to the body about the blood, the tissue, muscle tissue, and fat tissue. So the researchers were looking for any other hormone-like activity, which either mimic or antagonistic to the effect and production of both hormones. So they actually discovered about two hormones. One is called glucose-dependent insulinotropic polypeptide, which was isolated in the middle of 70 last century. And the second one is called glucagon-like activity, which is also discovered in about 1984. The first one, which we will abbreviate it about GIP, was isolated in once we eat in the gastrointestinal, actually in the upper part of the small intestinal, which is called duodenal and jejunal. And the other one, which abbreviated, which GLP, was secreted in the last part of the small intestinal, which ileum, and also another part in the rectum. As we can see from this slide, we will see that once we eat, there is a secretion of GLP from the part which I mentioned earlier. So they make a lot of action, which will and got very beneficial for the body. The first action has to do with the effect in the brain to make appetite, less appetite, and also effect for the stomach to make the food spend much more time, and about the pancreas increase the production of insulin and decrease the production of glucagon. So actually, it's not only that, they have a lot of activity regarding many parts or many organs in the body, about the brain and the pancreas, and also the heart, and also the liver, and finally the gut itself. So all these beneficial for the body make it more simple, as we can see from this slide. It has a lot of beneficial for the body. And when we compare it with the GIP, which is abbreviation, as I mentioned earlier, we found a lot of activity sharing the same activity, except about the glucagon. This one actually is increase the glucagon production and also increase the production of insulin. Despite their similarity between the GIP and the GLP, we found the GLP more concentrated in the pancreas activity, while the GIP more concentrated in the stomach activity. But actually, I mentioned a lot of beneficial effect to the body itself, but there is two problems facing these two hormones. First of all, is that half-life is very small, which we will talk about 2 minutes to about 7 minutes. That's the life cycle. Due to one enzyme is called DPP4, and this one deactivates the action of both hormones. That's one of the main problems. The other problem regarding these two hormones is the amount which is secreted is very tiny amount. So the researcher for the drug company will think about what do we make copy and paste from these two hormones and make it available as pharmacological action. So it has been approved by the FDA later on, and also by EMA in Europe, as drug can be used. So as we can see here, there is some drugs which are mimic the action of glucagon like the type, and there are so far 8 drugs. The first one is called Extenda, and this Extenda used only as glycemic control, and the first one is used only twice a day. But after in 2012, they discovered they extended release, making the action spend more time. So they can use it. The first one you have to use it twice a day, but the second one we can use it once a week. And in 2010, there is another drug that has been discovered, but this one also works with glycemic control. And in 2017, they add another benefit for the functional of these particular drugs. And this one can decrease the risk of cardiovascular disease. And later on, there is another one in 2014, and in 2000 المهم بعد كده they discovered in fact they add another function which has to do with cardiovascular disease prevention risk factor. Also later on in 2014 there is another drug also for glycemic control and also can be added another benefit which decrease the problem with cardiovascular disease. In Genomic is another drug also has been for glycemic control and has been used, and in 2020 they added another factor or another benefit which decrease the risk of cardiovascular disease. Here, this is the first one used as oral. All drugs of this particular hormone can be used only through injection, but this is the only one can be used as drug for glycemic control. And this one is used as to decrease the body weight. So they discovered it in 2021 recently, and also in later on they add another benefit which can be written in the benefit of the drug. What I mentioned earlier is only mimics the action of glucagon lipopeptide, but actually they can add the other hormone and make it synergistic effect both together. So there is two kinds of drug has been used. The first one for glycemic control, and the second one used for the decrease of body weight. Here is a to compare between two drugs. Actually, these drugs both are used only to forget, actually use it out of the label, which so they can use it for as for decrease the body weight. Here is a comparison only. So here is also to show the comparison between the three drugs which used for decrease the body weight. And here, what about the activity? Actually, they are very actually, the other one is used only for decrease of body weight because they fulfill the requirement for to be used as a drug for decrease the body weight. Here, what we so there is a lot of action besides the effect of the body weight and also effect on type 2 diabetes. What about the contraindication? They have a lot of beneficial, but actually there is a contraindication of using this medication. The first one, if they have hypersensitivity, in this case, we are not allowed to use this drug. Also, if the patients have gastroenterology or inflammation or all these cases, we cannot use it. For someone who has a problem with kidneys, they have to use it with caution. Also, when we talk about Extenda, which is the first drug has been used, this one affects the creatine or creatinine clearance. So in this case, we have to be careful while using this. We can't use it with someone who has a creatinine clearance less than 30. About extended release, which is long acting, also contraindication in case of he has the glomerular filtration rate is too low, which is reached about 45. For pregnancy, it's a contraindication. Actually, there is no data indicate there is a risk factor, but experiment on the animal study shows a lot of development abnormality for the fetus. When we talk about tryptoside, also they can cause pancreatitis. So if one has pancreatitis during taking the medication or have a history of pancreatitis, you're supposed not to use this medication. Also, for this group of medication, we can't use it if they have multiple endocrine neoplasma or thyroid cancer. So it's a contraindication to use it. Extended, also, we can't use it for warfarin. Warfarin is a drug used for as a to solve the blood clotting. So in this case, we are not allowed to use it because extended, the one has some effect of above the time for using, for causing the blood clot. Adverse reaction, of course, so nausea, vomiting, diarrhea, all this. Also, it does about the gastrointestinal effect, it does related. As increase the dose, it will increase the infection. Also, disease, infection, also increase the heart rate, itching, redness, side of the infection. For someone who is using anesthesia, it's also contraindication. It has some kind of adverse reaction because it may go the risk of expiration. And also, when we talk about adverse reaction, it may be cause risk review. It's a risk factor for pancreatitis, gastroenterology, and the other one. Also, it decreases the hypoglycemia. We already know that the GNP decreases the production of glucocorticoid. Precaution, we have to be careful. It's actually, this is not right for treatment. It's only to control and the management obesity or diabetes type 2. And also, we have to follow the doctor instruction for pregnant. If she decides to be pregnant, at least we'll give her 2 months ahead to stop taking this medication. And also there is drug interaction, so we have to be careful not to use it with any other drug, even prescribed or non-prescribed. Also, the diabetic patient have to follow precaution about when to take the medication, when to make the exercise, and when to eat. All these have to be counted with the medication and sport, and also with the doctor. When we talk about rebound, actually, we have to follow this drug with using resistant exercise before during taking the medication and after taking the medication, and you will see the effect of all this action regarding the mass, lean mass and fat mass, and also the body weight. Regarding the body weight, it will decrease the body weight by 17%. By 17% of the body weight will be decreasing within 70 weeks. But if you stop taking the medication, besides not making any exercise, about 60% will rebound. That's about the body weight, and here's the effect on the about the mass of the fat mass. And here كده خلصت صحبيت على شوية من الكتب. ده كان أول كتاب. ده 3 كتب. ده طلع في 2025. شكرا. جزاك الله.
Thank you very much for your patience to be with us until the last sessions. It is a pleasure to introduce Dr. Amna Yamani, Assistant Professor of Immunology at the Faculty of Applied Medical Sciences, Gallaudet University. She earned her PhD from the University of Michigan, and her research focused on allergy diagnostic and immunomechanism, with current work investigating oxidative stress in atopic dermatitis. Dr. Yamani is affiliated with both immunology unit at King Fahd Medical Research Centers and the Center of Innovative and Personalized Medicine, where she contributed to developing advanced diagnostic tools in immunology. Please join me in welcoming Dr. Amna Yamani.
Hello everyone, thank you for being here. Today I'm going to share with you some of my thoughts about advancing the allergy research in Saudi Arabia before I share some of the work I've done on allergy. But first of all, just so we could all know what is allergy, why, and how do we even have it. This is the shortest explanation. When susceptible people are exposed to allergen, this causes the epithelial cells to release alarmin. And this means that the dendritic cells is going to inhibit any regulatory response, and the immune system is going to shift to what we call the type 2 response. And it's characterized by these cytokines IL-4, 5, 4, 13, and it's going to end up with an IgE antibody, which is an allergen-specific one. Now, the problem with this type 2 antibody, with type 2 cytokine, is that it's going to affect tissue, and for example, it's going to activate eosinophil. And the IgE, the allergen-specific IgE, is going to stay for a long time, and it's going to bind to the basophil and mast cell, and as you saw before, mast cell contributes to harmful mediator that cause the clinical symptoms of allergy. Now, when I say clinical symptom, it does depend on the type of allergy the patient has, as we can see here. And the question here, how much allergy do we really have in Saudi Arabia? If we check the recent study, we find a similar percentage across subtypes of allergy, even if the participant and the population were different. For example, allergic rhinitis is 21%, asthma and food allergy is around 17%, atopic dermatitis is 13%. Now, if we put these percentages together, we could say that 18% of the Saudi population have allergy, which means 6 million. And to help you imagine what these numbers mean, that's everyone in the Western region, and even more than the whole population of Jeddah. Now, if someone is diagnosed with allergy, what happens next? Well, there is no cure, so the first thing we tell patients is they need to avoid the allergen, just avoid the trigger, which might look like regular washing of fabric, staying away from any fragrance, and use a nasal wash. We do have medications for allergy, but these are just to control the symptoms. And finally, there is a huge success with immunotherapy, where we give the patient small doses of the allergen until they could tolerate it. But this is what we always miss in the allergy field. That's the hidden cost and the hidden cost of these management strategies. And let me give you some of the examples. Just checking the market size for the hypoallergenic skin product globally last year, that was $44 billion. And for medication, just one medication, antihistamine, I'm sure everyone heard about Claritin. Their market size is $3.7 billion. And finally, the nasal spray, whether it's antihistamine, steroid, or even sea salt water, their market size is $29 billion. So now I could ask the question, does the allergy field or allergy study really fit in our future, or would it benefit the 2030 vision? So we have the first part of it as having a vibrant sector, And I'm sure having 18% of us itching or sneezing is not the best quality of life. But let's consider other parts beside the healthcare system. If we want to serve the Umrah visitor or any tourism industry, we do need to accommodate the need of all individuals, including the one with allergy. And for our economy, I showed you the size of the allergy market, but just in case you're not convinced, let's do some simple calculation. If you consider we have 6 million Saudi with allergy, and they spend at least 200 riyal on either medication or any product that helps them avoid an allergy, that's 120 billion riyal. So before I start any research in Saudi Arabia, I was questioning and I wanted to know what is the landscape of allergy research in here. So I checked with PubMed, the research article authored by Saudi affiliated authors, and I checked from 2017 to 2022, and this is where I saw. There was a total of 421 publications with a significant growth rate, but it was low per year. Next, I wanted to check what are the subtype allergies that being studied, and I saw that 50% of these publications were about asthma, maybe because it required more care, while other allergies such as drug, food, and needle allergy have from 7 to 8%. Even though it showed you before that subtypes of allergy have similar prevalence. I next checked the type of the research design because it tells you a lot about the research, and I found that observational studies such as cross-sectional and case control, these are 25 to 16% of our publication, and case control experiment were around 20%. But I want to draw your attention to the clinical trial and case study. We see they were low, maybe 10 around the period I checked. And I think with all the biotechnology we're developing here in Saudi Arabia, we have more chances for clinical trials or even case studies. So since cross-section were the most common one, I checked the type of method these papers used, and I found that most of them used questionnaire. Medical record was low, so that's an area of improvement. That would draw my attention here, what I want you to realize is that there was no national database or even Middle Eastern database for any allergies information, which tells me that that's a missing area we need to work on. So the conclusion of the first part of this my presentation, and hopefully I showed you that allergy conditions in Saudi Arabia are diverse, and there's a significant part of the population with allergy. The allergies sector have a significant economic impact, whether it's on the healthcare or in the consumer product industry. And finally, with the allergy, the Saudi allergy research, we have significant growth, but we need to consider the diversity of the allergies and the interdisciplinary nature of this disease. Now I'm going to switch gears to a little bit of the work that I've done in food allergy. As I showed you before, when someone who's allergic exposed to their allergen, various system could be affected. And if we have these three systems, that's what we would say a severe reaction, or maybe you heard the term anaphylactic shock. Now, what we don't know is the molecular process behind these reactions, or why do some people even have these severe reactions while others have mild ones. But we know a little about the physiological process of anaphylaxis. We know that we have 6 liters of the blood running in our vasculature to provide oxygen and nutrients in the blood, looking like this. But when we have mast cells being activated, it could dilate the blood vessels or even make the vessels leaky, so fluid will leave the blood. Now, if we lose 15 to 30% of our blood volume, that's what we say a hypovolemic shock, which is traumatic. So the heart and the lung try to compensate by increasing their rate, but this could their collapse. So this makes us questioning what is the role of vascular leakage in enhancing anaphylactic shock. And our aim was to identify the molecular pathway that modulates the severity of food-induced anaphylaxis. We started with interleukin-4 because it's one of the most important type of cytokines in type 2 allergy. And we use mice model where we hit them with the histamine, and mice usually lose temperature when they're allergic. We also check the hematocrit to examine fluid extravasation. And what we see here in blue that when we inject mice with the histamine, they lose temperature, their hematocrit increase. But most importantly, when we brine the mice with interleukin 4, now we have more shock, more hematocrit that correlate positively with the reaction severity. So this was a systemic administration of IL-4. So we used the knockout mice to directly see if the IL-4 is affecting vascular endothelial cells. And we've done this by using the DE coherent. So we here see that blue and green mean the endothelial cell express IL-4, and we see that the knockout mice, they don't express interleukin 4 receptor alpha in the vascular endothelium, but they express it other way. A second model we used is a transgenic mice where when we inject oral, give them allergen orally, we see that mice lose temperature and increase hematocrit. This is enhanced by IL-4. But if we only took the IL-4 receptor from the vascular endothelial cells, we could prevent the enhancement, which shows that the IL-4 enhancement really depends on the vascular endothelial cells. So next we move into signaling pathways. We're moving to in vitro model where we grow the vascular endothelial cells in a monolayer, we hit them with the current, and we measure the resistance. And this tells us about their vascular endothelial dysfunction or the permeability. We see that histamine will decrease the resistance, so it's going to make the membrane the barrier leaky, and IL-4 is going to enhance it and even extend this barrier dysfunction. And this is the calculated resistance change under statistical analysis. So since I'm going to talk about how histamine-induced endothelial barrier dysfunction, I want to show you how we know from the literature that histamine induces the signaling pathway to cause barrier function, which is controlled by the adhesion molecule or junction molecule in blue, because they're connected to the cytoskeleton cell system, and this is how endothelial cells make a whole barrier. And when we have histamine, it's going to target the junctional molecules. I'm going to focus next on the junctional molecules. We see here if we grow vascular endothelial cells on a monolayer and we image vascular endothelial coherent, as you can see in red, and the mucus is in blue. We see that histamine does affect the localization of the coherent, but importantly, when you pre-treat the cells with IL-4 and hit them with histamine, now the effect is even stronger. And this is consistent with what we see when we draw Western blot, whether it's with BE coherent or another junctional protein, the ZO1. So we can see that when we pre-treat with IL-4 and then hit the cells with histamine, we see less of the ZO1. So next we wanted to understand more about this pathway and about the gene transcription. So we did some RNA-seq, but I want to focus on the transcription factor analysis that we did in silico. And we see that many of the genes have STAT3 and STAT6 promoter, which makes sense because the IL-4 receptor, the IL-4 signals through these STAT and vascular endothelial cells. So we checked, started with STAT3, we checked the phosphorylation, and to make this short, we see that histamine does phosphorylate mainly on the serine residue of STAT3, and this is enhanced and extended when we pre-treat with IL-4. But the functional data show another pattern. We knock out STAT3, as you can see here in these cells, and we did the functional analysis, the resistance and variability, and we see no difference whether we in the wild type or the knockout cells. So this is tells us that this pathway could happen without STAT3. Next, we check STAT6 because I showed you it. We care about STAT3 and 6. So with STAT6, we IL-4 was phosphorylated as expected. Histamine did nothing. Then when we retreat with IL-4 comes back with the histamine, we see phosphorylation. Moving to the functional analysis, now we see a difference. We see, black and green, there is no difference because this is the histamine-induced vascular permeability. But with the IL-4 enhancement, it's gone if we remove STAT6. So this tells that this pathway needs STAT6 but not STAT3. Okay, so that's the question we asked in this project. What are the molecular processes that moderate the severity of food allergic reaction? And this is what I've shown you on the summary. I've shown you that visceral leakage does affect the severity of anaphylactic shock, and that alcohol and histamine synergize together to have a stronger visceral leakage. Now, they could phosphorylate STAT3, but this process actually requires STAT6 to do some gene dysregulation to enhance visceral leakage. Thank you for listening and for being here.
Thank you, Dr. Thank you, Dr. Amna. Now we have session for the discussion. Please, all speaker, can you appear in this theater? Dr. Michelle, Dr. Khalid. Dr. Peter. Okay. Any question?
I have a question for Dr. Dr. Anna, thank you so much for your presentation. It's very informative. I'd like to know from the beginning, why did you talk about or thought about IL-4 rather than IL-5, which is, it's a growth factor for promoting eosinophil. And eosinophil is the very first thing that usually gets upregulated for people with allergy. Is it because it's already known, or what made you think from the beginning about IL-4 rather than IL-5 mediated eosinophil?
Well, that's a great question. Eosinophil is more common or more important in respiratory distress and allergy like asthma. While we thought about IL-4 because we're thinking about food allergy. And eosinophil is not very important for food allergy. And so that's why we focus on interleukin-4.
Actually, interleukin 33 is the recently discovered cytokine, which is IL-1 family of cytokine, actually acts through IL-4. So it trigger IL-4, then IL-5, IL-30, and because we tested in the IL-4 knockout mice 10 years back in Glasgow, we published in Allergy journal. So IL-4 is the key for inducing allergy in asthma. This is our finding. Compared to IL-4, IL-5 and IL-30. So all are Th2 cytokines. So IL-4 is very important in terms of allergy.
Thank you very much for your thoughts. I have two questions, one for Dr. Peter and one for Dr. Khalid. Dr. Peter, since you're speaking of the inflammation and how that would end up with a very adverse effect, is there a specific chronic, a specific biomarker that tells me this situation is a chronic inflammation or it's acute inflammation?
Actually, because we are looking into inflammation in the acute phase. In the chronic phase, actually the signature changes. In our case, we find the GM-CSF is higher. Then IL-10, then IL-13 also up in the prolonged phase. So by seeing the signature, you can say that it is in the chronic phase. Also other markers are also there. It's not only the cytokine, chemokine, growth factors. You can also look at other factors. There are multiple factors which can play a role in both acute and chronic inflammation. So in our model, we are looking only the cytokines, chemokines, and growth factors. In the future, we are going to expand the panel so that we can differentiate the acute and chronic phase. It depends on the model also, what kind of model we use, what kind of trigger and the duration matters.
Thank you very much.
For example, also, like you see the mastocytosis, in which the mast cells are produced in large numbers. Okay, then the markers vary. You need to look into the mutation also. For example, you need to see the mutation in the c-KIT. c-KIT is a receptor for stem cell factor, and the mutation in one of the gene, this gene, c-KIT gene, the exon 70 in the position 816, the aspartic acid is converted to valine, and it will cause the continuous production of cytokine and chemokines in the mast cells. And mast cells also expand in huge numbers. So the mutational status of these cells also matters, along with other factors. There are many factors play a role. And the treatment for this is very different on the mutations.
Okay, thank you very much. Dr. Khalid, just one more question. Speaking of the GLP, so many people they using now the Ozempic, and my question is at the mechanism level. Do you think the long using of this kind of drug is actually mimicking the internal GLP? If somebody stop using it, that would affect the normal production of the internal GLP?
Actually, the production is very tiny amount. So even if it's effect, so the effect will be minor. Because as I mentioned, the quantity was created is very tiny amount, and also there is one enzyme which break it down. So deactivating the production of this local hormone.
Can I ask Dr. Anna, what kind of database should we refer regarding the allergic cases at the national level?
Well, great question. I think just having information about the type of allergen everyone is allergic to would be useful, because this will help us know the exact cause of allergy, and we could direct immunotherapy research or even the product market into that specific allergen. Okay. I have. Okay.
Assalamu alaikum. Thanks to all speakers. You have added a lot to our knowledge. Dr. Hisham, excuse my ignorance, but how can we explain the effect of a mutation in uncoding region that we study? The uncoding region, it's not affecting the expression of protein.
Like I said before, we thought it's not a coding region. So I think after this mutation, and there's like some studies on animals model, in this kind of mutation, CTLA4, the mutation in the third prime could affect the stability of the RNA. And maybe because also we have proved that the expression of the protein is also less in these patients. We did segregation in the family, and there's another 15, 16 patients in Saudi Arabia having the same mutation from the same family or tribes consanguinity. They have the same mutation. So we think this is really causing the disease, maybe because of the RNA instability. In this kind of gene or CTLA4, I think, yeah, it's coding, but maybe in other genes where the third prime could be uncoding. We don't know exactly. I can comment to that question about chronic and acute inflammation. This is really good questions, and we call it in the practice window of opportunity. If we can treat the patient in the acute phase, then maybe we will. If we treat him in the chronic phase, then maybe we'll progress disease. Nobody knows exactly the biomarkers until now, and it depends on the mutation, like he mentioned, and the disease and the pathophysiology. It's great biomarkers will be if we can find it.
Okay, I have one question, please, to Dr. Peter. In your model, you use the mast cells as a producer for pro-inflammatory cytokines, and as you said, it takes about 8 weeks to be differentiated from the cold blood. So, yeah, so it takes a long time. How about using other immune cells, such as the T cells, for example, especially T helper 2, which is known for the effect on the chronic inflammation of pro-inflammatory cytokines? How about using other models, because it can be differentiated using dendritic cells in a few 7 days, for example. So
yeah, I completely agree with you. Now we started with the mast cells. Probably in the future we need to move towards the T cell model. This is the model we are developing the last 5-6 years actually. This is the work from 5 to 7 years.
Okay, and what about the technique you use? An instrument can be customized to different type of cytokines to be measured
Exactly,
in any type of immune cells?
Yes, because the cytokines you can either get it from the company as a panel. In our machine, you can use up to 50 analytes.
Okay.
If you know the analytes, you can customize the panel also from the company.
And it's measured protein level only.
Only protein level. But in the machines, we can also use for the nucleic acid quantification, like you can mutation, SNPs, expression. You can do that. We didn't do it so far actually. We never tried it here. So you can use for both. It's not only for protein, for nucleic acid also. So
okay, last questions for Dr. Nashawi. Sorry, I know the time. Dr. Nashawi, when I saw the first case you put on the screen, it was for psoriatic patient and kids. So I wonder which physician that we took a child to see with the auto-inflammatory disease. It's such confusing. Is it dermatologist, pediatric, rheumatologist? Who?
I think this question we face always in all conferences and with other colleagues. It's multidisciplinary. It should be multidisciplinary, and all the stakeholders should take a role in these patients. Like the first patient, I think the dermatology at the beginning they're the most important. Then at the end, maybe the genetics or the labs, but the in cases. So all the people.
So the beginning is an image. You cannot find it. You cannot imagine the end of this. It is end by
immune dysregulation.
Immune dysregulation.
So maybe awareness for other colleagues and think of other or immune dysregulation if you have multi-system clinical phenotype.
Okay, thank you.
Can I ask a question for Dr. Khalid? Regarding the vaccine, what's the weight, those percentage for the drug during the trials that authorities such as FDA will approve as a weight loss drug? Regarding the vaccine, what is the weight loss percentage for the drug during the trials that authorities such as FDA will approve as a weight loss drug?
Actually, it's a very good question. For any drugs to be used and to be approved by FDA Saudi or FDA in America, there is 4 steps. First steps, we have to be sure about the safety of that drugs, first of all. The second step, we have to be sure about the efficacy of these drugs. So for the efficacy, it has to decrease at least 5% of the body weight comparing to the placebo within 1 year. If it's more, well and good. Other lower than this, it's not good. That's number 2. Number 3, they have to check about drug interaction, because we have 3 kinds of drug interaction. First of all, food drug interaction. Second, drug interaction. Third, drug alcoholic interaction. That's number 3. Number 4, they post-marketing and surveillance under the FDA if there is any communication from the public. So they report it and they will check the FDA. Because actually when they make any safety regarding the drug, they are not including everybody. Sometimes they forget about a specific disease, about a specific disorder, about a specific. So when we make the safety of the drug, after that they have to be post-marketing and surveillance from the FDA for any complaint from the public. Did I answer your question?
Yeah. But is there any general advice regarding such
drugs? About actually, these drugs has a lot of contraindication and a lot of side effects. It may cause some kind of cancer, especially thyroid. It also may kind of pancreatitis. A lot of side effects and a lot of contraindications. We have to be carefully when we use it. We have to be under the supervision of the doctor So he will take some sample from the blood and urine to check everything and the prognosis and the